Good morning, everyone.
Good morning.
You are welcome to today's session. We are some minutes late, but we shall quickly recap what we did yesterday, and then we'll start the session this morning. So we had a busy day yesterday, and we are glad that our colleagues online, you have joined us yet again this morning, and we hope to have another interesting day today. So the chair has not come, but I'll stand in. Otherwise, yesterday we had a number of sessions. We started with a keynote address on health professions education in the COVID-19 era, challenges and opportunities. And this was a session that took us through, I think, the various components that we are doing today. And what I learned is that we need commitment, we need strong leadership, and we need to use a business model to achieve this. We had another keynote, role of nursing education in strengthening the health system, a roundtable on interprofessional education. So we learned the importance of why we should deliberately plan the education and training of the different professionals together so that they can learn how to work together, learn about the different roles, so that when they finish, they continue. We're given a challenge of how to transform biomedical sciences education by doing integrated learning and teaching by all members. And this is for the future, and it's up to us to see how we can do that. So we had a number of presentations before going for lunch. We had a roundtable discussion on the role of regional networks in transforming HPE. Unfortunately, we cut that short. We don't know whether we'll be able to complete. And it's because we are trying to accommodate our guest of honor. So we had the official opening ceremony and a keynote address that crowned it all. And we're urged to write, is it a declaration? The people who were on, even online, Professor Sawankambo urged us to write, was it a declaration? Or a statement? So what was it, a statement or declaration? A declaration, a Kampala declaration on transformative, but it was on something one time, once in a lifetime opportunity. Oh, I thought you people can remember better than me. Now you pity the students. You pity the students. But my question was that, do we all agree that we write that statement that comes out of this? Yes, the people here are saying yes. The people online, do you agree that we should come up with that statement which urges increased funding for health or support? We'll get it, we'll get the words. So people online, there are already 16 people online, but do you support that we come up with a declaration so that we make a draft and somewhere in the afternoon we share and improve that as needed.
Yes, madam.
Even madam, thank you. Yes, I'm not madam. No, I'm madam, but please, I don't want to be called madam. I think no one ever calls me madam. It feels so formal. Formal. So what are you going to call me? Mm. How do I want to be called? Many people call me different things. Yes, madam. Many people call me my name, my first name. Okay, so I don't know if I've left out anything. I wanted to cut this session short. If there's anything that was covered that I've not, anyone either online or in this room can remind us. Faith, did we forget anything? Okay, Roy. Colleagues online? Okay, so we are ready for today, and it's going to be an interesting day. So I would like to request the Dean, Deputy Dean Busitema, supposed to lead us, but we have Dr. Rebecca Nekeka, who is going to chair the first session. Rebecca, you're welcome. I hope all the presenters are available for the session.
Thank you, Professor Chiguli. All protocol observed. Good morning, the colleagues here and the colleagues online. I hope you enjoyed yesterday. Personally, I enjoyed. It's something I've been looking forward to, a day when educators can sit together and we talk about the quality of our medical education. I think there was a lot to learn, just like Professor has summarized, and hopefully we are not going to leave the content here. We are going to move it down to our institutions. Yes, so I'm standing in for the Deputy Dean, and straight away, our time is already fast spent. We are going to the first set of presentations, and the theme for this session is nursing education. Personally, very passionate about nursing education. Each time I meet nursing students, I've always had a bit of motivational talk with them. And just like we're talking about interprofessional education, I've kept challenging the nurses in my institution that we need to catch up. You know, it's easy to talk when you're somehow at the same level as well. So we need to see nurses going higher, getting masters and PhDs. It's actually easier for us to interact. We shouldn't leave them behind. Yeah, it's very hard when you have senior surgeons, senior people, and then you have nurses on the ward who have stopped at diploma, and some have not, you know, in that there's just that gap that we also need to look at and close as we support nursing education. And it is possible. It's possible to have our wards run by nurses who are holding masters. And when the students see this, that you can have a master's and go to the ward, then they will be interested. Yeah, so let's move on to the first presenter. Our first presenter is online, and she's going to be talking about incorporating spiritual care in the training of healthcare professionals. That is Dina Chelengat. Dina, are you on?
Yes, I am on. Let me try and share, and if there is a problem, I would request to be assisted if I can't be able to share, but I am ready.
But,
It seems taking a little bit of my time. Can I be assisted from the other end to share the slides as I talk?
yes, Edward is sharing. Okay, just you can start.
Okay,
There you go.
thank
You're
you very
welcome.
much for accepting my request to be the first one to go. My name is Dr. Dina Chelagat. I'm the Dean of the Moi University School of Nursing and Midwifery. I have been in the university for the last 27 years, so I have interacted and participated in the training of students for quite some time. I am also a trained pastor, and so spiritual issues are part and parcel of who I am, and much more interested in incorporating the two together. I really appreciate the opportunity to present, and I'm not yet seeing the slides. I don't know. Are they on?
Yes.
Secretariat? Okay. I'm not seeing, but that's fine. So my presentation is on incorporating spiritual care to the training of healthcare professionals. So I start with a question. What is spiritual care? So spiritual care sometimes is people tend to mix or think spiritual care and religion are the same, but they are not. Because of time, I'm not going to go into details. They may be related in one way or another, but they are not one and the same thing. So spiritual care is that type of care that responds or recognizes and responds to the needs of the human spirit when faced with trauma, ill health, or sadness. It is that care that requires encouragement and presence by those who are providing care. I think in Kenya, and I believe the same everywhere, sometimes patients talk that when you get into a doctor's room, before even you say what your problem is, they are writing a prescription because they want to get rid of the queue, or even a nurse coming to provide care. They are so much in a hurry, they don't take time to listen to you. So this spiritual care is about showing kindness, concern, and cheerfulness when you are offering care to the patient. It is the type of care that allows the patient to discuss their anxieties and fears. And nobody will be able to discuss their anxiety or fears if you are not ready to listen. So, what is very key in spiritual care is the ability to listen. Why train healthcare professionals on the provision of spiritual care? Most patients and their relatives are spiritual and they demand spiritual care. Our research has shown that many patients have indicated that religious or spiritual beliefs influence their medical decisions, especially when they are having serious illnesses. They decide to take certain medications or not based on their spiritual affiliation or the way the state of their spiritual wellness is. Most patients and their relatives have requested that. Spirituality and religion, I said sometimes they overlap, and medicine and health have been related in one way or another for many years in most populations. Religious institutions were responsible for licensing physicians to practice in the past. I don't know about Uganda, Malawi, and the other countries, but in Kenya, we have a lot of hospitals which were put up by spiritual institutions, and they are still running today. What are the benefits of spiritual care? When we offer spiritual care to patients, what are some of the benefits? It helps people make sense of their lives. It helps patients cope with their experiences and helps people find and maintain a sense of hope and inner harmony, peacefulness in the midst of health challenges. And I think we have seen a lot even at this time of COVID. There are a lot of mental distresses, but people who are spiritual tend to have a better coping mechanism because of having a relationship with a higher being. Next. Healthcare professional, I think, go back a bit, please. So I said helps people make sense and helps people to cope. And even when a patient is awaiting to die because maybe they are in the terminal stage, a number of them have very nice peace even as they go to prepare to go to the other world, because they have made peace with themselves, they have made peace with God, and they have made peace with their relatives. So that is one of the benefits of offering spiritual care to patients. Next. So what is the problem? Why am I talking about spiritual care this morning? It's because healthcare professionals do not provide spiritual care. We are very much in a hurry to finish our required activities. If it is clerking patients, if it is provision of care, we want to clear the tasks. We are not ready to listen. So the healthcare professionals do not provide spiritual care, and healthcare professionals cannot be blamed. They have not been trained to provide this spiritual care to patients. We learn a lot of anatomy, basic sciences, and many other things, but that spiritual care aspect in many of our curricula is missing. Next. So how can this problem be addressed? How can we address the problem that we have of not addressing spiritual care? So we need to incorporate spiritual care in the curricula of all healthcare professionals. Are you a physiotherapist? Are you a doctor? Are you a nurse? Are you a surgeon? We all need this spiritual care incorporated into our curriculum. And it can be done by either having it as part of what they learn, like in most of what I do personally, I incorporate when I'm dealing with palliative care, that spiritual component, I bring it there. But it can be, I think it is upon each institution to see where it can fit into the curriculum. And for those who are already in service, who did not train on spiritual care, we can provide a standalone training on provision of spiritual care, and this can be done like a week or a day, every day in a number of weeks, per day a week, or have a full week, depending on what works in every institution. Thank you. Let's move. So in conclusion, it was a very short one. Spiritual care is a key component of patient care. If we have to provide holistic care to our patients, we need to incorporate the spiritual care. So there is need to develop strategies of incorporating spiritual care in the training of healthcare professionals. We are not saying we are making healthcare professionals to be pastors, but we want them to be able to assess the spiritual crisis of a patient and be able to refer. And if one is already trained, they can be able to provide. And therefore, I really strongly believe this is an area that we need to think about how best to incorporate. I know our curriculum is so condensed, it has a lot, it is congested, but this is a key aspect that needs to be undertaken and incorporated into the training. Yes, next. So those are the references. I have a lot of references, about 3 of them. And thank you very much. That was a brief but very important aspect of patient care that I believe we need to incorporate. I
Thank you.
am very grateful. Thank you.
Thank you, Dina, for that wonderful presentation. Is it okay to take your questions now, since you wanted to go for another meeting?
Yes, I would appreciate that.
Okay, so let's have a few questions for Dina, and then we can allow her join another meeting. Okay. Cloud.
Thank you very much for the presentation. I'm Claude Shirumuzia. I have issues with the spiritual care we are talking about. We have experience with different religious denominations, sects, some even contravening medical principles of medical practice. Now, if we are talking about spiritual care, considering the religious diversity, the different doctrines being followed, without a framework that is universal for all the institutions, how are we going to introduce this? Because some religions you'll find they don't agree with others, and what we are calling spiritual might be looked at by some religions as not being as such. So how do we go about it when we don't have a framework to handle that, the religious diversity? Thank you.
Yes, Professor.
Can I answer
Dina,
that?
maybe, Dina, can you take 2 or
Let's
3?
take 2 or 3 questions, and then you answer.
Thank you, Dina, for that eye-opening presentation. There is a question in the chat room. What's the difference between spiritual care and psychosocial therapy or psychosocial support? So that is one question in the chat.
There is a third one here.
But I also have another one before the third one. You know, what you're talking about is extremely important. And if any of us have been very sick or we've had very sick patients, many of us become strong because of that spiritual support. And I believe that, now let me stand, every patient believes something. And I think we can train our students to support without them going into the details of giving it. If I were to support, I may not support a Muslim patient, but I can support them to have that spiritual care they need. And you said it's not religion or whatever people believe in, without necessarily being the one to offer it, but understanding that it is part of the process for healing. And then how do we support? I think that is important. And I'll give a personal testimony about this. Yes, I had someone seriously sick, but by the way, 2 people. And as we are there, not knowing what to do, then of course the hospital doesn't care, the hospitals don't care. In one hospital, we decided that we needed this and we quickly mobilized. And when people came and prayed with us, that it gives you what you said, the calmness or the support to cope, and it helps. In another hospital, they have these different domains and they ask you, do you believe in this? What do you believe in? And how can we support? Can we call a pastor, a reverend? And when this person comes, supports you. And I remember this white lady, American, a priest said, can we pray? Can you pray in your own language? Okay, so I think we may not know how to do it, but it's something that we can actually put in our training, but also we can work with others. There are people who are trained to give it, and we can work with all denominations, so long as they are not treating our patients, but we can work, even those who don't believe in what we believe in something. Thank you.
Thank you. The last question.
Thank you, Mwambaka Bill. In your presentation, your description of spiritual care, you seemed to cross over to what to me sounds like psychological care. So I'm finding a hard time to draw a distinction between what you're describing as spiritual care and psychological care. So my question is spiritual care restricted to deity and the afterlife, that sort of conversation, or it incorporates the other components of, for example, psychological care? Thank you.
Thank you. Dina, you can go ahead and address those questions.
Okay. Thank you very much for the questions. That makes me happy that people are listening to my presentation. I think to be able to elaborate a bit, let me have a little bit of what I had left because of time, to be able to bring in the difference between religion and spirituality, because somebody talked about there are so many religions, and how will we be able to have a framework? In religion, we are talking about beliefs, practices, rituals, which are related to the divine or the sacred. But when we talk about spirituality, it is a very hard word, and it is elusive. It is like the wind. You may not be able to see the wind, but you will see the effects of the wind. So let me elaborate a bit. When we come to religion, it is community focused, it is observable, measurable, it is objective, those things that people do. It is formal, it is organized, behavior oriented, outward practices, and that's what people see. But when we go to spirituality, it is individualistic. So in spiritual care, we are dealing with an individual patient. A patient could be a Muslim, another one could be an Hindu, another one could be a Christian. So you will be able to deal with an individual, and there is a way of assessing that patient. And one of the ways, you ask the patient, do you consider yourself spiritual? We are not saying religious. Do you consider yourself spiritual? Do you have spiritual beliefs that help you to cope when you are in stress? And if the patient responds no, the physician might ask, what gives you meaning? What gives you a meaning in your life? So it's not about religion. So we are not going to develop a framework of addressing the religious diversities, but spirituality is individual. It is about a relationship. And I said it is inward. It is what does this person believe, and what guides him in his life? What calms this person in times of stress? And in that assessment, we ask clients, what is important to you when you are going through such? Do you have a community of people who assist you cope? So really, I'm saying we cannot develop a framework of a religious activity in the hospital, but we can say the key thing in spiritual care is to be able to listen to that patient, listen to what is going on, and then if they need to be assisted, as Prof had said, then we can refer. In our hospital here, our major hospital in Eldoret, we are training chaplains, and it is integrated. We have Seventh-day Adventists, we have Muslims, we have Christians, because we are not dealing with religion. We are dealing with that connectedness, how this person connects with the divine, how will this person cope? And therefore, we cannot really say we develop a framework of a religion. Another question about whether psychotherapy and spirituality are connected. They have a lot in common. They may not be exactly one and the same thing, but they have a lot in common because spirituality is about relationship. And in psychotherapy, there is a lot about relationship that goes on there between the client and the person giving therapy. And therefore, there is a lot that is related. And it is very hard to finish this in a very short moment as it is, but it is something that if we agree in totality that we need to listen to our patients, we need to know what is stressing them. We need to ask them what will assist them cope in the situation they are in. If they need us to call a priest for them, we will do so. If they need us to get an imam, we will do so. We also have what we call spiritual resources that we need to put in our hospitals, which are Bibles, Qurans, some music, what will help these patients cope. If we embrace spirituality, it means there is much more than just talking. We also need to have the spiritual resources that will help our patients cope. But the central part for us is to be able to listen to that patient and attentively listen, where the patient will see somebody cares about me. Somebody wants to know what is going on in my life. There are a lot of challenges that come with that. I know in Kenya and maybe the same in Uganda, we have shortage of staff. And that is why we should also train chaplains who can be able to assist so that they can support the patients when we cannot.
Thank you, Dr. Dina. Thank you so much for the wonderful presentation on spiritual care. And it's full, I think the audience is something that we need to consider as we train our students, because all of us are spiritual in one way or the other. Yes, so Dr. Dina, thank you so much, and we wish you a nice day as you join your next meeting. At this point, I want us to welcome Mitindwe Francine, who is going to talk about awareness and perceptions with regards to evidence-based practice among nurses and midwives in Mulago and Kawempe National Referral Hospital, Uganda. You're welcome.
Good morning, everyone. I'm Francine Mnitende. I'm here to present my study, which is titled Awareness and Perceptions with regards to evidence-based practice among nurses and midwives in Murago and Kawempe National Referral Hospitals. So this was my study, which led me to award of a bachelor degree in nursing. So this is our presentation outline. We shall go through this. And from the background, we can see little information about this study. There has been increased call on evidence-based practice in nursing and midwifery. And this call was mainly due to high demand of nurses and midwives to increase the quality of patient care and their outcome. So awareness and perception of nurses and midwives regarding this may be one of the influence for their adoption of evidence-based practice in their practice, yet the little is still known in our settings of Uganda. On that picture, that was actually me when I got an inspiration of doing this study. I was in my community-based nursing where nurses and midwives delivered a mother by using the traditional method of delivering, where they applied a lot of fundal pressure. By the end, a woman developed a serious PPH, which we had just resuscitated. So from that time, I thought, if we are learning evidence-based practice in class, and I still see this happening on ward, are nurses aware of EBP or there's something missing? So that's why I gained an interest of doing so, to get the awareness and their perception regarding evidence-based practice. So this study, it will be beneficial to many people in different ways. Like, many stakeholders may utilize the study findings to make many informed decisions. And again, it will also contribute to existing literature, since we still have a gap regarding EBP in our settings. Our major objective was to assess nurses and midwives' awareness and perception regarding EBP, and these other ones were the specific objectives. The research questions were generated according to our research objectives, where we wanted to determine awareness and perception together with the factors associated with them. That is the conceptual framework. It is showing us the factors which could be associated with perceptions and awareness, where they were classified under individual and environmental factors. We shall see this in next slides. This was a cross-sectional study. The data were collected once in Mulago and Kawempe National Referral Hospital among nurses and midwives who are registered to practice from those places. We recruited 384 nurses and midwives following a consecutive sampling method. 384 questionnaires were distributed, and they were self-administered. Data were analyzed using HEPI-SHSSU version 26, and chi-square was performed to see the relationship between the variables. We ensured quality. We did a quality control by pretesting the questionnaire and checking the completeness after data correction. Of course, we did this after approval of IRB and administrative clearance from the hospital, and again having a consent from the participant before their participation. So these are the results. These are the participants' social demographic information, where the majority of our participants were female at 81%. And again, the nurses were many than the midwives, and most of them holding a diploma in nursing and midwifery. Very few had a bachelor, and again, many has a certificate. The median age of working experience was 8. So we had even those one who are less than that, and those who are even in 50-something years. We also asked them if they have gotten a chance of attending CPDs and CMEs. 70% has attended, and we were also interested to know if they have gone for professional advancement, and a 55% had done so. Since I was interested in evidence-based practice, I couldn't leave out the question of if they have had a specific training on EBP, where a very, very small percentage has had that training, only 5%. And that last question of learning resources, here I wanted to see if nurses and midwives get some resources to help them get informed about available evidence. And we can see that only 40% do get access on resources. So on average of 299 participants who responded, only 46.15 were aware of evidence-based practice. And they have heard about evidence-based practice, and they heard about it from many sources, where the most cited one was from CPD and CMEs, which we saw in the past that some percent have attended. Others had it from their school. Like even me, I had it from my school because it was part of my curriculum in 4th year. So you can see that if even some others had it from there. Then when they were asked about the sources of their current evidence, most of them are still relying their practice on personal experience. This is their perception. You can see that when they were asked if evidence-based practice is highly important, most of them agreed at 63%, and these other ones. So these were the factors. We found that awareness and perception was highly associated with education attained and professional advancement, together with access to learning resources. So in conclusion, 4 in 10 nurses and midwives are aware of evidence-based practice, and 9 in 10 nurses and midwives have positive perception regarding evidence-based practice, although only 6 out of 10 were practicing based on available evidence. The major factors, we saw them, and perception was only associated with CPD and CMA. According to the result, I recommended that the Ministry of Education and Learning Institution should include evidence-based practice in the curriculum of nurses and midwives. Again, the Ministry of Health and hospitals should give nurses and midwives learning opportunities and learning resources. Also, nurses and midwives should be encouraged to go for professional advancement. The last, nurses and midwives should be sensitized about evidence-based practice. So those were the limitations, where we used a self-administered, which reduced our response rate to 78.9. And again, since this study was conducted in national referral hospitals, which operates at high standard, it may limit us from generating these study findings. That is it. Thank you so much.
Thank you. Thank you so much, Mitinde. Thank you for the wonderful presentation. Edward, where are you? We are going to, you can first have your seat. We are going to have all the presentations and then we have the questions at once. So I want to welcome Dr. Patience Mwanguzi to make her presentation on evaluation of graduate nursing programs and integrative review. Patience, are you online?
Yes, I am.
Yeah, you're welcome. You have 10 minutes to take us through this presentation. You're welcome, Patience.
Thank you so much. So, good morning, everyone. I hope you can hear me. Can someone confirm that you can hear me, please?
Yes, we can hear you.
Okay, great. So the presentation is titled Evaluation of Graduate Nursing Programs and Integrative Review. My name is Patience Mwanguzi. but I did this work with colleagues, Scovia Mbalinda and Tom Gabriano, and we're all from the Department of Nursing in the College of Health Sciences at Makerere University. So program evaluation is a way to systematically and critically examine programs. When we say programs here, we are talking about graduate programs in this particular study, and we're looking at things like master's programs. So it's a way to systematically and examine and critically examine programs, to provide information to make better decisions regarding programmatic changes, and to assess or reassess the program initiatives and objectives. So when you set up a program, you have goals that you've set up, and so you want to keep evaluating to see whether you're actually meeting these goals. So evaluation can be summative or formative. So it can be done at the beginning, in the middle, or at the end of the program. And it's important to colleges and universities to ensure that the day-to-day practices are leading to the desired outcomes. So you want to check that what is happening day to day is leading to the goals that you set. So at Makerere University, we sought to review or evaluate our master's program. And we thought that in the spirit of best practice, just like Francine shared, that we'll look at the evidence to see what other people have done and come up with the best way that we can evaluate our program. So the aim of this review was to examine existing evidence to ascertain the current practice of evaluation of graduate nursing programs. Next slide. So we decided to use a model to do this evaluation. We chose one that is the SIP model. That's the context, input, process, and product. And for the context evaluation, you're looking to assess the needs or problems or assets. This is generally done at the beginning when you're maybe designing your curriculum. And that's when you do this evaluation because it's context. So you're talking to people out there to find out what are the needs of the program that you're going to put in place. Then input evaluation, here you're looking at alternative approaches, action plans, staffing plans, budgets, feasibility. So at this point, you're doing an evaluation to look at probably the more managerial part of your program. And then the process evaluation, you're assessing the implementation of plans that you put in place. So here you're looking at the gist of the matter, the day-to-day running of your program, how is it going on? And then product evaluation is typically at the end to look at the outcomes, the intended and unintended, and then short-term and long-term impact of the program that you've put in place. Next, please. So this was a review because we did not find clinical trials or very many quantitative research findings out there. We decided to do an integrative review to be able to look at different types of studies. So it was a mixed bag, qualitative, quantitative, mixed methods, whatever we found out there. So our search strategy, we looked at different databases like CINAHL, MBES, ProQuest, Scopus to find information that was published. Then we also looked at the reference lists of selected articles that were key. We looked at conference abstracts, we looked at grey literature and other studies that we could access, for example, from libraries. I present here a sample search query for CINAHL to show you some of the different ways that we entered our search terms to be able to get the information that we got. And we looked at the articles that had been published in the last 10 years, just to make sure that we were keeping up with current practice. And we focused on the articles that were in English. Next, please. So these were our findings. We started by finding 2,004 articles from all the databases that we searched, and about 8 articles from the additional records. And we removed duplicates and remained with 1,807. And then we reviewed 113 abstracts after removing those that were not in English, that were looking at undergraduate programs, that were looking at other graduate programs, which are not master's programs. So we removed 1,694. And then we reviewed 30 full text articles that met our eligibility criteria. And we removed, sorry, that should be 89. Those ones that were looking at meta evaluation. Then there were those that were just evaluating curricula, not programs. There are those that were evaluating courses, and then those that were developing evaluation instruments. So in the end, we remained with 11 studies. Next, please. So this is just a geographical setting of the 11 studies and where they are located. Sorry if it's not so clear, but it's just to show us how the work is spread out in terms of graduate nursing. And this might also be a reflection because of the amount of time that some of these people have had graduate nursing programs. So you see that the majority of the studies were in North America and in Europe. There was one in Africa, which was in Liberia. and one in Bangladesh. Next, please. So these are the sources of evaluation data. So you can see where those 11 studies got their information. That was from the nursing graduates or alumni, current nursing students, from nursing faculty, nursing student reports, nursing school leadership, nurses, and expert nurse leaders. If you look at this graph, the thing that, sorry, just go back to the previous slide. If you look at this graph, what comes out clearly is that all these 11 studies only got information from nursing profession. So all of them, all these evaluations that have been done, we've only been focusing on the nursing profession. So we've not got information from out there, only from nursing. Next, please. Okay, so this is just the outcome of the review. So we mapped the 11 studies onto the 4 domains of the SIP, that is the context evaluation, input, product, and process. So just to show you where the different 11 studies went, and you can see that most of them looked, they were doing curriculum development, they were assessing curriculum development, and then the others looking at the outcomes, that's the product evaluation, and some of them looked at the process. But there was none of the 11 studies that looked at the actual planning, which was the input evaluation. Next, please. Okay, so I'm just going to talk briefly about the studies. So one of them that was looking at curriculum development was looking at competencies for graduate nursing. They were trying to find what are the competencies that a graduate nurse should have. So they identified 31 and put them onto the 5 roles of a nurse: expert, innovator, researcher, educator, manager. And then another study was looking at past and the current situation of graduate nursing. They're trying to find out the time lapse between basic education and graduate education, and also the motivation for graduate school. Another study was characterizing the core learning outcomes, and another did a needs assessment for potential participants that intended to enroll in an MSN program. Those were the studies that looked at context evaluation. Next, please. Then the 2 that looked at process evaluation, at actual process day-to-day running. One of them was looking at the development and application of an evaluation framework. So they had just started a blended learning master's program. And so they were trying to monitor and see how they could do support for that program. And then another was looking at faculty's experiences. Again, this was an online learning environment. And so their concern was that the faculty were going to lose touch with their students because of this online learning environment. This study was done in 2009, but you can see that it's applicable now because of COVID. And the faculty reported that actually the online relationship was improved because they kept on responding to the students' formative feedback. So as the students kept on giving feedback, they kept on improving their relationship. So it wasn't as bad as they feared. Next slide, please. Next slide, please. Hello. Okay, thank you. So for product evaluation, one of them was looking at PBL, that's problem-based learning, and the meaning of education to current clinical practice. So the advanced nurse practitioners were concerned that with this PBL, they wouldn't get enough skills to be able to practice in the real world. But when they went out after graduation, they were surprised to find that actually the information that they received from PBL was enough for them to be able to practice at the level as those who had had the usual face-to-face, learning. Sorry, the slides are not clear. I can't really read what's on there, but I'll just try. I don't know if it's me. Okay, so another study evaluated a program in pediatric oncology nursing to determine the nurse's working situation after completion. So they wanted to know, after you completed the program, what happened? So 65% of the nurses who went to oncology wards reported that they changed tasks upon graduation, that they got tasks that were commensurate with the knowledge that they had received and the skills that they had. Whereas those who had gone to the general pediatric wards, they remained about, it's only 20% that changed tasks. The majority remained at the same level. And I think the nurses around also can, relate to that. Then another study looked at process and impact evaluation of a new program for nursing faculty in leadership and education. So the graduates in this program reported that when they finished this program, one of the things that they got was they were able to innovate and they gained initiative, and they also became more assertive. And then the last one, this was the one that was in Africa. They were looking at a nursing program in a resource limited setting. And so the graduates said that they were happy because this positively affected their work, gave them career advancement, and they got, into leadership. However, some of the deans reported that one or two of the graduates challenged authority upon completion. I don't know if it's because it's a cultural thing, but when you look at the study before, they say they became more assertive. So probably these ones also became more assertive, but then their supervisors took it as challenging their authority. Next slide. So in conclusion, as we saw before, we really encourage people who are going to do program evaluation in nursing to involve varied groups of stakeholders and industry partners, both internal and external to the nursing profession. If we are trying to promote interprofessional education, I think we work together, we learn together. It would also be important to evaluate our programs together, because that is when we'll be able to have proper synchronicity of our programs. And then also it's encouraged for people to utilize various methodological approaches to collect data, because we found almost all these studies just use two methods. They will either ask the students or the faculty, there were interviews and just looking at records, but there are various other ways that can be used to collect data, including some digital methods or online. And then for product evaluation, most of the studies collected data just a year after the people had graduated. So we encourage people to do it maybe 2 years, 3 years, 5 years later, to also be able to assess the longer term impact. And then future program evaluation research should also consider employing theoretical models, because none of these studies employed a model for their evaluation. So it's very hard to follow the process or to be able to utilize the process that they did to be able to do our evaluation. So it's important that people have models, because this helps the evaluation to be more systematic. And then future studies should report both the outcomes and the process of evaluation. So all these studies reported on the outcomes of the evaluation, but not on the process. So the process is just as important as the outcomes. And then finally, it's important for people who do program evaluation to report also what they aim to do with the findings, or if they have finished this evaluation, to tell us how they utilize the findings to improve graduate nursing programs. Because it's not enough to tell us what you found, but also tell us how you're going to use it, or how you used it and how it made the program better. Next slide. Yeah, so I just wish to acknowledge Makerere University College of Health Sciences and the University of Pennsylvania School of Nursing, where I was when I did this work, and the Fulbright program for the funding support. I thank you.
Thank you. Thank you, Patience. Thank you for that wonderful presentation. Please keep online. We are going to take questions after this very last presentation. Let me welcome Moses Wakida to present his presentation on lived experience of nurses using modern technology while caring for patients in Uganda Heart Institute. Is Moses around, or is he online? Okay, we don't have his presentation and he's not here. So that saves us some little time as well for more questions. So let's take a few questions. We have about 5 minutes, to get questions. We already dealt with the first presenter. We have had 2 more presentations. So let's get questions.
Yeah, thank you, moderator, for the opportunity. Yesterday, I personally missed the presentation on impact of mentorship program on medical students. And today I'm privileged to present that impact. And the impact is Francine Mitende. She was given to me about 5 years ago to be her mentor by the MasterCard Scholarship Program. And I liaised with a colleague in nursing, Elizabeth. And today we are very glad to see the person who came from the Republic of Rwanda, is it Francophone, to English, that learning process, and she has completed on record time. She was able to graduate. So from her presentation, I want also to say that the presence of students, supported students on the wards, can have an impact on patient quality of care. Thank you very much, Francine.
Thank you. We are proud of you, Francine. Any other question?
All right, thank you very much. I'm Asha Navili. My question also goes to Francisca. I think it is a comment, not a question. In her presentation, she mentioned something concerning evidence-based. And when we reached somewhere about the results, she gave results of which questionnaires were self-administered. So I wanted to be clarified whether if we are looking at evidence-based, we shouldn't include in things like observation, because this is an evidence, of which we expect that since it is an evidence, you have to be there and observe. But here I just had something concerning the questionnaires. I did not hear about the focused group discussions and observation. Thank you very much.
Okay, thank you very much. Thank you, Francine, and thank you, Dr. Mwanguzi. Maybe it's a comment or a question to Francine. The fact that the nurses had low knowledge and perception on evidence-based practice, and in the recommendations, yes, the training and all that. But I think one way nurses, especially in clinical care, can learn how to use evidence-based practice. And this assumes that even the other health workers, the doctors use it, is to be together on the bedside and also to deliberately practice evidence-based medicine when looking after patients. And it would be very important for teams to be there many times. That is a challenge to the educators and also the practitioners. The nurses are not felt on the ward rounds. And I don't know why, because I've been there for many years. And I know there's a time when we had ward rounds with teams. It has been declining in some disciplines. And if we are to go to improve our training, we need those teams of doctors, of nurses, of other people. We work together. And also probably we should start with that training as we were advised yesterday. Thank you.
Thank you, Prof. Just checking if there are any questions online. I think there are only compliments. Francine, you can go ahead and respond.
Thank you so much. I will start with the first question, asking that why didn't I include observation in my study and focus group discussion and others. So this study was done as part of my undergraduate program. So I couldn't combine all those, but I can still recommend it for future studies to go and do more about this. This was just like a highlight. We've seen the gap. I think for the future research, we can still go and do more. Then for the comment of the professor, yeah, that is like what is happening on ward. Like fellow nurses are rarely in ward round, and this is one of the opportunities they have where they can benefit from other health workers. So I think we should still also do campaigns and whatever to ensure that nurses and midwives regain that behavior of attending the ward rounds and the CMEs, because they are also helpful for their learning, especially for evidence-based practice. Thank you.
Thank you, Francine. I don't see any other question, and our time is.
Thank you. A small one for Dr. Mwanguzi. I don't know what you recommend. The process you used and what you saw about evaluating programs and what the practice is there a gap? Do we actually evaluate our programs before we design new ones? From the process you undertook, what can we learn from that process? Should we continue business as usual, or what is it that we are not doing that you recommend from your study to improve the programs that we have?
Okay, thank you so much, Prof, for that question. One of the things that I found was that we're actually not writing. So I don't know if people are actually evaluating their programs. If they are not putting it down. So we can't tell whether people are actually evaluating programs or not. That's one thing. Then the second thing is that, I'm sorry. The point has gone. Just apologies, just give me a minute. Oh, yes. So the other thing that I wanted to say was about, especially in Africa and in Uganda, the information that exists there is more Western. It's a more Western type of evaluation. So I don't know if we can come up with some tools or some concepts that can be utilized for evaluation of programs in our setting. I think that would be very important. And I hope that for the HEPI program, that's something that can come out, which is really key. But we are really not doing evaluation. I don't want to talk about the Makere situation. I don't know how other people are doing it, but there are many programs that are just going on and on and on. Once it's approved, people do a curriculum review and keep on going, but they are not doing the evaluation. So one of the key things that also came out, as I had said, was to be able to get feedback from many other stakeholders, not just the nursing professions. People need to talk to the doctors. They need to talk to employers. Employers are quite key. They need to talk to the government officials, people who make policies, people who, like the public service, who create these jobs for us, because some of the people won't know that we are out there and we won't be able to meet the needs of the community if we're not evaluating our programs. So it's quite important for us to seek information or get feedback from many other stakeholders to be able to adequately design and improve on the programs that we have designed. Thank you.
Thank you. Thank you, Patience. Thank you, everybody. Our time is up. I request to stop here. Thank you for the wonderful presentations on nursing education. It's a journey that we are starting, and hopefully we'll get where our colleagues in the other countries are regarding nursing education. Let me hand over to Professor Chigli for the next session of the roundtable discussion.
Okay, thank you. Thank you, Rebecca. You know, I learned from the people who go to church. These people, they will never get this thing to speak without without sanitizing. Okay, so let's do that, especially at this moment. And I hope they don't close us and they don't close our churches. So we'll have a roundtable discussion. In the next session is, the theme is the role of graduate education in strengthening the health system. What is the situation? What are the challenges? And what are the opportunities? And I have a panel to discuss this theme, and I'll invite the panel to come, the members of the panel to come forward. The first one, Dr. Kaima, is going to be represented by Dr. Lydia Nachiyingi. He's not able to be here. And I know that Lydia is supposed to be online. So Dr. Nachiyingi, are you online? Okay. We have Dr.
Yes, I'm online. Thank you.
Okay, thank you very much.
Online. Thank you.
So Lydia is a member of the College of Physicians, and she'll tell us more about herself. We have Dr. Patience Mwanguzi. the head Department of Nursing, Makerere University College of Health Sciences, and you heard from her in the last session, and she's online. We have Dr. Mike Kagawa. I've seen him. Mike, can you come forward? From the Association of Obstetricians and Gynecologists of Uganda. Dr. Ruth Namazi from the Uganda Pediatric Association. And we should have had a representative from the College of Surgeons, Dr. Jane Farah. Jane, are you online or in this room? Okay, she is not. I don't know if, okay. Since the surgeons we have here are not prepared, I don't know if the Dean KIU can come in to join this panel, Professor Sebufu. I saw him, did I? Yes, please come in. I know you always be prepared. And I'm Sarah Chiguli. So this panel is going to help us discuss and understand the role of graduate education in strengthening the health system, not only in Uganda, but in the region. And we have about 15 minutes to do this. And as a way of a preamble, graduate education has existed for many years. I think in Uganda from the 70s, we've had it. Some of the disciplines, mainly a master's training. And when I talk about East Africa, I start around that time because I know that even the people who were trained and went and did these masters, the MMeds in Kenya, Tanzania, were initially trained in Uganda. So I would put it around that time, probably in Southern Africa a bit longer, and in other regions much longer. And for a long time in Uganda, we've just had master's training. The Masters of Nursing is following, and masters in other areas, public health and all that. A lot of emphasis in the region or in Africa has been placed on, primary health care training, village health teams and all that, which I think is important because there has been a problem and there's still a problem, but we've not had a lot of specialty training. And yet probably we also have a gap in the health system in providing services required for some people who need that. So this panel is going to help us understand that. And I want us to focus on specialty and maybe masters, but mainly what we've not been having the specialty training. And what is the gap? Okay. And how does this gap of lack adequate or inadequate training in these areas affect the health system? And I'll start this by asking Dr. Lydia Nachinji online to try and answer those questions, and then the others can follow, and then we'll have some follow-up questions. So what is the gap, and how does this gap affect the health system? So Dr. Lydia.
All right. Good morning, everyone, colleagues. Sorry, I couldn't be present in person. You can actually tell from the sound of my voice. I'm sorry about that. You know what is happening in Uganda. That's why I'm here in my room, but trying to join in with the to listen to the important discussion. So colleagues, my name is Lydia Nachinji, and I'm the country representative on the EXACO Council for these 5 years. and I'm also in charge of accrediting training sites through EXACOP. And like Professor Chigoli said, I'm standing in for our registrar on EXACOP, that is Dr. Kaima. So EXACOP basically is the East Central and Southern African College of Physicians, and it's a collegiate form of training that was formed mainly to address issues that have been faced by physicians for years. And back to what Professor Chiguli has put up, what are some of these issues what are some of these problems that have been seen? And these problems actually cut across not only to physicians, but also to surgeons. And they're not only in Uganda, but regionally. And that's why EXACOP has involved regions, countries in this region. That is, we have over 6 countries. That is Tanzania, Kenya, Uganda, Zimbabwe, Zambia, and Malawi. So we realize that these problems actually cut across the region. So one of the key problems that we face as physicians is the low access to well-trained physicians. You'll agree with me that given the large population of people, we have over 200 million people in this region, and there are only less than 1,000 physicians to cover this population. And we can only afford to cover this region in terms of physicians by providing more graduate training. And the other issue is you realize that although we need physicians, there are not adequate postgraduate training posts. Currently, there are only 30 universities across the region of EXACOP, and these universities are only able to graduate less than 100 physicians per year. And if we are to go by this rate, it would require over 100 years to achieve the desired specialists to cover this population. So the issue of limited access to well-trained physicians was one of the calls for EXACOP kind of training. And then the other issue that we thought EXACOP would address was the differing standards of postgraduate training, and thus the different qualities of physicians in the region. You realize that all universities are following different curricula. They have different methods of implementation. They have different periods of training. And thus, this means that you're going to have different qualities of physicians. And could this be the reason why, if you completed training, say from Makerere University, and you would wish to work in a country like Malawi, you will have to be subjected to another exam in order for them to confirm that you actually are the standard they require. So having regional training through EXACOP would help to curb some of these problems whereby we have different qualities of physicians. And of course, the other key issue that would need to be addressed through graduate training is the rising number of disease burden. Gone are the days where infectious diseases was the main thing, especially in these underdeveloped countries. Now we have the emergency of non-communicable diseases and other diseases that will need to be addressed, not only by clinicians, but specialists who are trained to handle these diseases. So there is a need for these graduate trainees, graduate trainees and physicians to cover these emerging diseases that are on the rise. And of course, this is with everyone. You realize that there is an imbalance in the distribution of physicians between the rural and urban settings. Look at the graduate students that have come out. How many of these have actually gone back up country to work? Most of the physicians who qualify will stay within Kampala. And because of that, many of our populations in the outskirts, in the rural areas, do not get what a proper, care by a physician will have because of that lack. So basically, those are some of the issues that we thought that EXACOP would actually address, and that's the formulation of EXACOP. Thank you. Back to you, Chair.
Okay, thank you. We'll have another round of questions where how you explain how that training will address the gap in the health system. So now I'll go to Dr. Ruth Namazi. What is the gap in graduate training in your area, and how does this gap affect the health system? Before you tell us what has been done.
Thank you, Professor. My name is Ruth Namazi. I am a pediatrician and also a lecturer at the Department of Pediatrics and Child Health, Makerere University. So what's the gap? For pediatrics, we know that a lot of steps have been made to reduce infant mortality and child mortality, but there remains a big gap in the number of specialists that are available to take care of these children. For example, in Uganda, less than 50 specialists graduate every year in pediatrics. Given the high number of children that are born every year, that is a very low doctor to patient ratio. So that's one of the gaps, that we actually have very low number of specialists to take care of children in pediatrics. The second thing that we have as pediatricians is that we lack an umbrella body. So we've seen that the physicians have an umbrella body that brings them together as the East Africans and maybe South Africans. The surgeons do, but the pediatricians, we actually do not have that body. And I'll tell you later what steps are being taken. Therefore, even as we begin to think about things like subspecialty training, things like super specialization, we are having a big challenge with regard to accreditation and making training is uniform across these regions, because we actually lack a body that brings pediatricians across the region together. So the other thing is the curricula that we are training on have been there for a very long time, and some things have not changed for forever. So for example, one of the things that is affecting child mortality in Uganda is adolescent health. About 300 adolescents actually die in Uganda every year because of HIV. And up to 27% of adolescents actually get pregnant before the age of 19. And our curricula have not addressed this very, very well. So we still have a problem in graduate education, that some of the curricula may not actually be addressing the things that are pertinent to pediatrics in the current era. So I thought these were the things that we needed to address. And that as the discussion goes on, I will explain what steps are being taken to address these gaps.
Okay, thank you very much. So the gap, but also how do these gaps affect the health system? Because we want to link to our theme, so that whatever steps we are taking, how will they improve, strengthen the health system? Because we can have more physicians or pediatricians trained, but what about the system? Okay, Dr. Mike Kagawa, the obstetrician.
Thank you very much, Professor, for organizing this discussion, and to my colleagues who have shared. The question is the gaps and how they are affecting care and the health system. What I can say on the side of obstetricians is that as obstetricians, we have an association, which is the Association of Obstetricians and Gynecologists of Uganda, yes, and we have an umbrella body in the East, Central, and Southern Africa, which brings us together. We are looking at ways of how to improve training, but specifically going to the question of how the gaps and are affecting healthcare delivery. What I can say is that our training as obstetricians has basically been traditional, and we have probably not responded to the needs as my colleague has presented. The current need as it is now is that the disease pattern has changed, and probably the current obstetrician by training is not capable of handling the demands of the population as it is. And we think as an association, as obstetricians, that we should be looking at super specialization or subspecialization in order to address these challenges. Why am I saying this? I'm saying this because we are all aware that the disease patterns have changed. We are now having more women with medical conditions, more women of advanced age getting pregnant. We are seeing mortality patterns that have changed in terms of what is affecting the mothers and what is killing them. And we are also seeing that we have advances, for example, in terms of procedures and processes such as advanced laparoscopy, such as assisted reproductive techniques. And these are all gaps in terms of provision of care, because the obstetrician as it is now, based on the way they are trained, is not capable of providing this kind of care. And that's why we think that we need to look a little bit higher. We need to look at another approach to training, because as you are all aware, if we want to have a training program that responds to the needs of the population, we need to look at what is it that is out there that we need to provide. As obstetricians, we realize that the numbers have increased. The medical schools that are training obstetricians has gone up, yes. We are now having many obstetricians, but the questions we need to answer now is, how capable are these obstetricians to handle the contemporary demands of the population? And we think that maybe we need to rethink how our obstetricians are trained. We need to rethink the approach to training, how we manage the training, and the kind of competences these obstetricians acquire in order for them to address the gaps. So that's what I can say for now, that we are looking ahead on how to address this gap. Thank you.
Thank you very much, Dr. Kagawa. I will turn to the surgeon, Dr. Tumusibe. So what's the gap? I know, and we've been told that every year funds are used for people to go abroad for treatment. Okay? What is happening? What is it that we can do so that actually people come to Uganda for such and we get the money? Where is the gap in graduate training in surgery, apart from what has been already said?
Yeah, thank you, Chair. For us to appreciate the gap, we need to look at the 6 building blocks for health systems. And the first one is service delivery. So I can say that the surgeons have tried to train and distribute, but in service delivery, there is inequitable distribution of surgeons. Currently, the Ministry of Public Service provided slots for general surgeons at local governments at district level, but most of them are not filled. And the reason could be that surgeons are trained in the center and they find going back to the villages as a demotion. I would like to appreciate KIU, for instance, the model they have taken to train surgeons at the site of the likely work in future. If they are trained in those up-country settings, they get used and they don't feel shy to go back to those centers. And then, like my colleague said, the health workforce has been mainly on primary health care. The specializations are limited, but even when they super specialize, they prefer to work outside Uganda. And one of the reasons could be that the other building block, which is financing, limits both acquisition of appropriate equipment, but also retention of the staff because of the poor remuneration. So as we train our graduates, we need also to give them financial management skills so that they are able to mobilize resources, write and win grants instead of waiting for them to be given the good remuneration. They should actually contribute to the acquisition of funds. Then lastly, leadership and governance. Usually our training is based on technical knowledge, but we have limited empowerment in terms of leadership and governance. And therefore, when our surgeons are given the roles to play the leadership roles, most of them, they have gaps, especially mobilizing resources, efficient use of resources, including accountability. So if that can be inculcated in our training, then we're likely to have a better workforce that strengthens the health system. Thank you.
Thank you very much. Now, lastly, Dr. Mwanguzi. So what's the gap? And you're going to tell us our sister profession. What's the gap? Yes.
Okay, thank you so much. There are quite a number of gaps, but today we'll focus only on the ones to do with education. So one of the challenges, I'll first start by talking about the numbers so you can appreciate where we're coming from. So the nurses that are at enrolled level or that have certificates are about 50,000. And those that have diplomas, about 20,000. Now I'm talking about the figures from the Nursing Council. Then those that have a bachelor's degree, about 1,500. Then those that have a master's of nursing, about 40. And then those with a PhD, about 9. So you can see the way that pyramid goes, starting from 50,000 all the way to 9. So there's already an imbalance. So if we're talking about specialties at higher levels, there's an imbalance. Then another challenge from a very long time ago was about horizontal progression. So somebody would have quite a number of diplomas. So you'd go for diploma in pediatrics, diploma in midwifery, diploma in nursing, and not really quite progress vertically. Now that is slowly changing because I think in 2004, Bayer University started a degree program, a master's program in nursing education. And then Makerere came in by bringing in the clinical programs starting with midwifery in 2011. And then now we have programs like emergency nursing and pediatrics coming in, and also other universities like UCU and Lira are in the process of bringing in other clinical specialties. So you can see that even graduate and upper, like higher education in nursing is quite recent. So that's another challenge. So another issue is that many of the nurses, even at the degree level, feel that they have very few options. For example, someone is interested in doing something like emergency nursing, and the only master's which is available is midwifery. So they might not be willing to specialize, and then they're looking for opportunities abroad where they can get the choice that they want, or they end up doing public health or other programs which are available because their choices are not here. And then another big one is about registration. Even for those who have done, for example, Master of Critical Care Nursing or about Master of Nursing in Midwifery, if you go to the Nurses Council, there is no particular standard or way that they can register you in your specialty. You're still registered generally as someone who has a Master of Nursing Science. So that becomes very hard for you to grow in your area of specialization because you're still all registered in one general basket. So that's another gap that needs to be addressed. And then a few years ago, there was a lot of work that was done to develop a scheme of service for nursing cadres that takes nurses all the way up to the level of even consultants as they grow in their area of specialty. But that is another thing that has been proposed. Some places have started implementation, but other places have not started implementation. So if that is implemented all over the country, it will be a good motivator for the nurses to be able to take up these specialties and grow. And then another key gap is around employment and promotions. So someone has gone to school, they've done their specialty, they're super specialized, they're ready, they're skilled, but then there are no opportunities. It's not recognized in the government, and even just in your health facility, that opportunity doesn't exist. So somebody comes back, they've done their master's program, but then they're still forced to work at the level of the diploma because there's no opportunity for growth. So many people are not motivated to advance their career because they say, even if I do it, I'll come back and still be at the same level, and it will still take me so long to progress. So that's another big challenge that we have in our profession among many others. But I'll stop there for now to allow the discussion to continue. Thank you.
Okay, thank you. Thank you very much. So colleagues, you can see that we have a gap. We have a gap that our training may not meet the needs of the population, that the curricula are outdated, even if we revise them according to the National Council or the regulators' regulations frequently. We have a gap in the fact that even when people train, sometimes they're not able to perform, use their competencies. But what I want to come out is that these, and one of the building blocks of the health system are the human resources. So when these graduate physicians, nurses, whatever, go out, how do they support the health system to be stronger? Okay, how do we train them? How does the training support the health system? And yesterday we learned that we need to work together, the service providers and the trainers, to improve the health system. And that gap between the employer, between the service provider and the training institution, I think needs to come out. But then what has been done to address the pediatrics? Are there, how have you addressed it? Are you training more people? Have you started specialty training? And how do you think that will address the needs of the population? Okay, and maybe one challenge, because I want the audience to come in, just a few comments and then one challenge so that we can move and allow the audience to come in.
So thank you, Professor, and the other panelists. So as pediatrics, what have we done? We have increased, let's say, the number of people that, for example, we admit for pediatrics at Makerere University, and this has tried to address the issue of the numbers. But we are also, as a College of Health Sciences at Makerere University, taking lead in starting subspecialty trainings for pediatrics. So we are saying that even if primary healthcare is key, we need to know that the things or the diseases that are affecting children these days need advanced care. Like Dr. Kagawa has said, more women these days are having children at advanced ages. And there's several advanced technologies that are allowing women to produce children who are very small. Babies as small as 500 grams are being delivered in this country. Therefore, these babies need advanced care. So we are starting subspecialty trainings in neonatology. It's already ongoing. In hematology and oncology, we all know that the disease epidemiology is changing from infectious to non-communicable diseases. So we are in the process of starting those trainings at the College of Health Sciences. We are thinking of critical care, pulmonology, all to address the gap in specialized trainings. Of course, the challenge remains: how are these specialists, one, accredited and recognized as specialists, but also how do we then help them to deliver the services, the advanced services that they are trained to deliver at the hospitals where they are going to train.
Thank you very much. And therefore, that's why we need to work with the people who provide the services, the ministries of health, so that the services, these people can have what to do when they complete. The issue of other trainers there, as we increase the numbers. Do we have enough trainers? That could be another challenge. But Dr. Kagawa, quickly, what has been done and what is the challenge?
Thank you very much, Professor and the rest of the team. Maybe I will probably start by saying what hasn't been done. I think what we haven't done is we have not engaged other stakeholders in identifying what the gaps are. Many times, like the chair said, we have this curricula which we revise over and over again, but we don't seem to involve other stakeholders. What I think we need to do is to carry out a performance needs assessment so that we can identify the gaps and then address these gaps. We have tried to think through as trainers that these are the gaps, but I think we need to talk to the regulatory bodies, we need to talk to the community, we need to talk to health facilities, we need to talk to the clients themselves so that we understand the real need, and then we can address this need. As obstetricians, and I mentioned earlier in my discussion that we are trying to move into the higher levels where we have subspecialty training. As it is now, we already have a program running in gyno-oncology where we have subspecialty training for oncology, that is for gynecological cancers. We are yet to start a program in urogynecology at subspecialty level. We are looking to start a program on maternal-fetal medicine at subspecialty level. So these are our thoughts and these are the ideas that we have in mind because we think the disease pattern has changed and the demand on the physician has also changed. We therefore need to empower the physician to address these gaps. But again, like I said, I think it's critical for us to find out from the community and not think for them. Thank you very much.
Thank you very much, Lydia. I think you told us a bit. Any challenge that you've made as you roll out the training in that umbrella organization, and anything more quickly in 1 or 2 sentences before Dr. Tumuzime comes in, and patience.
Thank you, Chair. Yeah, so it's actually very interesting to listen to what colleagues are addressing as gaps, because those are the real gaps that were looked at while coming up with the EXACOP, this kind of collegiate training. So one of the things that we've done is that EXACOP has been made to be a college without walls. You don't need to have structures like, you know, the famous Makere Senate building and so on. It's a college without walls. So you realize that most of the training is going on at the sites of operation, provided the site meets the training criteria with what the chairs talked about. Are the trainers there? Are the resources there? So we go through an intense assessment of a site, and then when we all agree that it's actually a site that where a physician can be trained, then that becomes a training site, and then all the other things, tutorials and so on, are given in terms of a virtual learning environment that was created. And this has actually helped to retain people where they prefer to stay, and also even those areas, rural areas, are able to actually have physicians who are being trained, and the chances are high that they will actually remain where they've trained from. And then when you look at the curriculum that we developed, this curriculum was actually competence-based, and it started by assessing the needs of the health system and the population in question. And then through this, we're able to determine the competencies and outcomes of interest that would meet the health system needs. So if you look at our curriculum, it's actually very, very key in addressing what the health systems would want in order to improve care. And as I said, this is a college without walls. So you find that we try to distribute this training across all the regions. For example, in Uganda, you find a training in the northern region, you find a training in the central region, a training in the eastern region, and so on. So we try to ensure that all regions have adequate training sites for the physicians. Otherwise, all in all, we try to first do a needs assessment of the health system, putting into consideration the gaps that everyone else has highlighted. And of course, the overall outcome, what we expect to have is a well-trained physicians who is well-equipped to lead manage and also steward the vital resources that can dramatically improve health outcomes for all people across the region, especially in the difficult to reach communities. Thank you, Chair. Back to you.
Okay, thank you. The first presentation that Dr. Mwangus gave us was the program evaluation should actually be complete. And it seems that we are doing, many of us have been doing just the needs assessment. So we should plan to do the other evaluation, the process, the outcome, and there was another one which I forget, the input, okay? So that it is a complete evaluation, but also we should publish what we are doing. We should share information because there's a lot that is being done. Patience, do you want to add on? You've told us what has been done. Do you want to add anything about what should be done? How do we move on to increase the numbers of graduate nurses? These people are training, they have masters, they have whatever, but we need to match. Okay, we need teams, well-trained teams. It will not improve our health system if we have just a few graduate nurses. So anything that we could do as we move forward?
Yes, please. Thank you so much. So one of the other things that can be done is to have fellowships, which are not just master's programs, but these are actual clinical specialties. For example, Makere already has the neonatology fellowship, and others can come in. The Uganda Nurses and Midwives Council is actually doing a wonderful thing. They are currently developing standards for registration for advanced nurse practitioners. I think Dr. Rose Clark Nanyonga is here. She's also involved in that as well. So what is happening at the moment is when people study abroad or when they do their specialties here, like I said, they can't register in their specialty. So standards are now being developed so that someone can actually register in their specialty. There's also a recommendation now for competency-based curricula, not just the academic ones, but we must be able to see the clinical competencies. Dr. Kagawa has talked about stakeholder engagement, but there's also a role for the associations, because now we have an association for pediatric nurses, association for critical care nurses, midwives. So all those associations can also add on their voice to lobby so that we have people from all sides pushing this agenda forward. Another challenge that I forgot to talk about is that when people come back from their training, for example, I've done my master's in midwifery, then I come back to the hospital and then I'm deployed to orthopedics unit or ENT or eye. So that is not making good use of the information or of the knowledge and skills that I've gained in midwifery. So the associations can also lobby to ensure that even the hospitals make sure that those that come from a particular specialty are placed in the area of their specialty. Then we are also looking for recognition out there in our specialties, so that when I come out and I've done my program, I'm able to be recognized even in my health facility, that I can practice, maybe not autonomously, maybe semi-autonomously, but if we have that interprofessional recognition and acceptance of our skills, then that will also motivate many nurses to come up and study and progress. So I think those are some of the ways that we can also improve, but I think the Uganda Nurses and Midwives Council is key in this as they develop these standards and enable us to be able to register in our specialties. Thank you.
Okay, thank you. There's a lot to talk. There's a comment in the chat that Lila University is developing a program in Master of Midwifery Science, and stakeholders were involved in the development of this program, which is good. The surgeon, what has not been said? Don't repeat what they have said as we move forward. What is it that needs to be done? One thing, and then we open the next 15 minutes so that the audience can come in.
Yeah, thank you, Chair. What needs to be done? One is we have to make a deliberate move to include mentorship as part of the training process. Most of the postgraduates are not mentored. They are sometimes seen as competitors. There is low commitment low commitment to train, but also to learn. So in most cases, when people come for training, they are moving up and down. Their teachers are moving up and down, and the students are moving what? Up and down. That in the process, they clash. And then it also leads to a low pass rate. Remember, the numbers are fewer entering into the system, but again, when we have a low pass rate, then we don't achieve the numbers. We take more years. So lastly, we need to go to the communities. Surgical diseases are in the communities. When we wait for them to come at the tertiary level, the cost of their treatment is too high. And therefore, I recommend that the trainees should be taken to their communities during their training so that they appreciate the burden of surgical diseases within their communities. Thank you.
Thank you. So we need to improve how we are doing things. Mentorship is an important area. We've been reminded, but also that we don't need to do all the training in the tertiary hospitals. We also need to go to the community. So I would like to invite questions and comments from the audience. How can graduate education, how do we implement graduate education with the purpose of strengthening the health system? So that is what I want you to comment on. There are two hands, Lydia, and then there's one near you, and then we'll come this way. So there are many comments. Please, a comment, we'll take all one round, and then the presenters will address.
Thank you,
Yes.
Chair. I am happy that I am here today because I chair a curriculum review committee at the university. And I want to be quick on the challenges that we face.
One or two, because many challenges have been said.
Well, yes, I'm not going to repeat anything that have been said. Number one, we need mindset changes at the regulatory bodies. What Dr. Patience has said is a problem at the Nursing Council. That's why those people are not being registered. They look at competition as coming. I don't know who can help them to be able to change their mindset about these people so that we have the specialists trained, registered, and sent to where they need to be. Number two, lack of investment by government.
Okay.
We have specialists who are coming back. We are not giving them the chance to replicate themselves.
Okay.
And that is associated with the bureaucracy from National Council of Higher Education. If a specialist has to train and there are few resources, they can link up with their fellows they have trained with from US, from China, from India, from wherever, to help come and train people locally. Why not support them? When you write a curriculum, they're asking, how many staff do you have? And the government is not recruiting this staff and deploying them at those universities to train.
Okay, so
In
bureaucracies, the last one, please.
Yes, last one. The other thing is expansion of internship sites. All district hospitals, I'm sure what people need to train medical students as sites for training. You need specialists at those sites. District hospitals have enough patients to be able to train. Why can't government recruit specialists and provide them the resources that they need to work at those sites? Because many other sites are full.
So what I get, because we're not talking about interns now, on internship side, so that the specialists trained can actually be employed at the district hospitals.
Yes.
They will be serving the population there.
And they will mentor others.
Okay, but also they will help to go to the community. They can also help training at that level. Okay, thank you very much. For the sake of time, there's another hand there. One comment, Dr. Cloud.
Thank you very much, Chair. My comment is on numbers. We agree we have insufficient numbers of specialists at the basic specialization level. Now, another point has come up of super specialization. We have limited resources. The numbers are not enough. We are talking about super specialization, which is also required. How do we strike a balance between the two? Thank you.
Okay, how do we strike a balance? They'll tell you, but if you know the burden of people, the burden of disease, I think we need to do everything because there are people there who need those services. And I know that some institutions, the Heart Institute is doing a wonderful job. The Cancer Institute is doing a wonderful job. The neurosurgeon. So I think we can do all, even if we are also looking at the lower cadres, because we have the capacity, okay? And people are dreaming big. Yes, Professor Sebufu.
Yes, thank you, Chair. And thank you for such a wonderful discussion. The biggest challenge I think we may be knowing the gaps, the needs as Dr. Kagawa is requesting, but we need to have political will. There's lack of political will. And if you have this political support, then you'll have the financial support, and then issues that were mentioned by Dr. Tumusime, Gerard, issues of infrastructure and equipment, they will be sorted. I'll give a very good example. We had the presidential scholarship for the different surgeons who went to India. They got fellowships. In surgical endocrinology, hepatobiliary, surgical oncology, all subspecialties. They came back and there is they don't have equipment. There is no infrastructure to support them. So once you have the political will, then someone will understand. Then the other thing, maybe as a way forward, again, to strengthen our health system, is also to create centers of excellence. For instance, the way it has been done, like now the Heart Institute, Cancer Institute, those can be centers of excellence for training, not only for Uganda, but also for the region. Then the other one would be
the last one.
No, it's still the same. So if we can create centers around the country, like Ruharo, like Chijabe in Kenya, where you have pediatric surgery, or Muhimbiri, where you have dental and urology, I think that will also help us to bridge the gap.
Okay,
thank you.
Thank you. And I know that the East African region is doing that, and each of the country has a center of excellency in service provision, but also in training, but we also need these centers in the country. I'll read one comment from the chat. Good morning. My name is Karame Glycine Ikerezi, first year BSN nursing student, Makerere. As for me, I think the students should get to interact with already graduate nurses. You people, graduate nurses, the students are asking for you. You are not interacting with them, okay? They want to interact with you so that they can develop, she said, some things like empathy. So early clinic exposure. Let's not forget our students because they are there. Then there was another comment that the doctors who have specialized in disciplines like microbiology, can they be registered by other councils? Yes, the comment, question.
Thank you very much. My name is Dr. Ankalubu Jonathan. My comment is a question to the panelists. Do we have any interventions to track the people we train so that we can know whom are we training for? Are we training to retain or are we training to export? Where are these people? Are they in business? Are they still in healthcare professions that they trained for? Thank you.
Okay, tracking. Any other comment or question from the audience or from the virtual audience? There's a question, tracking. How do we track all these obstetricians, these surgeons? I know that for the graduate first degree, I'll talk about the Uganda Medical Dental Practitioners Council. There's a system for tracking. Actually, universities are required to register the first year students so that the council can track the progress, but also after completing, they can track. But as institutions, we should track our graduates, okay, to see what they're doing and are we training for the country? I'm not sure. Yes, Dr. Kagao.
Thank you very much. the audience for those comments. The last question about tracking of trainees and what they are doing, I think we probably need to work differently there and start doing this. Many times all we can report is how many obstetricians are working in Kampala and how many have gone up country, but that's all we have. That are registered, but we don't seem to have evidence of all the trainees we have that have gone through our hands and where they are. But I think this needs to be done centrally because as we are all aware that we have different training institutions. So I think our associations have a role here because we are all expected to register with the council and the council can work with the associations to track our trainees. But maybe what I wanted to comment on out of, as part of this context, which was raised by one of the presenters, is the issue of the trainers. I think the chair alluded to this. While we decentralize training, are we comfortable that the trainers are there to train our trainees? Maybe we need to explore that. How do we actually train our trainers to make them capable of training the people that we are sending to be trained at various centers? There's the assumption that even at the university, the trainers are capable, but maybe that's an over-assumption. We need to look at the trainers. Are we trained to train? I think that's what we need to also think about.
So capacity building for the trainers at the university, but also at those centers where people are training. I've been to some of these hospitals where these students are, and you see them, one or two, and sometimes I say, okay, it's a good thing, but do they get everything? Yes, probably they also get the mentorship from the people practicing, but do they get all the competencies? And in one side, they told me every 3 months we have a grand round and all that. So competencies and how we track, because it's not only the skills, it is so many things that we are training these people to have. There's a hand. Is it destiny?
Or maybe,
Yes,
maybe I
Carmen.
can share one or two things just before we go on. I wanted to talk about building capacity at the lower levels. I'll give an example of one of our colleagues, Dr. Scovia Mbalinda. She takes her graduate midwifery students to a community in Atiak where they offer services and the students learn, but as well, the midwives who are in that area are able to be mentored and get the skills that are needed. So I think we should also be able to take the graduate training down to the lower levels, not only the master's and not only the undergraduate, because at the undergraduate level, we have things like COBAs where people go to the communities, but this should also happen at the graduate level. So I thought it was something key to say that even those who are doing graduate training for nurses should also take them down to those levels. It won't only be training the graduates, the students, but it would also be mentorship and building skills and competencies among the health workers who are already in service. Oh, thank you.
Okay, thank you. Anyone else from the virtual attendance? One last comment and then we'll close. Okay, there's no one. I would like to, there's a hand in the audience. Please go ahead. I can't
Thank you very much. I wanted also to comment on the need to attract talent in the graduate training, and that in a way is anchored in making their remunerations. You know, there's need to improve or to make their salaries attractive that can in turn can attract talent in the graduate training, that this eventually can again impact, can enable the system feel these graduates, the health systems, because also for policymakers to pay attention to the graduate training, they need to see that, to feel their impact.
How, during training?
No, after.
After training.
After training.
Okay, so thank you very much. We've learned that we need to do a needs assessment, but we should involve all the stakeholders, including the political leaders, including the ministries of health, including Ministry of Education, including the community, everyone, so that we can understand the need, but also to get support for the training. The regulators are very important. And yesterday we agreed that they should be realigned so that the regulation systems are in line. But as one of the regulators by default, we should also offer programs when we have the capacity. Many times there's actually no capacity, and this only to capacity, and this affects the quality of the graduates. So it is 1:15. I would like to end this session and thank our discussants and everyone. Let's give ourselves a round of applause. Okay, thank you. We'll have a break, 30 minutes. Isn't 30 too much? Let's take 20 minutes in case we need a bit more time. We'll come back at 25 minutes to 11 for the next set of presentations. So people online, please have a break, stretch, and then we'll come back for the next set of very interesting presentations. Please don't miss the afternoon presentations. And today we are not going to leave very late. Thank you very, very, very much.
Afternoon, everybody. Sorry, still morning. Let's begin our next session, where we're going to dive into a series of presentations about improving teaching and learning. Just to give us a bit of background, the university is supposed to do several things. That includes research, community service, which we've talked about before, and teaching and learning, which is very core. And all of us who are attending this conference and those online, we're all interested in teaching and learning, either as beneficiaries or as stakeholders in any other capacity. And so as we dive into this very important aspect of university functioning, we're going to go through a series of presentations looking at different aspects. We begin with Claude, who will be introducing bioethics, something about including bioethics in the another curriculum. Yesterday, we had something from Professor Sawan Kambo mentioning the issue of us being ethical in how we do our learning and our teaching. So the ethics of medical education, but he'll be talking about something different. This is bioethics in itself. I have something from Elizabeth Akinyi. I don't know if she's available online or Elizabeth. If you're online, please let us know because you're supposed to present. If she's not online, then we shall proceed straight to Felix. I met Felix, he's around. Improving learning and teaching in learning and teaching of medical mycology, where there are no mycologists. Very interesting. Then we got to Stanley. Yes, Stanley is here as well. Great. Improving learning and teaching of medical no, Stanley, I think they mixed up your topics. Is yours the same as Felix's? It's different, huh? Okay, so Stanley will come and present his topic. I don't have it here. What I have on the program is slightly different, something about PBL. And then Jen, I saw Jen. Yes, Jen is around also. So Jen will be last, so in that order. So we'll begin with Claude. Claude, you're first, as we try to confirm if Elizabeth is available. So over to Claude.
An extra pair of eyes. Thank you very much. As a way prologuing this, my names are flashed on the screen there and where I belong.
But I want to give some brief prologue of the current situation with regard to the teaching of ethics in our institutions. My topic is inclusion of bioethics, but you'll find that institutions are already teaching some ethics, medical ethics specifically. But we need to ask, how is it being done? And at which level is this? Are all the institutions doing it? As we get along, we shall see whether this is okay or not. So my presentation outline is as indicated there. In the interest of time, I will not go into one by one. So what is the ethics I'm talking about? I will not read the whole thing, but I want us just speak something from here. It's about well-founded standards of right and wrong that prescribe what humans ought to do, usually in terms of rights, obligations, benefits, society, fairness, or specific virtues. When we go straight to medical ethics, this one should critically examine the reasons that underlie any medical decision that involves the concepts of right and wrong, what is good and bad, and what ought to be done or what ought not to be done. These are everyday decisions in medical practice. So are we ready to make such decisions by the time we graduate? Ethics, as a caution, does not give answers to what is wrong and what is right, but as we get along, we shall find that we have frameworks that we can use to be able to make appropriate decisions. Later on, we are going to see, do we need to train somebody to be able to make appropriate decisions? Now, I want to set the ball rolling. You might not be able to read that, but I want us to start thinking, and this is the mode that we should be using when we are teaching ethics. This is a case, one case that surgeons can encounter: examination under anesthesia. Pamela, a 34-year-old woman with fibroids, was clocked in yesterday by a fourth-year medical student on an obstetrics and gynecology rotation. Pamela is scheduled to have hysterectomy, and the consultant asks the student if he would like to scribe in to assist during the operation. The student has assisted the anesthetist before the operation and has reassured Pamela about the planned operation. Once Pamela is anesthetized, the consultant asks the student to demonstrate how he would perform an internal examination on a female patient. The student realizes that Pamela was not asked for permission to do this and feels that it would be wrong to carry out the examination. However, he also thinks that it would be a good learning opportunity and is slightly in awe of the consultant, and he knows that he has shouted at other students before. The student decides to point out that he does not have Pamela's consent, but the consultant reassures him that Pamela is anesthetized. She will not know anything about it. Should the student perform the internal examination? What should he say to the consultant if he refuses? If this was part of a research study in which the consultant was involved as a PI and the student was a research assistant, what would be the acceptable approach? Is there a need to train medical students on how to handle such dilemmas? Considering the surgical procedures to be undertaken, what other challenges are likely to come up? Would training in ethics alone be sufficient, or there is no need to incorporate aspects of the relevant laws? At what stage in medical training should this kind of training be imparted to the student? Is our current medical curriculum designed to bring out this kind of competence in medical students? We are not going to answer this at the moment. So I can say we need some reorientation. The following reasons can be advanced introduced by ethics in medical education. Ethics has foundation in bioethics. Ethics contributes to high quality patient care and professional behavior. Knowledge of ethics allows medical trainees to become better practitioners of medicine. medical practice involves a lot of ethical dilemmas, and these require ethical arguments to resolve them. Theoretical frameworks on which to base the arguments, ethical theories, universal ethical standards to apply. Are these in place? Yes, but are we applying them in our training? We need to find out. This one is just to show where medical ethics and bioethics falls when we are looking at the spectrum of the branches of philosophy. Now, this is what a qualified practitioner is supposed to do: research, community service, teaching, participating in leadership and management. So as we train our doctors or health professionals, are they ready with the necessary competencies to handle these four we have on the square? Now, from what I mentioned in the case, there is sufficient evidence that we need to take action with regard to the way we are handling the training of our medical practitioners. And introduction of ethics can provide insight into such concepts as professionalism, communication, empathy. Some people are talking about empathy in the morning, and critical evaluation of biomedical research and policy. There are many things that we can mention. I will not go into everything. Yeah, we are sharing these slides, but I think we now know the direction we are taking. Ethical arguments have mentioned that we need a theoretical background, and theories are there, meaning the students have to be trained in these theories. The famous utilitarianism, deontology, virtue ethics theories, students will need to learn these. You can't say they are going to learn from experience. The principles, the 4 principles by Bucamp and Childress, they can learn these. The question is when and how. Now, as we justify this, someone might ask, but can ethics be taught? Because traditionally, people expected that the medical doctors, the young ones, would be learning from the seniors, and at the end of it all, they become experts. But things have changed. As we are going to see the evidence, ethics can be taught, but the question is there. Can character or virtue be taught? These are questions people ask. Are there universal ethical standards that we can apply with the diversity of the world? Are there enough resources to teach it? So we answer the questions at the end, but coming to whether ethics can be taught. Socrates, 2,500 years ago, said yes. James Rest agreed with him. Lawrence Kohlberg also agreed with him. And for him, he goes beyond and mentions different stages of learning, which can be, which people can go through. You have the pre-conventional level, conventional level, and post-conventional level. The first level corresponds to childhood. Conventional level at adolescent stage. Post-conventional level, that's where we can be able to question things, not basing on what our parents are saying, what the authorities are saying, but basing on our reasoning, and that one can be learned through education, which we are talking about. So, if we are talking about ethics, then the findings of Rest, Kohlberg, and of course from Socrates, the answer is a resounding yes, that ethics can be taught. So there are no questions about that. The other issue is about standards. Which standards do we use? The world is diverse, but scholars have come out with a number of approaches, and they put 5 different sources of ethical standards that we can use. Utilitarian approach, rights approach, fairness or justice approach, common good approach, the virtue approach. And these ones derive from utilitarianism, deontology, and virtue theories of ethics. These ones we can apply. I will not go into the details, but I put some detail on each one of them to see how we can apply them as we teach. So these need to be put together, but still a question comes. We may not agree on the same set of human and civil rights. We may not agree on what constitutes the common good. We may not even agree on what is good and what is harm. So what do? Considering what has been put in place by scholars, philosophers, and so on, different approaches can be used, but has been found through research that they lead to similar answers. And we can have a framework of decision making. Literature shows it, that it is there. We have a set of facts that we can follow, recognize an ethical issue, get the facts, evaluate, make a decision and test it, act and reflect on the outcome. That is the framework that has been put in place. The literature is there. We can also apply this. So what do we need to have in the curriculum? There are many things in here, and what I have given is that we can have this curriculum spread throughout the medical training. It shouldn't be concentrated in the first year when the students have not had any clinical experience. When you look at the schools, they teach, those that teach ethics, it is just in the first year, and it is not spread across the curriculum. So you'll find here, I'm prescribing what we can have in first year, what we can have in second year, what we can have in third year, what we can have in fourth year, what we can have in fifth year, relevant to their level of understanding and the clinical experiences they will have gone through. So that when you are teaching, they also have the experience from the wards. And to implement this, we need to put infrastructure in place. Human resource for health. I'm glad universities have already started training at postgraduate level. They gave me 2 minutes, I've used one. And we can establish, the resources are there, but we can just add and work on the curriculum and implement it. Thank you very much.
Thank you, Claude. I'll ask the next speaker. So we have 10 minutes per speaker, so try to keep the time. And I suggest that we do all the speakers first, and then we have a round of questions. So this is Stanley. Stanley, can go ahead. Rethinking problem-based learning, Systema University. Over to you.
Thank you. I'm going to take you through a talk of rethinking problem-based learning curriculum in Busitema University. This was a short study out of my HPE fellowship with FEMA. So by background, problem-based learning is an established pedagogical strategy in medical schools across the world. And it is gaining increased adoption in developing countries like Uganda. Busitema University Faculty of Health Sciences started implementing PBL in 2013, and since then, student numbers have increased and staff numbers and resources to deliver the program have remained the same or just slightly increased. So we assess the feasibility of the PBL curriculum in Busitema University Faculty of Health Sciences located in Mbale. So it was a cross-sectional study involving lecturers, administrators, and then the students. 36 students were involved and 7 staff from the Faculty of Health Sciences were interviewed using the qualitative approach. I will not indicate the details of voices here because of the time allocation, but a lot was said by the interviewees. So we came up with the one theme through our analysis, understanding the curriculum structure. So the problem we found here is that Busitema University adopted a hybrid PBL curriculum, meaning that 70% of the content is delivered using PBL and 30% lecture method. But this remained in the books. The administrators like the AR and the Dean knew that we are implementing the 70-30. But when you ask the lecturers, they are not sure of that. And most of them are saying 50-50. So the lecturer is the actual implementer of this curriculum. And if he's not aware of the mode of teaching that we are using, then he's bound to error all the time. So others said it depends on the course. So when it depends on the course, every course coordinator chooses how much should go to the PBL and how much should go to the lecture-based system. So that discrepancy that the custodians of the curriculum and the implementers have a difference. The administrators understand the curriculum structure, but they don't go to class. But the lecturer who goes to class is implementing something else. And then the challenge in the delivery of the PBL now began to arise. At first, we had very few students as the faculty was just starting. So we had more teaching staff than the students. So we would even have a privilege of having 2 tutors at the same time in a tutorial group. But as the students increase by the years, and then there's pressure from government, taking more. So the student numbers increase and the staff numbers just increase very slowly. So the large student numbers required that we needed more infrastructure. We needed more classrooms. So if you have an ideal PBL should have about 8 to 10, maybe at most 12 students in a tutorial. But if you have a class of 120, you probably need like a minimum of 6 small rooms, 5, 6 small rooms to accommodate these students. So with that, there's a lot of pressure on infrastructure, which is not coming up very fast. Then that also, there was also a problem of tutor absenteeism. Maybe sometimes because of poor remuneration, and sometimes I think the ethics are lost. They say this one is a government job, it is in store. Let me look for money elsewhere. So sometimes the ethics come in play and tutors are absent. And this also has led to combining the groups. If you have a tutor absent, that means if you combine that group with another, instead of having, say, 10 students, you have 20. Already you are developing into a class, and the PBL is lost. And what follows after that? Objective assessment. I love Professor Chiguli when she gets to talk about objective assessment. Now, to assess 20 students in a tutorial group becomes a very, very difficult to be objective. And then, at least if there are 10, you know almost every student by name, and you are able to engage them, make them contribute equally. But now when you divide, say you have 2 hours to run a tutorial and there are 20 students, how much time are you going to apportion to one student? It becomes a big challenge. So objective assessment became a big challenge. And because of tutor absenteeism combined with this, we found that actually some tutors would even assess students before a tutorial happens, because of the objectivity of the assessment has been lost. Again, we've recorded also student-led tutorials. Ideally, a tutorial should not happen if the tutor is absent. But then the tutor connives with the student that, please go on. I'll join you later, maybe in the next tutorial. And you see that there is a student-led tutorials, which is not really good. These groups are not well guided. And the quality of tutorial problems also came out glaring. There was need for quality assurance on the tutorial problems, such that they can deliver the objectives that they are intended to answer. Some administrators perceived PBL as time consuming. Of course, it's sad if that comes from the administrators. And I think this explains partly what is very common in Uganda, that if I am administrator today, I bring this program, is doing well, the next administrator will want to trash that and bring on board theirs, not to add value on what I have built, but to show that you did nonsense. Now I am going to make sense here. So if this comes from the administration, then it's really very sad. And so the strength of the PBL curriculum from both the students, administrators, and staff, they think this is a very good program. It gives confidence to the students. And this, you find a girl can come in first year, he talks to you facing down, holding a skirt. By second year, you can engage in a very meaningful conversation. So all over, we've received these reports, even after alumni evaluation, that our students are really confident. So the program is good. Challenges of finances delivering it are really immense. So students also obtain lifelong learning skills, which was good. And indeed, as we conclude, we need more knowledge about PBL curriculum structure for the staff, because these are people who are going to implement it. It shouldn't remain at the administrator's table, but let the staff from the time of recruitment understand what they should implement in the curriculum. Then more resource allocation. We need more classrooms for these small groups to study. And then we need more materials, flip charts, whatever is required to deliver a tutorial, a good tutorial, flip charts, markers, and so we need more resources on that side. And faculty development programs need also more resources, develop faculty to be able to objectively assess in a tutorial, and also develop their capacity in all areas, because an increase also specialists in such areas. We've had tutorials run and someone is complaining, I am a public health expert, and you're taking me to a tutorial of anatomy. So sometimes it's hard for someone to take off quickly. And we have had incidences when the tutor admits to the class that, you know, even me, I don't know these things. So how do students perceive us when we give them such responses? So we thought that was important, and I conclude and thank HEPI and organization of this meeting. Thank you.
Okay, thank you very much, Stanley. I'll quickly invite Felix. Felix, where are you? Like I said, we're going to go through all the presentations first, and then we'll invite all the speakers back here to, as it were, respond to some questions from the audience. So Felix is next, but I've liked Stanley's take on doing something good in a difficult situation. That's an interesting perspective. And as Felix's PowerPoint comes up, I think you have to prepare for some comments on that. Felix, you can introduce yourself as we find your slides.
All right, thank you, everyone. I'm Dr. Felix Bongomin. Yes, so I'm a lecturer in medical microbiology and immunology in Gulu University, but at the same time, I'm a third year internal medicine postgraduate at Makerere University. So my talk basically is about how to improve learning and teaching of medical mycology where there are no mycologists. This was really for global outreach using our platform, which we call the leading international fungal education. For starters, medical mycology is the study of fungal disease. So fungal diseases are really complex and wide spectrum. Just to introduce you to the concept and why we really need to teach people out there about fungal diseases. They're really complex and mainly complicate, already big problems like HIV, TB, or other chronic lung diseases like COPD. So, for example, we all know cryptococcal meningitis, which is one of the leading cause of HIV-associated mortalities in our setting. And then, of course, the new kid on the block, COVID-19, which has also introduced many other fungal diseases, which we now call emerging fungal diseases, like, for example, COVID-19 associated aspergillosis, or the big epidemic of COVID-19 associated mucormycosis, which, India has declared it as an epidemic. The media calls it the black fungus. And we have also seen the impact of this on fungal-neglected tropical diseases and as well as AIDS-related mycosis. Recently, we published a paper in PLOS NTD that showed, the negative double impact we were foreseeing, what is currently being seen in India, how, COVID affects already HIV, TB, and malaria, which are big issues. But at the same time, there's minimum funding for the fungal-neglected tropical diseases like Madura foot or ringworm, and so on. So this remains a big issue. But what is the global burden of fungal diseases? Again, some 4 years ago, I attempted with colleagues to really define the global burden of fungal diseases, where we showed that, over 1 billion population actually gets skin, hair, and nail diseases, but also not forgetting the 700,000 patients who really get crypto, resulting into, big number of cases of death, plus other really fairly rare diseases, but they occur. And we calculated that, up to about 1.6 million people die of fungal disease, which is comparable to 1.4 of TB, or even just 700,000 of HIV annually. And also recently I've shown another big issues related to endemic and epidemic, as well as emerging and re-emerging fungal diseases in Africa. And still we see that, the key drivers of fungal diseases, even in Africa, is HIV, TB, and poverty. And this also actually includes Uganda. So we think it is a big issue, but still quantifying the global burden is big problem, because fungal diseases really are not put in surveillance, and there are limited expertise in fungal diseases. For example, we are only actually 3 in Uganda who understand fungal diseases in totality. 2 people in Makerere and 1 in Gulu. So as I was working in the University of Manchester, I did a 3-year research fellowship in Manchester with one of my bosses, Professor Denning. So with this, we made function this fungal education program, which now we call LIFE, so that we get different aspects of fungal diseases and educate the world out there. So really, it was meant for people in low and middle income countries, and just to improve their skills and knowledge so that they're able to diagnose these diseases very early. So I made these slides with Professor David Denning. All the slides were peer reviewed by experts, and we made it available in YouTube and different PowerPoints presentations, and also in podcasts. And we derived specialists in fungal diseases from across the world, including Manchester from Mayo Clinic, myself, Manchester by then, and then people from Minnesota, and also St. George's University of London. So we then piloted this. I sent this link to my colleagues in Gulu University so that they can pilot, especially in the antifungal aspects of the disease, where we piloted things mainly involving essential medicine, which are already listed on the WHO EML. So this was a 2-day lecture on antifungal diseases. Day 1 was on amphotericin B and flucytosine, which are the cornerstone for the management of cryptococcal meningitis. And day 2 really was on the triazoles. There's a typo there. Fluconazole, which we know very useful in treatment of candidiasis, but also maintenance and consolidation phase for cryptococcal meningitis, and also itraconazole for, candida resistant to fluconazole, and voriconazole for invasive aspergillosis. So then after that, we did a pre and post evaluation. So we do not have very many students. There were 60 at that point in time, and majority were really male, 78%. So we showed clearly that, there's no big difference in the performance of males and female medical students as far as this course unit of microbiology was concerned. Just to note that we did not use these marks for final evaluation of our students for their progress in third year. And we also showed that even when the lecturer who delivered the lectures was really not an expert in mycology, but a general microbiologist, we were able to see a 14.4% improvement in the pre and post scores. And students also evaluated these materials, which were online, both the PowerPoints, the podcast, and the YouTube videos. And they were really highly rated, and they highly recommended this for us to continue with it for the next class. So I conclude by saying fungal diseases are common, especially in low and middle income countries, where there are limited number of experts in this particular area. And we showed fairly that using freely available online materials, which were synthesized by experts, could enhance the teaching and learning of medical mycology in our setting. And if you wanted to know, then we published this paper last year. And also just to remind you that the future may be fungal, because even when we get the non-communicable disease, most of the super infections may come in. And this is a recent publication from Scientific America that showed that, the next deadly plague may actually be fungal, like India is already seeing mucormycosis. Thank you.
Thank you very much, Felix. Jen, 10 minutes. As you can see, we have a very big spectrum of topics. And after Jen's presentation, everybody will come back here and she'll have a series of questions to them. I've already prepared mine. I'll listen to Jen's and modify.
So I'm Jane Francis Namatovu, a lecturer at the Department of Family Medicine at Makerere. I am also a health professions education PhD student, and those are my supervisors. So before I started out with this journey, my area of interest is continuing professional development. So I did a review of what other people have done around this work. So, and I was looking at what frameworks have been developed in different countries to see how I can improve what I envisage to do in my PhD studies. So as a way of background, CPD is a process by which health professionals keep updated to meet the needs of their patients, the health system in which they work, and also their own professional development. And it is important that they have this because it is one of the 6 domains for quality assurance in healthcare systems. And that importance can be subdivided into 3: to the individual doctor or health worker, to the profession where they subscribe, but also to the public. And to the individual, they would like to keep pace with the current standards, but also maintain and enhance the knowledge and skills which they acquired during their preliminary education and also make a meaningful contribution to their teammates with whom they work, and also to keep them interested in the profession. But for the profession, CPD is important so that it helps to deliver a deep understanding of being a professional and also advances in a body of knowledge and techniques in that profession. Importantly, to the public, it helps to increase public confidence in the individual professionals and the profession, as it were, but also contributes improved protection and quality of life for the public. Different strategies have been deployed in different countries to try and improve CPD, and the main strategy is to develop an effective and feasible CPD framework that is suitable for those particular health practitioners, in this case doctors, in their practice environments, because practice environments are different. And so it is important to make sure that what is chosen as the framework is effective and feasible. So the objective for this review was mainly to describe the relevant development processes regarding what is functional as a CPD framework for doctors. And as I reviewed the literature from the different databases, the keywords that I was using were CPD, CME, medical competences, and CPD activities. And I reviewed over 20 studies which had been done both on the African continent and elsewhere. On the African continent, we really had very few, but at least there were quite a number from Canada, from the Netherlands, and some from the Asian population. And most of the papers showed that there must be some drive for CPD, and the drive may come from the practitioners themselves. It could be from the organizations, but it could also be facilitated from the workplace learning strategies that they have, and also the workplace cultures that are present. And all of them are trying to ensure that there is some form of transformation of the individual professional, transformation of the workplace culture, but also to see if there's transformation of skills among the doctors, and also transformation of knowledge from when they graduated and how far they've come. So the main components that were identified from these studies included 3 components. And the first one was that most of these had to identify first the CPD needs or competencies of those doctors, that what they perceive is what they need, or what the organization is requiring them to have as competencies. And the second important component that they had was to plan on how the doctors will learn, but the planning, most of it emphasized to be collaborative and internal, but also participatory, including other people who may be probably not the doctors, but people who make decisions in those organizations. And then the third and last, which was obvious, was evaluation was important. And the evaluation was mainly to give feedback to the previous 2 main components, but also to see how to improve continuously what they are doing on a daily basis, to see that the value of CPD can be improved every now and again, depending on the changing times and the needs of those organizations, but also the health workers as they grow in their career. As I conclude, it is important that the foundations of the 3 components is looked at as they developed this content-specific CPD frameworks. And the context was very important in defining the doctor's practice needs, but also important in the choice of the learning methods that is being picked on, If we have noticed, our context here keeps changing, and right now, the whole world has COVID. So there are many things that have to change as far as how we do CPD is concerned. Thank you.
So I'll invite all the speakers to come and sit in front here, so that we can have a few questions to them. Anyone with a question? Anyone with a question? We have one, only one. 1, 2, 3. Okay, we begin with those three. Where's Edward? Edward, come and help run around the mic, please. Or run the mic around, not run around the mic.
Thank you very much, the three presenters. Questions and comments to the speaker from Positema. Was any preparation done for faculty before introducing the curriculum about problem-based learning, how it is done, and preparing this faculty to undertake this? And two, is there continuing faculty development regarding this? Because if we don't have this, then we might throw away a second baby in the dirty water. And the comment, the last one is a comment, is that probably we need continuous faculty development to understand really what they are doing and why. And that's the challenge, even the administrators. But also I did not understand when you said how much time do you give each student if you have 2 hours and you have to assess objectively. I thought that the students are discussing all of them, what is coming out of the problem. The ethics training in undergraduate is very important, and I agree that probably it should be at all areas. The question is, are you proposing courses of ethics from year 1 to year 3 to our already overburdened curricula? How can we innovatively introduce ethics training in what students are doing without adding, and is all that information relevant at this level? I think I'll stop there and allow others to ask.
Thank you. My first question goes to Stanley. So Stanley, I would want to inquire first, how were the staff involved in the development of this PBL curriculum? If not, then many times lecturers find it difficult to implement a curriculum because they were not involved in the development of that curriculum. So it becomes very difficult really for them to implement, and that could be the reasons why some people were saying they did not understand part of the things that we were doing. And then to Dr. Felix, thank you for the work and the development of the content that you have online. My concern is the content that you have online, you develop it from the UK. So you must have based on a lot of diseases that are prevalent in the UK. So I don't know how much it took into consideration the local disease prevalence here, especially mycotic diseases. And that's the way we are going to teach it versus the drugs that we have in the essential drug list for Uganda. Because otherwise we are going to be teaching the ideal, which is outside there, and we forget what is actually ours. And yet our role is first of all to ensure that the student who is supposed to practice in this country understand the diseases that are prevalent in this country and how they are treated based on the drugs that are easily available. I'm not saying we shouldn't tell them about the others because they can go and practice outside, but it is a must to know what is our problem here. And on ethics, I just want to agree with Professor Chiguli about innovatively introducing the ethics. We cannot teach ethics throughout, but a bigger part of the ethics is actually delivered by the ways the students look at us. There's what we call the Eden curriculum, which the students see in what we do, not what we teach. How we conduct ourselves, how we behave around patients, how we handle things, administration, how we talk to people. If we are telling them to be ethical, but the way we are behaving conveys the otherwise, and the ethics we are talking about, actually we kill it by the way we behave or interact with our fellows and students.
Thank you very much for your presentations. My comment and question has kind of generated some discussion already, and this goes to the person who presented ethics. My question was your prescription of training of ethics in the different years, year 1, year 2, year 3. I was inquiring how you got to that to assign them in those different years, whether you involved other stakeholders or it was your way of thinking that this should be done like this. I can see members already questioning that, but I would like to know how you came up with those prescriptions.
Yes, Robin over there. Last question. Then I don't know how to get the guys online. After Robin, we shall answer those questions, and then we have anyone online with a question, and we wind up. So Robin.
Okay, thank you, Chair. My question goes to Cloud about introducing, I think the pediatrician has alluded to it, introducing ethics in a staged manner. So how do you want to introduce it as a course unit, or what is in your mind? Each clinical year, you are saying that ethics should be introduced. So is it a course unit, or how are you going to do that? And then the other one is to Felix, mycology. So what steps have you taken to make sure that you are not only 3, but there are others that you are mentoring to be like you? Okay, thank you.
Okay, so I think we shall answer those questions as the people online. Oh, I see. You also had a question. Next round. Okay.
All right, thank you for the questions. Maybe to start with Professor Sebufu's question. Yeah, so probably we are only 3 because there's no university in Africa which train people in mycology. So 2 of us trained from the University of Manchester, and the other one trained from University of Aberdeen, Newcastle. I think that has been the other issues. And even still in the UK, I mean, there are only 3 universities which have specialization in medical mycology. The third one will be University of Exeter, and there are no any other universities then across the world which does the same. But of course, I've interested so many people in Uganda in terms of mycology research. I have so many people who are now budding experts in, aspergillosis or crypto or histoplasmosis, which is now my next interest. Then back to your his question, I don't remember his name, which was about the content of the courses, on that I've just not indicated there. So we covered all the spectrum of fungal diseases, from superficial ringworm to invasive fungal diseases, either occurring in transplant or, HIV, whatever risk factors. So we made sure we were as broad as possible. And then thinking about the local context, in microbiology generally, we have a saying that, if you look for it, then you will find it. So one of my big study, which I did here in Uganda, was with Dr. Lukande. I went to Dr. Lukande and said, can we get histology results of samples that you have analyzed in the past 70 years? So we started from 1952 to 2020 to look at, how many of his histological analysis yielded what? Fungal diseases. And we found 800 fungal particles, which were suggestive of invasive fungal diseases. And actually out of those, only 30% were clinically what? Suspected to be fungal diseases. In other words, 70% were missed. And then back to local epidemiology, people those days, first of all, mycology has like 2 pages in microbiology book. And then you hear about endemic fungi in the Americas, histoplasmosis or blasto somewhere in some America. But I can reassure you that from our histology review with Dr. Lukande, we found that, even the coccidioidomycosis, which you say is in California, or they are here in Uganda, but only that they did not look for them, so they couldn't find them. So basically, that is what we did. And then, of course, we also covered for the drugs which were in the essential medicine list, which were mainly the 5. But also, that most of the things that you see in the essential medicine list are driven. There are some people who drive what should be there. What is in, for example, in addition to what we have, we recently applied to the WHO, which added itraconazole and voriconazole, and those should now be available as well for us. The same as, diagnostic for fungal diseases. We cannot make a proper diagnosis if you don't have the diagnostics. And that is our next step, to advise WHO to make sure that, essential point of care diagnostics are made available to our people, and then you can make the diagnosis. Thank you.
Okay, I have 4 issues here. One was any preparation done before the curriculum was rolled out? Yes. A few lecturers were recruited because we started with first year, then they recruited a few lecturers. They trained them on delivering this curriculum, and they started running the curriculum. But as subsequent recruitments were done, the number of trainings really came down. But then the beauty is that after these findings, through the Deputy Dean Academics and the HEPI project, a lot of trainings have been done. The ones I remember, we did PBL process and student assessment. And this one, I think Professor Chiguli was around. Then we also did an online PBL. How do you conduct a PBL online with breakout sessions and whatever? Then we also went through a workshop on how to write tutorial problems. So a lot has happened after we disseminated these findings. Yes, continuous professional development. I think this has been actually really part of it. And how much time do you give each student? Now here, if you have a bigger group, 20, 30, you're supposed to balance. Every student should ideally contribute because you want to score them that they are contributing. So making these students to contribute, how much time are you going to allow them to contribute to the discussion? So it becomes challenging as the groups become bigger. But if the groups are kept smaller, every student has at least enough time to contribute to the discussion. Then here, where staff involved in the development of this curriculum, yes, staff are usually involved in the development of curriculum. But once it is implemented, it is kept as a document in AR's office, in the dean's office, sometimes even difficult to get a copy. Then the subsequent staff may not be exposed to regular training. But this sponsorship from HEPI helped us to address the key issues, which include the tutorial process, students assessment, and problem writing. Thank you.
Thank you very much. briefly, if you can answer one or two of your items.
Thank you. I'm going to combine them because some of them are overlapping. Proposing year 1 to year 5, yes. Can it be done in a better way? Yes. We can have innovative ways of doing it. But I wanted to start with the hidden curriculum. History of medicine has envisaged, when you read the history, you'll find they envisaged that medical practitioners would learn from the seniors. But yesterday and today, we have been hearing we don't have sufficient role models. So if there are no role models, where are these people going to get their learning and mentorship? And that's why experts are saying it needs to be taught. And it has to be distributed by, in relation to the situations. For example, there's 2 schools where I have taught. Ethics, medical ethics is in year 1, when the students have not been exposed to any clinical situation. So when you bring scenarios, because we are supposed to teach using vignettes depicting clinical situations. So how does the first year was just come from senior 6 relate those scenarios with the clinical situations he has not seen? So we can integrate it in the curriculum. Like if they are doing road rounds, you can say, part of it will be a vignette on a scenario, and then it becomes part of the curriculum, whether they are in pediatrics, whether they are in internal medicine, surgery, wherever they are. The institutions can work that one out and relate with the National Council, and then we see how to go about it. Did you do research? Yes, but the research was on documents and the scholarly work that has been done in this area. And like Professor Buch said, do we have it as a course unit? We can have it as a course unit, or we distribute the credit units along with the curriculum, but to make sure that the information, the propositions made are well distributed within the curriculum, so that we don't leave anything behind, and then the students are able to march along with the needs. Thank you very much.
Thank you very much. Jen, did you have any question? No. All right, great. So I think I beg to stop here. We have some more sessions, but probably as our presenters go back to seat, and the next chair comes up here, I want us to think about a question to all of us. No, I can't answer. We have another session. So as Faith comes up to do the next session, please, you can have your seat. As Faith comes to have the next session, I want us to think about these people having done research as faculty, they're doing research in medical education. Yesterday we had an issue about mindset. Faith, you're the next person. Faith is chairing the next session. As she comes up, these are medical teachers and they're doing medical research. And my question to them would have been, how did they get there? But that's probably something we shall discuss as we go through the day. How do you as a teacher get involved in medical research? How do you document what you're teaching? Faith, over to you for your session. Thank you very much.
And the last session, we were not disciplined. We did not keep time. Yes, I usually say it as I think, unfortunately. So there's a team waiting at midday, and they're actually in the US. They'll wake up at 5. So I request that at exactly midday, we break, okay, to have that session. And then it will be 1 hour. It would be good if we got 15 minutes so that we do it in 45 minutes, but you know, it is not the problem of that session. But let's do that session. If we can, 45 minutes, that's fine. If we can't, then we'll go back to complete Dr. Faith, yes. Tomorrow, Dr. Nawaji's session before we go for lunch. In some conferences, if the 10 minutes are over, they switch you off. And this is one thing that we need to learn as we move on. Thank you.
All right. Thank you so much, Prof. And you're welcome to the next session, which is about innovative student learning. At exactly midday, we'll break as instructed. So I would like to invite our next speaker, Peter Kavuma, to take us through his presentation.
Good morning. Good morning, everyone. So I'm called Peter Kavuma. I'm going to be taking you through in the next 10 minutes. This presentation on the inception of the European Research Council Certified Training in Uganda. So this is a project that is sponsored and partnered with those institutions that you see. So we have AGNF, which is an emergency care training institution in Germany. We have a hospital partnership, that is an institution that gets funding through GIZ, which is the German government, the European Research Council, and Makerere University, College of Biosciences to be specific. So the facets of this project is around emergency care, critical care, and resuscitation, which is according to these figures here. If you can see, the incidence is the prevalence of sudden cardiac arrest in hospital is quite alarming, especially in our setting. You can see there's a study that was done by a team, Ochen et al., that showed, and this was in 2018, thereabout, showed the prevalence of in-hospital sudden cardiac arrest to be at around 2.5% compared to figures in other countries such as the UK, that is at around 0.16%. And despite these happening, interventions occurring, return of spontaneous saturation, if an intervention such as CPR was done, only happened in 7.5% in Uganda compared to higher rates in the 18.4% in other countries like the UK. And the biggest contributor to this discrepancy is basically lack of knowledge and skills in intervening in this kind of a situation of cardiac arrest. And this is further manifested as failure to recognize cardiac arrest. You don't know whether someone is arrested. We don't really have those monitoring systems. If you don't know, you cannot really initiate CPR. CPR is cardiopulmonary resuscitation, and you cannot do early defibrillation. It has been proven by research to be one of the interventions that improve outcomes for cardiac arrest. So this project, like I said, is funded by many partners, but our parent affiliation is through the European Research Council, which is a body that has a mission to preserve human life by making high-quality resuscitation available for all. For people that don't know what these associations do, they basically deal with resuscitative medicine. We've heard about resuscitation and critical care. So they all are under an international body called the International Liaison Committee on Resuscitation that has bodies such as the American Heart Association, Resuscitation UK, et cetera. Among these is also the European Resuscitation Council. So these bodies are charged to put out guidelines on recommendations on resuscitation, as well as put out trainings to standardize care for people that have cardiac arrest. So the objective for this project were the following. So I wanted to establish an independent European Resuscitation Council course center in Uganda that is responsible to put out faculty according to these to the ERC standards, train providers in ERC courses, which I'll mention in a few. So ERC has a bunch of courses, both pediatrics and adult courses. And among these, we have the advanced life support, the immediate life support, and basic life support. I think people are more familiar with the basic life support and the advanced life support. The pediatrics also has the same continuum of courses. both from basic to advanced, as well as the trauma courses. And these are all standardized courses and have been approved internationally. So third objective was to also create a national resuscitation council that will oversee such kind of efforts in Uganda, because this is where countries are going. Most countries have resuscitation council that has contributions from different societies to overlook resuscitation efforts. So we set out in late 2019, December, to establish, to work around these objectives. The first was to do a rollout to get initial faculty to train these courses. Second was to develop more advanced faculty that will oversee the trainers and do more trainings for local providers here in the country. And the third was to establish an independent center that will run these courses independent of the international body. And these are some of the results. You can see we have done quite a lot in phase one. We have, we did a bunch of courses that provided us around 107 ALS or ILS providers. We got around 16 instructors throughout this. And for this phase, Makerere University College of Sciences was accredited as a training venue for these ERC courses. Phase two, which was the later part of 2020 with COVID, we managed to train more people in the tune of 378 providers in these courses and got more local faculty trained. As well, we got course directors for these courses, because the way these courses work, there's a continuum of faculty. We have the facilitators, then we have the course directors that oversee the facilitators as these courses are ongoing. Recently, this year, we also established a training center, because these courses also have to have a home that is run by a full set of an administrative unit and faculty that are housed here that are tasked to oversee the development of this training of these courses. So we hope to do so many things. We hope to spearhead the creation of a National Resuscitation Council. The Uganda Heart Institute has had interest in this and have pledged to work with us to create a National Resuscitation Council, as well as do more courses and bring on board the pediatric and trauma courses, respectively, because in our situation, trauma and pediatrics are very key areas to concentrate on. So in conclusion, resuscitation science is very important across all fields. And I'm not here talking about one field, pediatrics, internal medicine, surgery, obs and gyne. Everyone needs to know, have some skills in resuscitating their life, because we all have those patients that become critical at one point and we need to know how to intervene. So thank you.
Thank you so much, Peter Kavuma. I think we shall reserve the questions for during lunchtime. You can reach out to him. And we should get the next presenter, Blaise Chimba. Is he in the room? Thank you.
Thank you. Good afternoon, everyone. My name is Blaise Chimba. I'm a medical student from Makerere University. I thank everyone for being around, and I like the theme of the conference. So I'm here to present our project, which we did in northeastern Uganda, Karamoja region, Kabong district. It's promoting hand washing practices within households in Kapilanba West Village. So I did it with other colleagues of mine under supervision and mentorship by the hospital superintendent. So we focused on hand washing practices because of some reasons. I have a simple background, which says that proper hand washing has been found to be a strong pillar in international development and public health, as it improves education, nutrition, health, among other things. That's according to the Global Hand Washing Partnership 2017. The problem why we mainly focused here was because during our placement at the hospital in the district, we realized that among different diseases which the cases the hospital was getting, there was an abnormally high rate of diarrhea diseases as long as respiratory infections. And we decided to do a simple community diagnosis, which found out that generally hygiene and sanitation practices were very low. This one was augmented by another study which was done by UNICEF in 2019 still, and it found out that sanitation and hygiene practices were still at 40% compared to the national level of 79%. That was in Karamoja region. So we got an objective of promoting hand washing practices among people in the village. We employed methods for our project. So we first did a pre-implementation survey to really confirm that this is a problem. And in that survey, it gave us a really good picture because besides the behaviors, also things like the hand washing facilities like tippy taps in the village, among others, were really very low. So we decided to do mass mobilization by the use of local community leaders. Then we staged 3 hand hygiene education sessions in 3 different places in the market, at the LOC1 and LOC2 areas. Then we did, each session had 2 hours, and averagely we got about 35 attendees in each of the sessions. Our emphasis per session was on the relevance and standard steps of hand hygiene, tippy tap construction use, maintenance, 10 tippy tap construction, and we ended by giving out tippy tap construction materials to 6 active members during the session. Then we assessed our project, both pre and post, to assess its effect. Results, there was a general increase in knowledge, which was assessed using the epistemic method. Knowledge was high among hygiene-related diseases. The most understood were diarrhea, dysentery, and respiratory diseases. And then the least understood was hepatitis E, though they had had a previous history of an outbreak in the area. The standard time and steps of hand washing knowledge was also increased. Tippy tap construction increased, and we ended up with the prevalence of 23% in the village. And those were like the immediate outcomes. We observed an increase in the tippy tap use and the general increase in the hand washing in the place. That was one of the pictures. So we concluded and recommended that knowledge concerning hand hygiene increased. Then plus the number of hand washing facilities. However, we also realized that providing construction materials encourages tippy tap construction, because out of the 18 people we gave, at least 11 managed to construct, 2 didn't construct at the end of our assessment. So we recommended that future research should be done in terms of hand hygiene in the area to assess more whether there is any change. Then more tippy tap construction materials and other wash-related programs should be extended by any possible funders. Thank you. I acknowledge HEPI and Makerere University for the time granted and the opportunity.
Thank you so much. We have like 6 minutes. Should we take questions, or should we have the next speaker for 6 minutes? I think so. Yes, let's have Miss Lydia Namimba. Let's give her 8 minutes to be realistic. Yes.
Are you serious? No, he doesn't see the presentation, so he's saying probably we could do question and answer as he's looking for it.
Jonathan.
Or the next presenter.
Jonathan Kalwood. It's almost, okay, let's do the questions for the other.
Yes.
The other two. But
So-
also quickly, I have some questions and comments. Thank you very much, Dr. Peter Kavuma and Blaise Chiyimba. Comments, Blaise, I think this was this a COBAS project? Okay. This is very useful for the students to be involved in what is happening in the community. And I commend you for the work you did in Kabong. Dr. Kavuma, thank you for that work. The trainings you offer at that center and you've been offering, are they free? Do people have to pay? Because if it's not free, then what can be done to make this feasible? If it's not free, then we may not reach many or we may not sustain. As a matter of information, I think about 30 years back, is it that? About 96, I don't know how much that, we had advanced pediatric life support and basic. So the model was trainers came from UK, they trained faculty and other people as trainers. We are certified, and then we would continue the training. But sometimes with many changes, things die. So, and I wonder why pediatrics was the last, and yet more than 50% of our population is children. Thank you.
Thank you very much to our presenters. I would like, first of all, to commend Blaise. If you start presenting your work as a student, you really have a great trajectory in front of you, and that was really a good piece of work. And thank you for presenting it. That was just a comment. For Peter Kavuma, that is also great work being done in our community. My question is, who are the people who are being trained? And if it is under Makerere, is there a way of integrating that into the curriculum for undergraduates and postgraduates, and also continuous professional development for our faculty and also other health professionals, so that this can be sustained? There's a need for sustainability, because now I also that center, which is it under Makerere? Is it being a separate entity altogether? Thank you.
I think because of time, let's just take these questions and let's have Kavuma answer some of these questions.
Thank you so much for the questions. I'll just quickly run because the time is on our side. So are the courses free? No, they're not free. So for sustainability purposes, we had to cost these. Because if you're offering this freely, you cannot really sustain. Because so for advanced life support, and our costing was based on a cost. So for ALS, it is at 450,000, and it is a 1 month course. So it has an online and hands-on component. So online is self-paced for 4 weeks, and you come in for 2 days hands-on, intense hands-on. For the others, lower course ILS 250 and BLS is 150. Sorry? No, Uganda 150,000 Ugandan shillings. So
Alright.
this, and if you do an analysis of how these courses are costing across Africa and Europe, we're actually one of the cheapest centers across Africa for countries that are offering this. Because I can tell you, in East Africa, we're only center offering this. The nearest will be South Africa or Egypt or Sudan. For why PIDS last? PIDS was a bit complicated because of a committee that was concerned with rolling it out in other countries. So decided to first go general with basic life support, advanced life support, and ALS for now. But I'm actually sitting next to a person I engaged at the Department of Pediatrics to see that we can actually do something through the Department of Pediatrics at Makerere University to ensure that these are come back to the university. He's shaking his head, so he's in agreement.
All right, thank you so much. We truly appreciate your work. I would like to hand over to the next moderator, Professor Elsie Shiguli.
Thank you, Faith, and the previous presenters. Good afternoon. We have a very interesting session coming on. It is about simulation-based education. And we have international guests online. I don't know if they are there. We are privileged to have Virginia Ginger Sherik from Yale University, Michelle Teofa from Yale University, and then we have Agnes Ogwang from Clark International University, and Professor Robert Opoka from Makerere University. For those who are here, maybe you could come in front. And then the IT team, do we have our international guests on?
Yes.
Oh, great. Welcome. Thank you so much for waking up early and joining us. And we are going to begin as soon as Agnes and myself take our seats. So I think this is really an interesting topic because I've had so many discussions and people are saying, why should we use simulation, especially in our context where there are so many patients and the patients are willing to participate in training of students. So maybe to begin off with, I would like to, so that we set the context of the discussion, I'd like to ask Virginia, our guest, what is could you please define simulation in the learning context so that we set the context and begin the discussion? Thank you.
So simulation is an experiential learning process. And that gives us an opportunity as educators to let students have an opportunity to actually immerse themselves into a clinical setting, into what we consider an outpatient setting that they wouldn't normally have, instead of just having that classroom experience or learning it through the book, through theory. So it's a bridge between what they're reading and what they're learning in that classroom to actually doing in clinical. It's a little more of a higher form of doing skills lab, and doing that hands-on, because it's taking the opportunity to do knowledge and comprehensive work, but actually apply it and do analysis work, and eventually be able to do things where they could be creating new scenarios and apply it in those situations. So it's much more experiential. And I think it's the next thing we're going to be talking about is why it's so important to use this type of learning experience.
Okay, thank you, Virginia. I would like to request you to give us an example of a scenario where you use simulation, and then we can go on to the next. I'll ask somebody else to take the next question, if you don't mind.
So we use simulation in all contexts. We use simulation in every one of our clinical courses. So we use it in our medical surgical course, our psychiatric mental health courses. We use it in our childbearing family course or maternity courses. We use it in pediatrics, and we use it for the context of providing an opportunity for giving the students the means to be able to practice not on the patients. That's very important to us because we feel you shouldn't be practicing on patients. You should be practicing before you're taking care of patients. And the main reason is you can equate it to professional musicians or professional sports players. You would never show up to the game or to the concert without practicing. So the expectation is that you should not be practicing on patients. You should be giving patients the highest level of care that you possibly can, because you still can make mistakes when you're in school, and you shouldn't be making those mistakes on patients. You have the opportunity to make a mistake in a safe learning environment and be given feedback from your instructors without causing harm.
Thank you very much.
Yeah,
Okay.
so I was just going to say, so I know that's a very broad answer, but if it was in medical surgical nursing, we would choose those things based on a lot of different factors. And it could be everything from wanting to focus on a urological area that we felt was important. It could be on a cardiovascular disease process. It could be on how to draw labs. It could be on making a prioritization of you have 4 patients that you need to take care of and who should you go see first. So simulation can be used on a lot of different levels.
Okay, thank you very much, Virginia. I would like now to come back here and ask Robert. You know, this has been said, as I said at the beginning, that we have patients, we have enough of them, and they are willing to be practiced on by patients, by students. At the same time, it also costs us more to use simulation. So what do you have to say about that? So why are we using simulation in our context?
Thank you. Thank you. Again, I'm Robert Opoka from College of Health Sciences. I work in the pediatrics department. So yes, it is really true that here in resource-limited countries, settings, Uganda, other countries, we have many patients. Our wards are full. We have lots of pathology. So many patients, many pathology, and the argument normally is made that then where do you need to do simulation? And again, just to rephrase and paraphrase, simulation is you are creating an artificial situation that resembles the real case. So you're using something which is something rather than the real case to achieve educational goals for learning, for acquisition of skills. And I mean, like yesterday we were saying, we need to move on. I think we cannot keep on doing the same old things in the past. I think medical education needs to move on. We need to move to the challenges. And the reality now is that we have many students on the ward. We want them to get early clinical exposure. We want them to get standardized education so that we have enough, the same skills. And this is where simulation comes in. It is very good for the transition from the preclinical to the clinical. So by the time that they come to the wards, they have practiced and they know. They have acquired some of these skills, okay? And although we have patients, we must think about patient safety. We can't afford to, because we have patients, then everybody must come and try and error, on the same patients, okay? And now we have many students, and so we can no longer use that same method. So for patient safety, for standardization, in some cases, you want to learn to do a pulse, or you want to learn a condition. And at that time, that condition may not be available on the ward, So to be ensured that everybody gets that skill, the better way is when you have simulation, because then you can plan the session, you can know what skills are supposed to be acquired, and you're not limited by where the patient is there or not. And then for some of the rare and complex diseases, or some of the very severe diseases, like my friend was talking about first aid, you cannot begin practicing CPR on a real patient. I mean, it's unacceptable at all, Yeah, because by the time you go do a CPR, you must have your skills ready. So there are very many examples and the many advantages why we really need to do simulation. And I think simulation is the way for us to go, to manage our big numbers, to improve our quality. And literature actually shows that with simulation, there's improved clinical skills, both to the simulator and even to the real patients, and the adaptability is quite good.
Thank you very much, Robert. I would like now to go back to the US. This is being very easy flying to the US within a few seconds. So I would like to ask Michelle. So when we've used this simulation-based learning, how do we assess that the students have acquired skills? What are the best ways to assess acquisition of skills? Thank you.
It'll be based on the objectives for your simulation. So before you design your simulation, you'll come up with your objectives of what your learning goals are. And then based on that, you'll create the simulation around that. And then following the simulation, there's always the debrief, and that's really the kind of the biggest part of the simulation. The simulation itself may only last 10 or 15 minutes, but the debrief usually lasts 20 to 30 minutes. And that's really where the majority of the learning comes in, where the students are able to think through what they did through the simulation, what they could have done better, what they think they did well, and to really kind of be in a safe environment to process the learning that they did. And it'll depend on the simulation. So there are high stakes and low stakes simulations. So if you may have a high stakes simulation where you really want to test somebody, such as like on an OSCE, and that's going to be a little bit different. So you will have clear objectives and things that you want the students to do. And if they don't do that, then you would assess them based on that. Whereas if it's more of a formative or a lower stakes simulation, that's going to be one that just really wanting them to learn, and you're not so much grading them, but to kind of bring them through that experience so that they have more confidence, so that they can then go to the ward and work with a patient and gain that confidence. But there's different tools that you can use, and Ginger and my other colleagues there in Uganda, I'm sure, can speak to some of the tools that are used for the evaluation.
Thank you very much. I'll come to Agnes from Clark University and ask, in our low resource setting, I know Clark University is private and it has a bit more resources than probably some of our government or public institutions. So how have you used simulation-based learning at Clark University?
Thank you, Professor. I need to first dispute
the fact that you are saying Clark International University Skills Lab is well equipped. We are still in need of more equipment. But I'm glad to also appreciate that you have noticed we have a good skills lab. So at Clark International University, of course, we've also been doing the traditional competence-based learning with the coming on of HEPI. We embraced simulation-based learning, and I think we have been one of the institutions at the forefront of getting capacity building for our staff. So given the limited resources, would appreciate that we use low technology measures. We call it low tech because it's not a programmed, we don't have a programmed simulator, but we can use something that is available and then take students through with given or selected scenarios. So that's how we do it. And of course, we appreciate that once the students are given prior information about what is going to be done, then the students are able to read. They are prepared prior to the simulation, so they take on prior reading before the session, and then as they come, still the instructor takes them through a brief of what the scenario is all about. Some aspects of the scenario are shared while others are not, so that we check how students are able to discover those unrevealed probably complaints or concerns. And of course, therefore, these students are taken through by the instructor on the different steps of either assessment, whatever the procedure is, they are taken on, and eventually they will be now subjected to performing like a return demonstration, which they do. And of course, this is guided by learning guides or a checklist, which is very important, because when Ginger was talking about simulation-based learning, we don't need to divert the students. They need to be focused, and therefore the objectives that they intend to acquire in that given session are met. So that's how we do it, and therefore the students go on and take on the procedure. Once they get to that level of proficiency, or when they feel, when the competence is picked out, then it's recorded. The ICT team comes and does the recording, and once this recording is taken on, it's kept until after the debrief. After the debrief is when now they are able to watch what was taken. And eventually, we are making a pool of video clips, which will be posted into our university YouTube. So students can be able to view these procedures, and of course, it helps subsequent groups of students to understand how simulation is done. Thank you.
Thank you very much, Agnes. And that's really great to hear that we are actually putting this into practice in our context. I would like to go back to Virginia and say, usually our curricula are in silos. We teach pediatrics, then we go to internal medicine, then surgery. How do you integrate simulation-based learning into your curricula? And how do you plan your schemes of work? Is it also in silos, or do you have an integrated way of doing it?
If I understand exactly what you're asking, the courses are still siloed, but the concepts are still, followed through. So we start with med-surg, medical surgical nursing is the first one, which incorporates fundamentals. In our university, fundamentals of nursing, which would include things like bed making and bed baths and vital signs, those concepts are incorporated within our medical surgical nursing course. At other universities in the United States, that's actually a first course. So that information would be provided in a skill lab through simulation, and then it would be placed into med-surg, and then those skills would be scaffolded. So anything that they then learn and experience through a simulation in medical surgical nursing, and then at the same time, they're taking their pharmacology courses and their anatomy and physiology courses, and they have a pathophysiology course. So all of that information is now fair game. So we can make a simulation that is having them put all of that knowledge together. Then that information goes forward into their pediatric course and their childbearing family courses in the next semester. So it's constantly building upon each other so that by the time they get to their last semester, that we're able to, I know I'm frozen. Can you still hear me?
Yes, yes,
okay.
we can hear you well.
So that in their last course is our community health course, there is an expectation that they're able to synthesize their skills that they have learned across the year, but also the leadership expectations, the assessment of the community. So it gives this opportunity for the faculty to look at, are these students able to move forward? It's very similar to what was just described, where you're ensuring that they are competent in these particular areas and not allowing them to progress unless they're ready to, but also if you identify areas that there are still weaknesses with a student, you can address it within that course. And we would bring them back into the lab to say, we need to continue to work on this skill, or we need to continue to work on this in clinical, because now we know that it's an area they need more experiences to work with patients on this particular topic. Did I answer the
Yes.
question? Okay.
Yes, thank you very much. I would like to pose the same question to Robert. In our setting, now for you it's Makerere, we still teach in silos, and that we've thought about it before to see how we can integrate some of these things that are actually run through all these courses. But you learn about TB in pediatrics, Then you go TB in a pregnant woman, TB, you know, that kind of approach. And when it comes to these aspects that we want to use simulation-based learning, how are we going about it in the College of Health Sciences?
Thank you. Thank you. We're not doing so well, unfortunately. We're still stuck in our silos at the College of Health Sciences, and people are doing. And we had tried actually to integrate when PBL came in. I remember the biomedical sciences were integrated. There was early clinical exposure. You could see the patients, you could see the students early, but it looks like we are reverting back to our old ways, unfortunately. But I think it's an opportunity for us to discuss how we can integrate more. I think we have developed a skills lab at the College of Health Sciences where we had hoped that in the early clinical years, students would come and learn some of these clinical skills. So by the time they come to the ward, they have some skills that they can use for their clinical clerkships. But it is there. Is it going forward? Is it going backwards? We are still at a flux. In pediatrics, we, I think, do slightly better. Of course, we do better in pediatrics. We do slightly better. We have actually taken on simulation quite a lot. We have it in at least the resuscitation courses for newborn. We normally do simulation. We have mannequins that we use to teach our students how to do newborn care and newborn resuscitation. We have a whole course which is called ETAT, Emergency Triage Assessment and Treatment, that we give to our learners, both the undergraduates and the postgraduates when they come in. And we use a lot of simulation in that course. It's a few days course. And we teach them how to do triaging and how to do resuscitation using simulation. And they like it. They normally, the feedback get is very, very good. And also we innovative, of course, use simulation in assessment. The OSCEs. It's a mix. We use real patients, and where we're not able to get real patients, we use simulation, especially for the difficult, for role plays, and also for the emergency skills. We use simulation. So I think it's a good big opportunity for us as educators to use more simulation in our setting. And yesterday, a professor was calling us to have a call to action. I think this may be one of the call to action that we can take as a conference, that maybe we should agree as, you know, in this conference, that we should maybe use more simulation and incorporate it in our trainings.
Thank you very much. And I think, to me, pediatrics really needs this. I can't imagine starting on a baby, bringing in a student to actually learn some of these things on a baby. So thank you so much for introducing that. For pediatrics is very important, but it is important all across what we do. And as he says, I think this is a great opportunity, and we should do all the universities represented here. I hope you are taking this on, like Clark and Makerere University, and of course, Yale University has been doing this for a very long time. Now, I would like to open it out to the people who are here. If you have some questions, comments, somebody is so eager. Scovia is very eager. And one thing I've noticed is that nursing has actually used simulation for a long time, even in our context here. They seem to be leading. I don't know if it's the case even in Yale University, but then nurses have taken this on, taken on simulation-based learning quite well. So Scovia, please give Scovia a microphone, and then she gives her comment or question.
Thank you so much First, I want to thank Michelle and Ginger for joining us. I know we've just woken you up to join this session. We really do appreciate that. My comment, and I would like Ginger and Michelle to share with us. Yesterday, we had a session on interprofessional education, and we really know that in actual clinical practice, we have different professionals working on this particular client. And you have said simulation is, and also Dr. Poka, you've highlighted that it's a bridge between class and clinical work. So I'm just asking, I know, Ginger, you're the director of the simulation in Yale, the nursing department, but do you ever have a simulation where you bring in other professionals, like for example, the doctor and all that, and you play it out so that they can understand their roles and responsibility as they go into the clinical work? Thank you.
Thank you very much. Great question. Please go ahead, Ginger, and give an answer.
Sure, I'll answer it, and then I don't know if Michelle will have anything to add specifically to this, because I do know that the midwifery department does have an interprofessional simulation as well. I just don't know if Michelle is familiar with that particular one. But we do have not only a simulation, we actually have a course that our students take in combination with the med school and our physician associate program. So the students, it's a very unique course. There's only, last I knew, I think 10 in the entire country, universities that have this course, where all of these first-year nursing, first-year med students, and first-year physician associate students take together to really have the opportunity to learn teamwork and learn empathy, as well as understanding of what all of these professions actually do and bring to clinical together. So they attend clinical together. They actually have a clinical rotation together. But in addition to that, they do have simulations. So they have 3 simulations through the year. Because there's 250 students that are coming through our simulation center that take these courses. And again, it's a scaffold. So that first simulation is them working together as a team to go in to see the patient, and they're only doing a history in the first one. The second one is a more in-depth history with a physical, and the last one is a history, a physical, and then a diagnosis and a plan. So again, it's building upon each other as they go forward. So we definitely do that. And then one of the other ones that we do is having our own nurses in the same specialty, so that the nurses and then our nurse practitioners, so they're at 2 different levels, are utilizing the opportunity to, it's a birthing scenario where there are students working at the registered nurse level, and then our midwifery students are working together in the same scenario. And then the other one is the one I don't know if Michelle is aware of, for the cesarean. Did you know that one, Michelle?
No, but there is one that we do at the hospital, and it's part of the ongoing hospital learning that we do for shoulder dystocias, and that is interprofessional. So we will come together with physicians, nurses, midwives, because shoulder dystocias don't happen that often, and we'll do sort of a team-based simulation. We do that once, I think it's once every 2 years. We all have to, everyone, all the staff in the hospital that works on the maternity unit has to go through that one.
So one of our, it's actually our specialty director has an OBGYN, so it has a physician come into the school to help with a cesarean in terms of not in the actual operating room, but through that process of when to call for a physician into the room, and then brings the students to the area and goes through what that assessment and what those needs would be. So I am not directly involved in that one, so I can't really speak too much. I just know that that is another one where there is a collaboration with two different levels of care that are needed. So yes, we definitely do that as well.
Thank you very much. Maybe if Robert or Agnes would like to say, do you do any integrated simulation-based learning in Makerere or at Clark University, where you have other professionals come and work with you? Okay, thank you very much. It's not being done yet in most of our universities, but Agnes would like to say something, then we'll go on to Faith.
Interdepartmental clinicals are often scheduled, especially for first years, because during first year, you find that nurses are also doing what we call clinical nursing skills. And then you find also allied health students are also doing similar content. So to avoid duplicating and increasing workload for the instructor, it's always good to have them together for that 1 year.
So that's actually happening, and that's one of the advantages of interprofessional education. You reduce on the workload for the instructors. Let's have Faith, then we'll have Sarah. Let's be quick, please, with the microphone. Sorry, we have to sanitize.
Yes.
Okay, Faith, please.
All right, thank you so much. And my question goes to the local team and the team from Yale. The first one is, are your simulation centers accredited? And if so, how is that done? What's the process? Then to our local team, do we need to accredit our local simulation centers? And what is it that we can focus on that is in our capacity? Thank you.
Good, Faith. We'll go to Yale first. Who is going to respond to that?
I would suppose I would be the one to respond to that one. So we are not currently accredited. We are in the process of accreditation. It is a laborious process. It is through the Society for Simulation in Healthcare. That is the group that provides certificate or accreditation. And you can go online. Everything that you would need to know about the accreditation process is online and available to any university or any center that would be interested in going for accreditation. I would highly recommend downloading the information and going through all of it, because what it does is it sets you up for best practices. Even if you decide not to actually try to get accreditation, it shows you what things you should be doing in terms of providing the simulations, how to provide the simulations, what information you should be capturing with your evaluations, what information you should be capturing on your metrics regarding your ratios of faculty and facilitators and training. You do not need to have high fidelity mannequins. People are under this assumption that having a lot of technology is what makes you an excellent simulation program or an excellent simulation center. And that is absolutely not true. It is how your simulations are designed and how they are executed and how they are evaluated. So having that information from SSH helps support what you are doing, and will show you what you are not doing and where to make the changes in your program. So we're on our way to what they are expecting, but it's more that it's taken us a while because we need to get everything in order. But you do not have to have this glorious looking simulation center to get accredited at all.
Thank you very much. Any comments from Agnes or?
I just want to, I like a comment that that it is not really the high fidelity mannequins that makes simulation very good, but the other things that she has mentioned. So really, I think that is very encouraging for us that we can still do simulation with whatever we have here. And of course, I'm not sure. I don't think, Professor, that we are accredited anywhere. but I know whether I'm comfortable that even there and they're not accredited. But I like the idea also that maybe we should download that thing and see how we can improve our process. I think we are set at a lower stage. We need to get simulation off the ground, and then we can think of things like accreditation later in the day.
I remember when we started simulation, we started really low fidelity, taking students to start with first years how to take a pause, and they would partner. You get a partner it didn't have to be a very special place, and that's how they would start when we were beginning, when we had changed our curriculum around 2003. When we started simulation, we would start with those, how to take a BP. They would take the BP on themselves, and we would continue. So low fidelity to begin with, I think it works. Sarah, please.
Okay, thank you very much. Yeah, let me stand, because that is another area that stole my heart. At that time, it was not called simulation. I don't know if it was there in the literature. When we went to Maastricht, 2004, no, 2000, as we were developing the PBA or before. And they talk about skills training, skills lab. I know Virginia said simulation is beyond, but at that time we're at that level. And the gentleman I went with, no one understood what it was. So they said, you go there. And I went and the journey started. But to come back, yes, we are not accredited, but probably we should download and see where we are. But we should start small. Start with whatever we have and then build up what we have. I wanted just to mention that I said in addition to integrating, but also interprofessional education, which we can do even at the medical school at Makerere, but also students to learn some other competencies that are important: communication, teamwork, leadership, through the scenario that they're doing if they're working together. We can actually have it, and we had designed something that was integrating, building, but I think we have someone running that place. And this is something, if we commit, we can actually go back and see that we even improve on what we had. Bob, what you are doing, is it accredited in some parts? Because the trainers have to be people who have gone through, and also you have that strict evaluation, strict way of doing things so that you do it the same, whoever is doing it. So I think this is what we need. Can we make an effort in our different institutions to see that simulation is off the ground I know that at Clark it is off, but also it seems to be off in nursing departments, and nursing is leaving us. So can the nurse educators here lead? I know that that team from US has been supporting, and actually we have been laid back, and they are willing to take us through online training so that we go and reach a point and we can commit to have that. If all of us in this room attended, it's online, it doesn't matter. All of us can attend and see what we pick as we go forward. And when we design those scenarios, we design them for the medical students, for the nursing students, for the senior house officers, ops and pediatrics. Okay. Anyway, I'll stop here. Thank you very much.
Thank you, Sarah. Dr. Sebufu Professor Sebufu had something. Would like to hear from other universities. You have something. This is very interesting, but we are running out of time. So, okay.
Thank you, Chair. I'm Robinson Sebufu from KIU. We actually have a simulation lab, or it started as a skills lab, and then a simulation, though Mbarara, I think, is a little bit ahead of us when it comes for, well, the simulation lab is for each discipline. That is mainly surgery and obs and gyne, and a bit of pediatrics for resuscitation. However, I wanted to pick on what you said, that actually we have patients and they are also they are willing to be worked on by students, and the cost or simulation equipment is very high. Maybe if we reflect on how we've been treating patients, or how we learned, or how we acquired the skill, what the damage we did before you acquired that skill. That is one. Two, also, when you look at our patients' rights, very few of them actually know their rights. But now when you look at the cases that are coming to medical council, it shows that actually people are picking up. So my request is to go for simulation lab rather than acquiring skills using patients. Thank you.
Thank you very much. So we hear all these universities are actually at some level. We are running out of time. So I'm going to give each of our panelists at least 1.5 minutes to say something, then we will end this session. And I will begin with Virginia. Please, a last comment.
Just to echo the sentiments that I feel simulation is absolutely the way of the future for all healthcare education in all of the disciplines. It's an opportunity for students to practice without harm. It is a safe learning environment for the patients, but it's also a safe learning environment for the students as well. It's psychologically safe so that they can make mistakes without hurting somebody, and an opportunity to be able to be corrected, but also an opportunity for them to learn themselves through that reflective process. And that to me is really the most important piece. And it can be done through very low fidelity ways by using things that are readily available. We use foods as props that we remake into different things. Michelle and I were talking last night about how we use papayas as uteruses. We go shopping to recreate pregnancy abdomens or pregnancy bellies out of cloth and cotton. I make hernias out of different things. So we really take an opportunity to recreate things without purchasing those very expensive items that look great in the catalogs and online, but they're not always the most economical purchases. So we don't always do things like that. At least in my department, we do not do that. But I did want to make one response real quick in my minute to something Robert had said. And it was in regards to the curriculum piece. And I think there is a way that when you have everybody in silos, the simulation group or simulation in general is a great way to be able to take a curriculum map and identify where things are being done in silos and give an opportunity to start to do that scaffolding and say, you've already accomplished this in this course that was in the beginning. We don't need to do this again. And if you really want to do this, like Foley catheterization in another course, let's look at the reason behind why you want to do it. Does it need to be repeated, or does it need to be, do we need to elevate the objective in terms of what you're doing? Is it just a skill, or now is it an application where you want them to make some decision making? So a curriculum map specifically with simulation matching the curriculum map of the courses can really fix part of that problem.
Thank you very much. That's very good advice. A last comment from Michelle.
I don't have too much more to add. I think one of the things we didn't talk about that doesn't require a lot of equipment or anything is one thing that we had to do last summer when the pandemic hit and our students were pulled out of clinical, is we really worked over Zoom. And you can do this just person to person on their counseling skills and on history taking. And so we would give them a scenario, and then they would have to work on how to do counseling or how to deliver difficult news. And that's something that a lot of our students struggle with, and just having these very basic conversations with patients. And so you don't always, like Ginger said, and others have commented, you don't need the high fidelity equipment. And it's really just to give students a safe place to practice these skills that they need on the wards.
Okay, thank you very much. Robert, the last comment.
Yeah, and one of the things that we have learned in this conference is that we should not use yesterday methods to train tomorrow's health workers. And I think the way to go really is simulation, something that we have to adopt going forward. Because we didn't do it in our time, doesn't excuse us from not doing it now for the next generation of health workers. So that's a point I think we should take. The other thing is that I think we can be creative. I think we can be innovative. In our ETAT courses for the intraosseous needle, intraosseous insertions, we use chicken thighs. And I didn't know that before I did that course, that you can use chicken thighs to learn how to put an intraosseous needle. It works perfectly. So before you eat your chicken, please try to put a needle through it to help you when you come to the emergency ward. So we can be really creative. We can be creative to get models and to get things we can use for simulation. The last thing, of course, is that we focus so much on clinical skills and knowledge, and forgetting the other skills: communication, professionalism, ethics, interpretation. And I think simulation would be a great way to teach some of those skills. For example, like talking about breaking bad news, you can practice on a real case, and yet it's very, very easy to do that in a simulation, in a simulation environment, so that by the time you get to that unfortunate situation, you are well equipped. Yeah, so simulation is there for us to go. Thank you.
Thank you very much. Last minute, last comment from Agnes.
I would gladly say that simulation is the way to go. I remember when we were making one simulation scenario, I tasked the student to reassure the dummy. Remember, you are talking to a dummy. And I was like, I want you to reassure this Madame Zoe about what you are going to do. The student first looked at me and was like, okay, so how do I start? I said, the way you talk with your patients, you know? So I think simulation unpacks the fears that students have and help them build confidence in how they interact, because that's a beginning, that's a starting point for them to interact with the real patients. So if they are told to start interacting with a dummy, then they will develop good communication skills. And this also applies to the attitude, how you handle, how do you turn, how do you lift, how do you provide privacy. All these are incorporated in simulation. So I think I know there are leaders representing institutions here. I think each of us has a task to play in advocating for budgets. In every budget, try to purchase affordable materials, items that can enhance skills acquisition by our students. And then lastly, it's important for us to foster interinstitutional partnerships, because I am aware that Mbarara University has the best so far simulation lab. And therefore, if we could foster partnerships, do collaborations, we'll use them as points of us also to learn together. Thank you so much.
Thank you very much. I'd like to thank our panelists. Thank you very much from Yale. We really appreciate you waking up very early in the morning to join us, and you've given us very useful tips. I'd like to thank Robert and Agnes for their participation, and all of you for participating in this. And I like what Robert has said. One of our calls for action for this conference is to look at our simulation in the different schools and see that we move it to a higher level. I like also what Agnes has said, that we can do actually collaboration partnerships. We have a good partnership. We have our colleagues from Yale, I understand, working together with the Makerere and all these other institutions. So let us take this partnership and utilize it to make ourselves better. So thank you very much. I don't know if you are going back to bed in here or starting your day. Have a good day. And I think for us, we are going for lunch. Thank you very much for this session. It has been a great session.
Have 30 minutes, there are 4 presenters, 8 minutes per presenter. Yeah, let's have 8 minutes, and then we can have, we'll do 30 minutes presentation, and then we'll do about 30 minutes discussion, and we go and have lunch by around, let's just start at 5 plus 25 minutes. Is that right? Yes. So,
Sure. But we had a few questions that were pending for Dr. All right.
Thank you, Faith, so much. My name is Namwimbwa Lydia from Kavala University School of Medicine. I work with the Department of Physiology and I'm a HEPI fellow, currently doing my PhD in medical education. So the topic I'm going to present is strengthening the connection between health professions education and practices, experiences from a rural setting in Uganda. So that's the Western region. So I'll briefly talk about the background. Health professions are expected to be lifelong learners as regards updating their knowledge in relation to the new innovations in science, treatment, and management of medical conditions. So you agree with me, health workers are meant to be lifelong learners. And you also agree with the previous speakers from the limited resource areas like Kabale, like the West Chigezi, you find that the distribution of health workers is basically minimal. Most people prefer working within the towns, Kampala, they don't want to go to the rural, apart from some of us. So it so happens that you find that the health workers there are really few, but the constant factor remains that patient load remains high. So you find that the health workers actually have a lot to do, but less time to continuously read. So, however, due to the poor staffing of hospitals in rural settings and the high patient burden, it is uncommon for the health providers to find time to update their knowledge regarding the different health conditions. We are all aware that health system, medical field is a constantly changing dynamic area. We always have new regimens, new innovations, new research, evidence-based practice from different therapies. So you find that I agree with you that, of course, some hospitals try to put in place CMEs, but poor habits of health workers, few of them can attend. And some of them actually don't get opportunities to go and attend maybe conferences where they are going to be taught about the new innovations. So it is therefore important for in-service health workers to keep up to date with the new innovations in science so as to provide better patient care and management outcomes. So we set to evaluate the effectiveness of health professional education on practice among the in-service health workers in Kawale district. So I'll put a disclaimer, this is ongoing work, and we give credit to the HEPI project because it's fully supporting this work. So what did we do? We held 2 days health professional education workshops, which were organized under the auspices of HEPI project. So a total by then of 2 workshops were conducted, one at Kaba Regional Referral Hospital and one at HEPI Hospital. So we found that these workshops were facilitated by a team of doctors and nurses. So it's kind of like an interprofessional approach. These people were from Kabale University School of Medicine, and they took the participants through different trainings. So the health workers at Kabale were trained on diabetes, its management in children, pregnancy, and HIV patients. While at HSSSU, when we went there, the health workers were trained on shock, basic and advanced cardiac life support, airway management, protocols for appropriate use of inotropes, newborn resuscitation, and management of postpartum hemorrhage. So a total by then of 69 practitioners were trained, and of course there were different cadres, nurses, doctors, clinical officers. So we use the interprofessional kind of approach because we believe all of them come into touch with patients at some time. So they were trained on diabetes. Okay, this I won't repeat. And actually all of them reported there was an evaluation at the end of the trainings, and they acknowledged the fact that they learned something new from the training workshops. And they felt that these trainings were relevant as regards upgrading them with the new information regarding disease conditions. They also reported that the new information would help them change their practice in relation to patient management, leading to better patient outcomes. So they also appreciated, during these trainings, I'm one of the trainers, they actually have this opportunity to ask things they're not in position to ask during their practice. So they end up getting clarifications on different therapies and different opinions about different regimens. So I therefore conclude, there's need for health professional education, and it is vital for in-service health workers in order to improve their knowledge and skills on the new innovations in science as regards disease management and therapy. Thank you.
We should have the next presenter is Jonathan Kaluvo around. Is he online? All right.
Thank you very much. Good afternoon to everyone. So I'm going to be presenting about the COBAS program as one of the possible solutions to the healthcare worker brain drain in Uganda. I was inspired by this conference to write about this because as we are training healthcare professionals, are we thinking of whom are we training for? Are we training for the other parts of the world? I'm currently an intern doctor at Mulago National Referral Hospital. So the disease burden continues to rise, especially in sub-Saharan Africa. And as of 2007, that's I think a paper by Anyangwe suggested that the global disease burden was at 24%, and just here it was at 3%. But in 2013, despite the increasing disease burden that you're having in our region, about 30% of the graduating physicians in Uganda continue to immigrate out each year. So that map just tries to show us the disease burden being highest in the African continent. So medical brain drain refers to where the human resources for health crisis that plagues the healthcare systems of many developing countries, where newly graduated physicians and other healthcare professionals choose to leave their countries after receiving their formal medical education. In the previous years, we used to have it happening whereby you have from the low and middle income countries to the Western world, but nowadays we have from the rural to the urban areas. So we have less people wanting to practice in the rural areas. So this shortage and uneven distribution of healthcare workers has aggravated by the medical brain drain in Africa. Other continents, Asia and Pacific countries, has contributed to impaired health service delivery and a high rate of mortality and morbidity in those countries. So a study conducted by Kendall in 2017 suggested that expanding the diversity of medical students in terms of educational and socioeconomic background by targeting low-income parts of the country will generate doctors more likely to stay in the country and more connected within their home. To continue with that, strengthening and building upon the community health care programs already utilized will allow medical students to appreciate their role in the Ugandan health system. Therefore, one way of achieving this is through the COBAS program. So everyone, I think, in this room has been a product or has heard of the COBAS program. It has been realized that there is need to have medical training closer to communities where a majority of the population lives in order to orient the trainees' attitudes towards future practice in such communities. So the COBAS program involves exposure of medical students to the community for the purpose of research and project implementation programs. The program involves visiting of communities in 3 phases, that is in 3 years. In the year 1, they go and enter the community. In the second year, they carry out a community diagnosis to identify key problems in the community. And in their 3rd year, based on the prevailing problem they found out in year 2, they design a project and implement it to solve that problem. Some of the benefits that have been realized that the program is beneficial not only to the students, but the communities. The impact of COBAS at individual basis is yet to be studied, but in general, it has led to an increase in the number of medical doctors working in rural settings due to their prior exposure to these settings. The program has led to the development of research questions outside the academic curricula, thus introducing medical students to research early in their careers. I think I'm one of those products due to that benefit. Medical students gain experience in applied medicine through public health projects and contribute meaningfully to primary healthcare delivery. Besides that, they develop leadership skills and active learning to solve real-life problems. The community is made aware of their health problems, and through a community diagnosis and subsequent interventions, enables them to overcome some of these problems. This program exposes students to their future workplaces, including the hard-to-reach areas. So that is one of the illustration of students delivering a malaria prevention project to one of the communities. In conclusion, the COBAS program allows communities to actively participate in health promotion projects and also skills undergraduate students in community engagement, hence increasing retention chances of these future human resources for health. I therefore recommend that this program should extend to other medical schools where it is currently non-existent and more funding allocated for its smooth running. Thank you everyone for listening. I also thank the organizers of this conference.
Thank you so much, Jonathan. That was a great talk. Let's have the next speaker, Rebecca Nikaka.
Thank you. What a good background for my presentation. I'm going to talk about something related to the COBAS program. I'm Rebecca Nekaka from Stema University, and I've been coordinating the COBAS program for the last 6 years. I'm also happy to say I'm a PBL pioneer among the first people who went through the COBAS program. Yes, so I'm looking at something that we did using the COBAS program to improve TB case detection by teaching CQI. This is continuous quality improvement to our medical students. Edward, there was another, it's different. I updated this, not this one. Hmm?
You know when you go to present, as they're bringing you, because if you go to a workshop anywhere, be ready to present whether technology works or not. Because you can reach there, and those things are not there. So you should be able to present. So always be prepared as the scouts are with the scouts. But always do that and be ready to keep time. Now this COBAS graduate.
Thank you, Prof. Sorry about that. I had updated it. So we have all talked about the need to train our students and also try to address. So the way we have structured our COBAS program, we want to fit within the Ministry of Health priorities. So we try to look at the gaps within the community and see how we can actually use the program, because COBAS, just like COBAS in food, is community-based education, research and service. Much as we want to educate the students, we want to do research, but we also want to offer a service to our community. So one of the issues we picked up that was a big burden in the eastern region of Uganda was the TB detection rate was so low compared to what is supposed to be as of Ministry of Health guidelines. And we thought that we could actually contribute to the community, to the improvement of this case finding by using the program that we have. So we aimed at looking at the effect of training the medical students in continuous quality improvement as an approach to improving TB case detection. So we used the existing COBAS model, just like Makerere, not sure if still the same way, but we have 3 attachments for COBAS. In the first year, the students go and get introduced to the community. They identify challenges. In the second year, we have introduced, in addition to community diagnosis, we have a structured research methods training for them. And then in third year, we asked them to implement a project. So we decided to work with the third year group to actually implement and teach them a structured quality improvement module. So during the first week before they went to the community, We took them through the principles of quality improvement, the way the module is structured under Ministry of Health. So we had 86 third-year students, and they were in groups of 4 to 6, placed in 15 health facilities. They went through this one-week classroom teaching about quality improvement, and we guided them to look at TB indicators, and we chose out TB case detection as one of the poorest indicators that we had. So the students, when they reached the facilities, they were able to review registers, they line listed TB index clients, and they were able to zone them according to the guideline that they have under Ministry of Health. They also went ahead to do home visits with the community health workers. They assessed household contacts for TB using the intensified case finding form. We did this together with the implementing partner, that is Right CE, and we had staff from Right CE supporting the students in some of these things. So the students were also supported to collect sputum samples and send them to the health facility after using the case identification form. For all the presumptive cases, they were able to take sputum samples for examination. That's part of a supervisor going to check on the students and see how they were doing. Yeah, and students faced a lot of hardships. It's not an easy thing going to homes, a lot of hard to reach. This is the road to Bukwo. One of our COBAS sites is Bukwo General Hospital. And that is how the road was at that time, very hard. This is a Manyata in Moroto. So out of the 15 sites, they were all over these districts in Eastern Uganda. That is one of the lecturers practically working with the students and seeing what they are able to do in regards to screening. So as a result of this quality improvement project, the students were able to identify 408 TB index cases that were line listed from all the 15 facilities. 59.8 of these household contacts were traced. They were able to screen 1,099 contacts for TB, and out of these, 20.6% were children under 5. The 38 under 5 children were initiated on TB prophylaxis after being screened for TB and found negative. 288 TB presumptive cases were identified, and 83.3 of these received the gene expert test on sputum. And out of this, we had a yield of 4.6% that tested positive for TB. They were initiated on treatment. Yeah, then they also were able to do, because whenever we talk about TB, we want to talk about HIV. They were supported to do testing and counseling for HIV. And out of the 344 clients, 15 tested positive and they were linked to care. This, I'm not going to go through the detail. This is a breakdown of the different districts. We see a big number of clients identified from Moroto, given it's a regional referral hospital, and then the Busore Hospital also had a big number of index clients. Yeah, so in conclusion, we have learned that student-driven continuous quality improvement projects can actually improve the quality of care in our communities. And if we introduced this early to our students, it offers a big opportunity for them to actually do this when they get out to the community. And given that we have this program and the students are in the community, I think it's an underutilized resource. As we are saying, COBAS, community-based education, research and service, we have done a lot on the education, on the research, and we also need to look at the service, but we need to align it with the Ministry of Health priorities since we are working with Ministry of Health facilities. Thank you.
The last speaker, Job Kutesa. You're very welcome.
Good afternoon, everyone. My name is Job Kutesa.
The topic is specialty career preferences among fifth-year students at Makerere University. So the WHO really recommends that we have a doctor to patient ratio of 1 to about 400, but in Uganda we have about 1 to 28,000. So, and this is worse among specialties, medical specialties, hence the imbalances in the healthcare workforce and delivery, service delivery. So we all know that if you don't deal with this distribution, it's taking place among students right now, and if you don't deal with it, it affects your eventual workforce. So this is a registration of by the Medical Council. They had in 2019 they had most of what took the big share was the public health, and then we had pediatricians, and then have obstetricians coming in, and the rest followed. So we understand that the career preferences of undergraduates will aid planning if you took special interest in it. So our study was aiming to determine the specialist career preferences and associate factors among these fifth years. It was a cross-sectional study, mixed study, and it was in Makerere University School of Medicine, and in fifth-year students. So out of the 78 students, we had 35 who were eligible, and then we have for the qualitative, and then we had 3 focus groups discussions. Those are sampling procedures and then the variables. Sorry. Yeah. For the results, you can look. If you look at those bars, you realize that obstetrics took most of the share, and the surgicals. And then if you look at the females are more likely they were taking up the medical disciplines, that is medicine, pediatrics, and public health, and psychiatry, and others, compared to the surgicals, which is the opposite for the. And if you look at this, you realize that the females were less likely to take the surgical disciplines based on different. When we went to the qualitative to try to explain some of these decisions, we came up with 3 main themes, which were facilitators, barriers, and solutions to these specialist preferences. And among the facilitators for the students' preference, specialist preferences, there were controlled lifestyles, and then assured good life. One of them say that I think of all of us, I think all of us would like to go to those specialties, even the trivial ones, as long as a good life is guaranteed, would like to serve. Then the inspirational specialists, as you can go ahead and see there. For the barriers, we had bad experiences in clinical rotations, lack of guidance, and perceived poor and miserable specialists. One of them quoted that about the biomedical sciences, I wouldn't consider them, just because first of all some of them, according to, they don't look happy, and I would and the way they see them wouldn't want to be like them. So for the suggested solutions to the barriers, we had mentorship programs, need for career guidance, and specialist treatment of students with respect. Yeah. So we had OBGY as the top because of their organization. They are inspirational and motivating teachers there, and are willing to teach. And we realized that more male students were more likely to take surgical specialties. These other specialties like ENT, anesthesia, family medicine, the findings, given they're not well taken up, the findings are much more similar to studies done in Jordan, and not only in Jordan, even Pakistan and other places, because of limited exposure, and some of the assessments were very strict, so they made which I literally scared away the students. 2.5
of students who are undecided about their future because of lack of guidance, career guidance. So in conclusion, we have OBGY as the most preferred career, and the facilitating factors here are gender and controlled lifestyle, good life, I'm assured of a good life, and inspirational specialists. Then the barriers were bad experience in clinical rotations and lack of guidance and poor, passively unmeasurable. So we recommend that the improve planning in the curriculum within all the clinical disciplines, so that they can improve exposure and experience of students in their various rotations. And then strong programs of career guidance and mentorship should be recommended and taken up by the faculty. And then we also further recommend that a follow-up is done on undergraduates through the postgraduate and also post-education phase to determine the factors that affected associated with their eventual career choices. Because some of us here, you want to do OBGY and you find out you're a mycologist or something like that. So anyway, so we want to know those. So those are my mentors. Some of the pictures have not come out very well. Thank you very much.
Thank you so much, Job. That was really excellent. Do we have any questions for our presenters? Anyone online or in the room? Yes.
Okay, thank you. I want to ask a question basing on the presentation on COBAS, where you talked about targeting those training students in low socioeconomic environments and targeting those from disadvantaged backgrounds for medical training to increase retention. I want to link it with the training at Busitema, and I hope I get an answer here. I am aware that in Busitema, you give a greater percentage of your admissions to diploma holders who are coming for medicine. I don't know what this is creating in terms of retention, if it can show us that positive trend of retention of these people since they are coming from this background. And about biomedical, well, I love negative things, and I hope there are so many people here from biomedicals. And this is what I've always said about the hidden curriculum. How do we conduct ourselves? I think we can see how our ways of behaviors are beginning to motivate the potential people who are supposed to be coming into the biomedical disciplines, and yet we're always complaining how we teach biomedical. Can we be able to find a way of teaching biomedical in a way that makes the students find it easy to integrate during the clinical years? Or we teach plain science and the student find it very difficult to see how useful it is during the clinical years. But the hidden curriculum, I think this is where it comes from. We walk back home and the student they say, no, I don't want to work about, I don't know what we can do about that. But it is an interesting one. It's positive for me.
Thank you so much. So I'll give a chance to, were there comments? I think to Rebecca.
Yes, thank you. So retention and a COBAS program, actually, we've not yet documented, but informally, talking to my preceptors, I currently have about 7 of them who are our former students in these facilities. That's a very good indicator for retention. Number 2, our students before internship, pre-internship, majority go back to their COBAS sites and they spend that holiday in the facility. Actually, many of them look forward to an opportunity to go there. So maybe we need to do an evaluation and see how much have we contributed to the retention in the region. Thank you.
Thank you so much. Job, do you have any comment to make on the comment raised on biomedical? All right. And the people online, I think we should keep them.
Online, yes. Two things, short ones. I think they gave us a model, integrated teaching and learning, biomedical training also in there as we go upwards, so that the biomedical people are there to be seen and what they can do. So I don't think that they are doing many wrong things. Maybe we're even doing more wrong things in the clinical area. And as you saw, that's the preference, but why are the male students, why are they choosing OPS and GYN? Okay, so the motive, good life and all that, that's not what we want. And we should reverse to have something for them to want to serve the population. The COBAS, thank you very much, Dr. Jonathan Nkalubo. I wish you can give this presentation to the administrators of Makerere University College of Health Sciences, where COBAS now starts in third year, and you people were there doing nothing, roaming in the communities. So that's why we need to come up, all of us, with strong voices so that there's continuous improvement. And even this COBAS, we can revert to the situation. Thank you. But weren't you people impressed by the mycosis person? Felix, I don't know if he's still with us. Did you see what he was presenting? What the VC was saying, research-led. You teach what you have researched on. He was quoting his papers. Let me tell you, you go and Google Felix Bongomin, you will see. And in the afternoon, I'll tell you more. Thank you.
All right, then I think we can reserve the rest of the questions to the speakers during the lunch break. I would like to give a little chance to the people online. Is there anyone with a burning question? Are there comments coming in? Let me have a check on that. All right, please come back at 2. We'll be beginning exactly at 2. And for the lunch break, please ensure by 2 you're back. And thank you so much for attending this session.
So Kajimu Jonathan, are you on?
Yes, Professor Sarah, I'm on.
Okay, thank you. So we have 4 students. I think more are coming. Are we expecting more? No, okay. So we have 4 students with us who are going to take us or to be the panelists for this roundtable discussion. And I'm going to stand in for the Dean, School of Medicine. Sarah Chiguri is my name. I'll ask the students to briefly tell us who they are, their names, their institution, program, and year of study. But also, as you are introducing, tell us if you've done research before and how many publications you have there. So we'll start from those who are here, and then we'll continue with Kajimu online.
Thank you, Professor Sarah. Good afternoon, ladies and gentlemen. Ignatius Asasira is my name. I'm a 4th year medical student at Makerere University, and I also serve as the president for the Makerere University College of Health Science. I am a young and expectant researcher who is having an ongoing research with no publication so far, but looking forward to having a number of them. I'm glad to be here with us. Thank you.
Okay, you're welcome, Asasira.
Good afternoon, everyone. My name is Gochalia Anna Maria.
I'm also a fourth year medicine and surgery student at Makerere University. And I have one publication. It's about knowledge, attitude, and practices of patients in Mulago or in COVID-19 preventive measures. And so that was my first paper. And then the second has just been accepted for publishment. Then one is under peer review. Thank you.
Hello, good afternoon. My name is Linda Tulinda. I'm a fourth year medical student at Makerere University, and I'm happy to be here. I've had one publication so far. It was assessing the attitude that medical students had towards e-learning in this COVID-19 era. And I'm also the editor-in-chief of the 50th edition of the Makerere Medical Journal. So I'm really passionate about research. Thank you.
Okay, you're welcome, Linda, Atulinda. And Jonathan, can you introduce yourself?
Hello, everyone. My name is Jonathan Kajimo. I'm a fourth year medical student at Mbarara University of Science and Technology. I have so far published, I think, 6 publications with quite a number of other projects that are in the pipeline. I'm passionate about emergency medicine and research, and I'm really happy to be joining you today.
Okay, thank you. We're expecting nurses. Is she there? Please come and join us. We'll get a chair for you. Yes, I know there was a dentist. Has Felix gone? Yes. Okay. Yes, please introduce yourself.
Good afternoon, everyone. Nasozi Diana Roda, a third year medical student pursuing a bachelor's degree in dental surgery. So far, I have over 4 publications, and I'm a young early career researcher.
Okay, so you've had them. Maybe I can say the first publication I had, I was a pediatrician. Okay, I had worked some years, and they used to tell me you should publish your dissertation, and I didn't know how to. And actually, the people who are telling me publish or perish, never did not teach me how to publish. So when I see these people before us, I look forward to what they're going to tell us. So I want to begin by asking our panelists. So what is the situation of research by students? Does the training that we have give you the skills to do research and publish? I'll start with Jonathan, and then I'll select a few of these students to answer. So Jonathan, the training you have at Mbarara University, do you get the skills to do research and publish?
All right. Thank you so much, Professor Sarah. One, I would like to stand from a point that I haven't been a beneficiary of the previous HEPI tutor cohorts, and I've had to develop my research skills personally and also through support of my networks. But from what I've heard from colleagues that have been beneficiaries of the 2 cohorts so far, they are being really supported to run projects and pick up skills that will be of great benefit to them. And I think we would all love to see that we have such projects being run through medical school for a good number of time. We hope that it doesn't come and then go. We would rather prefer that to have a sustainable approach that is put in place.
So the answer is no. There are projects which don't reach every student, and you've had to get your skills. Yes, Nasozi?
I personally have been a beneficiary of HEPI, and I'm really grateful for that, for what HEPI is doing at college. You enrich us with knowledge during those trainings. But aside from that, it's more of your interests in research and the students, what you really like. Because most of the time, we do not get like really mentored into the research. So it's more of the student initiative to if your interests mostly.
Okay, thank you. There is sanitizer around if you are to move around. So do we all agree that the main real training, the curriculum, does not impart adequate research skills? But is there nowhere in this program where you do research training? Look at the whole program you have. Is there nothing at all? Or yes, Asasira, and then we'll move to the next question.
Thank you. In relation to that, we have a program, the previous speakers talked about it. That's the COBAS program, Community Placements. While we're doing our COBAS, which we start in our third year as per the new curriculum, we have a series of lectures, but the problem is that they are more academic research lectures than, I can use the word passion. We study them for purposes of passing exams and going in the communities and collecting the data for purposes of presenting, and we are done with that course unit. So I want to thank you for asking that question, but the truth of the matter is it doesn't go deep in hearts. She talked about passion. We don't really, up to now, as a student leader, I find it very hard to be convinced that the students of Max CHS on a bigger scale are fully involved with the word passion. And the other problem in terms
So this
of
is the new
situation,
program.
Yes, it's a new program. It's a new program altogether. And whether it gives us the skills and publication, for the part of research, yes, I've been a beneficiary of HEPI, and I can say the small skills that I have about research, I've learned them entirely from HEPI. But when it comes to the part of publishing, I think the trainings we have did not go deep into the publishing part. No wonder I have two of my studies which are still pending on the part of publishing. So after here, I think I will get what I need. Thank you.
So I want HEPI to be out for the time being. Maybe it will come. So colleagues, the students are telling us that there are gaps. Mbarara, Makerere, Pusitema, we had their view, but this is what they are telling us. And so what are the challenges? What challenges, apart from not being trained to have the skills, what other challenges do you find when you want to do research? You are passionate, so the training is not adequate, but are there any other challenges, Linda, that have not been talked about?
Okay.
And then Gocharia will come in.
Okay, so for the challenges that I've seen mainly, because there are some medical students that are actually passionate, but one big problem is how to start. They even find generating a research question quite hard. They don't know what should a research question be like. And while in that line, the other problem that they find is choosing a mentor, because we have the lecturers, but they find it maybe hard to approach them because of the time. And also we've been told that before you approach your lecturer, make sure you have something substantial to show them because they don't have time. So that's a problem, how to start, the starting point. So the passion is there, but they lack that starting point, that step forward that will take them to the next level. So I find that as the biggest challenge that medical students are having, even those that are passionate.
Okay. Yes, Gochara. Any other?
The other challenge on top of what Linda has submitted is how to actually find the funding for research. Well, HEPI has been able to put out calls, but then in case of no HEPI, very many students don't know where else to find the money. And I remember in my first experience, if it weren't for Prof. Manager to send me grants, I think I really didn't know where to get the money from. So the other challenge is how to actually find funding for the research.
Okay, so no funds, no the training. Would there be invisible funds within our programs? Are there ways that students can get the data, because the funding is mainly the data. We shall discuss as we go along. Then Jonathan, online. So what opportunities have come up for you to enable you do the research? You said you didn't get opportunities for the funding that is there, but what other opportunities are there?
Yeah, thank you so much. So one of the greatest opportunities that I have probably leveraged on, it's conferences that I have attended before, where you get a chance of meeting people that are probably in line that you also want to follow, that you link up with, and then they keep supporting you, develop your different ideas, and then you rise up. And
We've lost you. Auntie?
hello.
Yes, you're now back. Any other
Sorry
opportunity?
about that. Yeah. Yeah, and then in addition to that, I was saying, amongst such people, there is one key person that has really given an extra hand to so many of us, that is Dr. Bongomin Felix. And we would really like to appreciate him so much for what he does for us, which is quite outstanding and unique, because we don't see
so conferences where he meets people. Okay, Jonathan, that's fine. I'll get the other opportunities from here. That's why I wanted Bongomin to be here. You the mycologist, one of the 3 worldwide, not so? Who is also a graduate student in internal medicine. He's also mentoring so many, and they're saying opportunities. Okay, so the team who is here, any other opportunities?
Well, also, most of the opportunities actually come within our lecturers. Linda mentioned the issue of mentorship. The biggest help a student can actually get while in school is when they have someone to mentor them into whatever they want to do. So giving my example, I've had 2 really good mentors, that's Prof. Mayanja and then Prof. Nelson Tewankambo. And the only way to actually find those opportunities is when you are a proactive student.
How did they become your mentor?
Yeah, like I was getting to it. When you are a proactive student, when you engage into leadership activities, and then they'll identify you. And when you relate with them, they can actually open up your eyes into some of these opportunities that are actually there. Because Professor Manja normally sends grant applications so that you can apply for them. Then Prof. Nelson, the same thing. Yeah. So the biggest help or the biggest opportunity for any student is really a mentor.
Okay.
Yeah.
Linda, my friend. Linda is my old girl. Yeah, from my school, but she has never come to me to ask for research support. So Linda, what are the opportunities?
Yes, thank you so much. So the opportunities that I think are there is to, like she said, be proactive, look out for the opportunities yourself, because many people say they don't know about HEPI, but it's because they do not look out, because the calls for HEPI, for example, are put out on our medical school notice boards, or other different opportunities are put out across social media platforms, because it's what we use mostly, whether it's going to be Twitter or Facebook. So I feel like it's the students to look out for grants, look out for applications, look out for training opportunities and be able to seek them. So for me on my end has mainly been that being proactive and looking out for these opportunities and applying. And when I get in, that's good. I then undergo the training.
Okay, so projects or training opportunities from projects of lecturers. Yes, President Sasila. Any other opportunity? Our time is almost over, but
yes,
I want
in particular, I want to acknowledge that the international office and Madam Susan has been very supportive on my side, because there are a number of people who come into the country, maybe other student exchange or other health investors, and they come up with these good ideas, and I find it easy for me to learn from them. And I've also been able to reach out to other fellow students who can utilize the similar opportunity. I want to thank Madam Susan for that.
So it's been a platform for us to really engage into research. So there's a little funding that comes from there. And then lastly, about opportunities, have been other trainings personally I've attended, which are outside medical school setting. I usually go on the websites for MJAP, Muju, Red Cross Uganda, and I find they have like an upcoming. Recently, I was in Mbarara for a training, and it is all about research. It was under Red Cross. So some of these things, like Linda said, is a personal initiative to go and look for them. Thank you.
Okay, Nasozi, do you want to add on, or those are enough? Anything else?
Okay, what I'm going to add on concerning the opportunities in research. So there are collaborations in research, because most of the times you do not work alone. You work as a group and everyone adds knowledge to one another, and you connect with different people from different countries if you're running a project. And it's one of the things that I've really appreciated in research.
Okay, collaboration. Let's think about ourselves, faculty. Do we collaborate or do we compete? So what are the students telling us to do? Okay, so collaboration, very important. So the last question, and then 5 minutes to the rest. So how can our institutions, universities, improve this research competence among all students? Because we know that some students are left out, they may not be as proactive, they may not be assisted by the international office, they may miss calls for HEPI. Recently, there was a student who waited for me and was saying, you know, I heard that there was a student training on research. I also want to be part of the training for HEPI. And you know, he was very serious. I did not take his name, unfortunately. Then I said, you know, we are going to put up a call, but what if that call goes out and he misses? And I've forgotten how he looks like and his name. So what can we do so that everyone participates? Jonathan, one thing, one idea, and then each of the others will give us one idea.
All right. So personally, I happened to was well known to go through in the second cohort of the HEPI tutor at Mbarara. But one thing that I would probably recommend universities to do is to ensure that the faculties get to be ready to always support students that come up with ideas related to projects they would like to run.
Okay,
and
support.
That is what I have done, and I'm grateful to the faculty that.
Okay. Yes, Nasuzi.
Okay,
one idea.
Yeah, my idea is this should start like straight away from year one. If something like year one students could be engaged in, once they join university, they should be engaged in these research opportunities, and more awareness concerning that.
Okay, awareness right from that time people start the university. Yes, Asasira.
I would suggest you start up a mentorship program as HEPI,
Okay.
if it is possible, because there are a number of young people who want to participate, but they don't know how to get mentors.
Okay.
Especially from the other schools other than School of Medicine.
So a mentorship program, research, mentorship for research only?
Yeah, okay, it can start for research and maybe moving forward it can.
Okay, and you're asking HEPI,
Yeah.
and we are going to take it up as HEPI, we are going to take it up. All the institutions for HEPI, I will speak for them, but I want you to lead, contact us and give us ideas on how we can do this so that it is sustainable even beyond HEPI. And I've given you my young colleague, Dr. Mukunya, if you know him. I don't know if David is around. And Dr. Ambalinda, you write your concept. We assure you that during the few years of HEPI, we are going to try our best, think of sustainability. Yes, Anna Maria.
My point is on collaboration. Recently, I attended the Moncrief Open Day, and then I realized that most of the researchers were from lecturers, but then none of them had a student on their researchers list. So I'm hoping that with time, if a lecturer is to take up a research project, there's at least 2 spots for undergraduate students, so that at least if they can begin with just data collection, they'll get into writing a proposal, then publishing, and then the whole complete research.
Okay.
Yeah.
That's an idea that costs probably little. Be part of our research groups. I hope someone is taking this noting. And you know, some lecturers have projects that have even ended with a lot of data. Okay. I- I've had some research, if you go and Google Feast tracked, we have data well collected. So if you would need to answer any question, you can just come and collect that so that you get, but also it could be ongoing projects. And we get many students from the UK, from wherever, because some of our grants are international, they're international researchers. Their students come and benefit. Why not ours? Okay. Yes, and my friend.
Okay, so since the question looked at targeting all students and not just those that are proactive, I looked at it from the angle of COBAs. We're already doing community placement as part of our course unit, so all students must do it. So when we do our COBAs, they give us supervisors who come and see how we're progressing, but how I wish the supervisors could instead turn into mentors, yes? So that when they come to check on if we're actually doing our projects, they sit down and maybe look at any challenges we're having and try to guide us in that line of trying to solve the problem that we have, because they come and check on us, but they've not really done a lot of the mentorship. And I feel like for every student to actually get impacted in the line of research, it would be nice if those supervisors actually turned into research mentors, because all of them have done research and have a lot that they can teach the students. So that's one way that all the students can get research mentorship.
Okay, integrated it into the curriculum, and COBAS is a good way. From Busitema, where COBAS starts in first year or the previous Makere, then it is easy. But I thought that mentors or supervisors do that. Okay, so open to the audience. Some questions, comments, colleagues, both online. We are in the next 5 minutes and then we go to the next. So any comments, questions? I'll begin with colleagues online. Does anyone want to say anything about research? Please go ahead. There's a hand here. And then we'll go around. There's a Dr. Poka, and then we'll go like this. There, this one. And then from there, you go to Dr. Poka, and then we'll go around.
Thank you very much. I'm Lubega Jason, once again, President by Medical Science Students Association. So as the panel has been talking, I've been noting down some few concerns on the topics, the challenges, opportunities, and benefits. So I feel like research should be incorporated right from year one, because personally, right from year one, I wanted to do research, but I didn't know what to research on. And so I clung to someone, Dr. Felix Bongo, means mentee, Ronald Olum. And I first became his data collector. I was doing a research about suicidal thoughts among medical students. So that was the first bit, but I didn't know what else about research is about. So the problem is about late incorporation of research methods in our curricula, and also mentorship. You've talked about it. And also people have big ideas for the facilities available. I've been to a research proposal defense this morning, and people want to sequence genes. They have ideas of how to do things, but when you go to where you're supposed to sequence from, the machine is only run once a month, once in 3 months. So it's really hard, even when you take your...
Can we start with simple ideas and grow?
Okay. Let's look at the opportunities.
And just one last statement.
Yes.
Please give us your one last statement.
About the ideas?
I don't know where you put up your hand. I don't know what else you want to say. Because of time, I want to stop you.
Oh, sorry about that. Okay, can I say one more?
Yes, yes.
All right. I want to look at how I entered HEPI. I had to cling on someone's proposal to get in for the training. But I was getting in for a training I didn't know how to conduct anything about. But my first requirement was a research concept. So that makes it hard for someone who can't come up with a research concept, but wants to learn research. So
Yes, and in HEPI, we didn't ask for a well-written research project. We asked an idea, a concept, and whoever wrote, we took them in to train them to write research. And I think about 5 or 6 have published. So that is the model we took, knowing that you didn't know, but if you were interested, then we took you, trained you. Dr. Sasia, we're going to have more trainings if people have data for publishing. Okay, this Dr. Poka.
Thank you. First of all, I'm very impressed. I'm very impressed by these young people. Everybody's saying I have 4 publications, 6 publications. When I was your age, I had 0 publication. So you're doing very well. Congratulations. And I just wish that I just wish you could share your story either in a, write it as part of the to motivate other, inspire other. I think you're the biggest inspiration because people relate to you. I think you guys are the best role models for your generation. So if you could write some of your stories down, publish them so you can inspire other young people to come. Number 2, we have heard, I'm part of HEPI, we have heard what you have said. I think we're going to work very hard to implement some of these things. The mentorship that you have recommended and training for research, that's something we're going to do. My last thing was about student journals. I know there used to be a Makerelian, and I don't know whether that can be strengthened as part of the way to improve research and publication. You may fail to get it onto Lancet or New England Journal, but if you get onto Makerelian or another medical journal, maybe that can be a first step in getting to publish and to publicize your work. Thank you.
Okay, let's revive our journal for those who can't get the peer reviewed. Yes, from behind, is it Professor Sewufu? And then the last table, and then we finish. Just one statement.
Yes, thank you, Chair. Back then we used to, first of all, thank you, the students. You are really very inspiring to your peers. And I was very surprised. Ronald Olumu, I don't know where he is.
Olum was here yesterday, he's not here.
Yes, he's one of the people who,
yes.
who reviewed my paper because he's a specialist in COVID. So I was very surprised when he was made a reviewer by the frontiers of public health. Prof. Chiguri, we used to have mentors at Makerere.
Yes.
Back then in 1992, 93.
Yes.
When you come in,
you are given a mentor.
You are given a mentor who is going to look at your, not only your academic life, but also the social aspect of it.
Yes.
I don't know what happened to that.
We are going to engage. We would need a statement. At one time, we are told that the students want to choose their mentors, but in year 1, they don't know anyone. It's another passionate area because I used to assign mentors, but it's all about coordination. We shall take it to the leadership. Please, one sentence.
Yes, Chair. Under HEPI, one of the sub-aims is system strengthening. So in addition to mentorship, I propose, because in our respective institutions, there are students research associations. There's also students research networks that cut across institutions. So those two also could be included under system strengthening in addition to mentorship. Thank you.
Okay, but they need to be supported. And please, all HEPI grantees or awardees, make these activities part of your work plans for the next year. Yes?
Mine is a question. During your publishing or during your research process,
what has happened during the COVID-19 where there's a lot of online supervision? Is it an opportunity or more of a challenging situation? Thank you.
Okay, and the last one, I'll take one of you gentlemen. The first one, yes.
Thank you so much. And I'm happy for the students for what you're doing, and continue, don't stop. And Jonathan, I hope you're still online.
Yes, I am, Dr. Olo.
Yes, Jonathan, I want to meet you when I come back. But
Okay.
coming back here to everyone, I want to ask, one of the things you mentioned is fear among you as students to talk to lecturers, isn't it? Now I want to ask this because I am one of those. Jonathan,
Yes,
you tell me
I want
something.
to stop you,
I want
sir.
to hear,
Just,
how can we make it easy for students to approach us as lecturers? What should we be able to do from your side? What do you think?
Jonathan, one word or two?
I think, like we said, we need to have an avenue in which
someone here is connected on Zoom. Please switch off.
Yes, Jonathan.
I was saying I would recommend we speak to the students first of all to know that, well, if sorry about that.
Okay.
I was saying,
What should we do, Jonathan?
yeah, I would recommend that one, we approach it in a two-way thing. We have strategies we impose on the student side and then even on the lecturer's side. We would like to encourage students to reach out to lecturers because these are people who might not probably know what our interests are. They only get to know them after you've approached them. People shouldn't feel like seeking for help is something that probably undermines your capability. And then on the
Jonathan, we have
on the lecturer's side, I would prefer we recommend them to look up for opportunities that they believe can support their young generations to rise up, and then they expose them to their students.
Okay, thank you very much. Let's stand up and give these students a round of applause. Let's give these students a round of applause. Thank you very much. We needed more time, but next time we shall give more time to these students. They have told us what the gap is and how to move forward. Please don't fear us. We are human beings. Please don't fear us. So I'll give Dr. Faith, is it Dr. Faith Nawaji? He's the standing in for Dr. Roy Mubuke. But the next keynote address, to introduce it, and we'll have one keynote person who is online, and maybe we'll be some minutes late. Maybe she can ask if she's there, so that she gives end with the other one. If she is on, she can give on a recorded one.
Let's have a bit of a shift in the program. Eddie, could you check if the Dr. Janet, the FEMA president, is online?
No, ask you, just ask you.
I am online.
All right, thank you. So we are going to have a little bit of a shift. We will have Dr. Janet Maldenovic's talk first. And Dr. Janet Maldenovic is the president of FEMA. FEMA is the Foundation of Advancement in International Medical Education and Research. And it is a foundation for ECFMG, which is the Educational Commission for Foreign Medical Graduates. She has a lot of leadership in health professions, leadership given her various roles in various academic leadership. So we will have her presentation. She's online, but her presentation is pre-recorded just to make sure it's more clear for clarity. and to prevent any internet disruptions. After that, we have Professor David Gordon's recording as well that will be featured immediately. All right. So after her presentation, she will be online to take any questions that you may have. All members online and all members here in person, please take note, pay attention and note your questions. You have a chance to ask. I'm now going to let the IT team begin the talk.
Well, good afternoon. It's such a pleasure to be here with you today to talk a little bit about leadership development in health professions education. I come to you from FAMER, an organization that many of you are familiar with. But if not, by the end of my remarks, I hope you'll at least know of our commitment to health professions education. In the few minutes today that we're together, I hope you'll come away with the following. An organization that many of you are familiar with. But if not, by the end of my remarks, I hope you'll at least know of our commitment to health professions education. In the few minutes today that we're together, I hope you'll come away with the following. I'll try to impress upon you a rationale for leadership in health professions education. This is something I know that we are aligned on, and we understand how important leadership is in our institutions to keep us up with the critical advances in our field and to move these to the next generation.
Dr. Jeanette, since you are online, do you think it would be better if you can present?
The next.
Sure, I'm happy to, if that would be better.
Because unless if the volume here improves.
So would you just like to go to my second slide and I'll present from there?
Okay, thank you. That's much better.
Is this better? Yes. Great. Okay, so just move on to the next slide. So in our few minutes today, I'll try to impress you with something that I know we're all aligned with, and that is the importance of healthcare education and professions, keeping us so that we can be up to date in our fields as we move from one generation to the next. I'll also use the FAMER experience of the last 20 years to illustrate how leadership training can impact communities and the next generation of learners. And finally, I'll chat about those areas that we personally believe are important to advance beyond our initial programs of teaching the professions how to teach. Next, I'd like to start with a reminder of what the word doctor means and how it has come to have a mix of meanings, which for those of us who are physicians may have led us to a false sense of expertise. And that is, doctor comes from the word to teach in Latin. And It was first used in the 13th century to signify the most learned in the academic world. So how did physicians come to earn this title? Eventually, it was given to learned members in the field as practitioners, which has led to some confusion. In medicine, it actually took decades to understand that just because we were called doctor and we knew how to care for patients didn't mean that we knew how to teach. In fact, in the United States, it was only in the last 2 to 3 decades that it was recognized that expertise was important in education in order to use sound principles in the development and oversight of curricula, oversight of assessments, and now to assure competency. Next. In many ways, other professions outside of the schools of medicine have been more true to the meaning of educating their faculties, in particular in the areas of pedagogy. In my past role as a leader of health profession schools, the differences in our cultures were reflected often in their faculty and the curricular implementation. These schools and professions have long held well-defined faculties that carry a title more aligned with its true meaning, that is doctor. In medicine, because of its predominant need for clinical faculty, we often have evolved in very different models. So in fact, to return to a model in which we educate the educators was critically important to advance our missions. Next. Yet, as we know, the critical 3-legged school of medicine, which I actually heard about yesterday as one of your speakers gave a passionate plea to integrate academic medical centers into schools of medicine. That 3-legged stool is critical for us as we develop the practitioner of tomorrow. The 3-legged stool, which is educating the next generation, leading the complexities of our healthcare environments, and creating the knowledge for a healthier tomorrow often requires that there be individuals with additional skills, knowledge, and attitudes that can help lead these areas. For instance, in healthcare, we often see additional degrees or certificates in quality improvement or finance or an MBA. In research, we see the in-depth study of a particular area in order to keep up with the technical advances of science needs specific in-depth education. So why do we think education is any different? It makes sense that to inspire tomorrow's learners and create programs of relevance and excellence requires additional education. Here, yes, a PhD or an EDD or specialized programs or fellowships. Next, enter FAMER, or the Foundation for the Advancement of International Medical Education and Research. I'd like to tell you a little bit about our history. Many are familiar with the ECFMG as it began in the United States in the 1950s as an organization to evaluate the credentials of physicians who were coming to the US to obtain additional training. After many years and programs that fosters faculty exchanges, the ECFMG created FAMER as a way to focus its efforts outside of the US. Its first leader, Dr. John Orsini, along with Dr. Paige Morhan, originated FAMER's major program, that of a fellowship program focused on faculty development for medical schools. It was meant to optimize its impact by partnering and concentrating in geographic areas that contributed many of the ECFMG physicians to US education. Next. This 2-year fellowship, now some 20 years old, was meant to develop leaders in health professions education. It used methods that led to high learner engagement and engaged the fellows themselves and their own communities as a laboratory to develop a project to try out their newly acquired skills. These, even today, are the common elements of this fellowship. Its faculty sites of delivery, and even methods of delivery have modernized, yet its principles have been enduring. Next. As we're discussing leadership, we wanted to share a little bit about our leadership program, which in my experience, engaging in these programs over the last 4 decades, is really similar to many leadership programs. It has 3 common elements. Understanding self, which is often the most enlightening and far-reaching impact in one's personal development. Learning the principles of leadership and often of management as some critical skills that are intertwined and really depend upon organizational needs and the state of the organization. And finally, higher level understanding in the sector in which you are working. Here I've shown it's health systems, but it could be educational systems or financial systems, or pick your own sector, as there are many leadership programs everywhere we look. FAMR, over its many years, has developed its own approach to these common areas of leadership programs. Next. So what has been the success of FAMR's fellowship? And how do we know that this program has mattered at all? Well, we began with the Philadelphia Institute, where everybody came to Philadelphia a couple of weeks during their 2 years. Those fellows went on to lead in their own communities and develop FAMR institutes that engaged locally, attracting their own fellows in partnership with their own universities. These regional institutes now number 12, and they use the FAMR structure in partnership with FAMR. Here you can see we have 4 institutes in India where we started these programs first internationally. You can push the tab and you'll get there you go. Now, 20 years later, we have 12 institutes, as I said, 2,000 fellows from 59 countries who are FAMR alumni, with some 800 fellows in India. Here, the color of the map represents the concentration of our fellows. Our newest institute is in Indonesia, and it is now some 3 years old. Next. Because we have worked with our colleagues in India the longest, and because we've spawned over 800 fellows there, we can look at some long-term outcomes of this program. In India, remarkably, as far as we know, all fellows have remained on faculty, with many rising to significant leadership in universities. This suggests that those who have completed our fellowship obviously had great leadership potential. However, FAMR fellows have contributed significantly to policies and leadership in medicine in India. Here are just a few examples of what that leadership has meant. They have been members of medical advisory boards and the National Medical Commission, now the renaming of the leadership group in India. They were responsible for participating in the mandated faculty development activities that are required of all faculty in India. And this includes participation in the FAMR institutes. They have led a vision and developed the requirement for a CBME curriculum, which is now being implemented nationally in India. Next. Beyond their own leadership and their own institution, FAMR fellows have led the way to recognition of a unique body of knowledge in health professions education. Here, they have organized as an academy. They have created a university degree in health professions education. They have initiated a peer-reviewed journal. And finally, they have led the movement to recognize that educational leadership is part of career advancement in the academy. Next. And during COVID, FAMR fellows were instrumental in transitioning the required learning, including in COVID, to virtual platforms, including student assessment. FAMR fellows, in addition, worked on the front lines, with some of them losing their lives to the pandemic. These fellows really, truly supported students and learning during the pandemic. Next. Because we're speaking in Africa, I wanted to tell you a few vignettes of FAMER fellows in Africa. Perhaps you recognize some of them. Dr. Hafi Conradi, the family physician who completed his FAMER fellowship in 2011. He implemented a project that really has had long-term impact. Prior to his retirement in 2016, he began the Uganda Rural Clinical School, where students spend a whole year longitudinally, and which has resulted in attracting more physicians in rural areas. This campus has been sustainable, and another like campus is now 3 years old in a small town in northern South Africa. In his retirement, he continues to work with students on rural projects from 3 universities in South Africa. Next. The projects may be seen as the most intensive and challenging of the FAMER Fellowship. Yet, the important act of defining a project advances the skills, collaborations, and approaches that may have the most enduring impact on the individual and the communities they serve. FAMER coaches the fellows through these projects, which they undertake in their own environments. Next. A few years ago, FAMER attempted to evaluate some of the outcomes of the many projects that were completed and that had follow-up. Of the over 900 projects, almost 50% led to institutional changes. 30% were replicated, as we saw in the rural campus example, and some 26% were expanded. As you can see, fellows found intradepartmental collaborators. They enhanced their interest in education and hopefully the quality of education and teaching, and actually they published their efforts almost half the time. Next. In Africa, some 11% of the projects engaged the community to improve health. In Uganda, primary care education was advanced into traditional medical education by Dr. Innocent, continues to teach and remains an active tutor in this area. In Cameroon, Dr. Licky implemented diabetes management into the community. His project, funded by the World Diabetes Foundation for some 3 years, has now resulted in a documentary. And in South Africa, our FAMER fellow, Professor Josie France, is now Deputy Vice Chancellor at the University of West Cape. Her project to advocate and educate about healthy lifestyles resulted in 4 years of students visiting communities through these outreach projects. Next. FAMER has recently looked at the number of HPE degrees or diplomas in Africa. Of the 54 countries in Africa, there are HPE diplomas or degrees in some 6. In both Northern Africa and in South Africa, the asterisk is meant to signify a FAMER institute. Given these findings, we're eager to expand our FAMER institutes. Next. In particular, we hope to expand to Eastern and Western Africa in partnership with institutions who see this as an important way to develop their communities and their students. As FAMER, we have now begun to advance additional curricula, all of which are meant to support faculty so they can develop programs and teach in different arenas. Here you can see that we are targeting 4 additional programs. Some are educational, such as competency-based medical education and the essentials of accreditation, which we know is the first stage and the continuing life of most universities and schools. We are also developing a program on the basics of translational science. As we just heard from the students, what we do in medicine and health requires that we understand the principles of how to make our community better from day one. And finally, we are interested in developing a program in point of care ultrasound as a way to advance clinical skills across the continuum of education and improve the health of our patients. Next. These programs in Africa are part of our overall new strategic initiatives in FAMER for the next iteration of FAMER. You've heard about FAMER Global, which really includes all of our international institutes. But more importantly, our new curriculum, our expansion of our degree programs into institutions if they so desire. Our Philadelphia Institute is now an online program, the International FAMER Institute. This year, it had well over 100 applications for its 20 positions. We offer this program in areas where there are no institutes or where leadership would like to begin institutes. We will expand our effort to, again, continue to support the international medical graduates who come to the United States. This is important as they integrate into the US healthcare system and hopefully take those lessons back to their communities. And finally, we are creating a world resource in partnership with several organizations, including with those in Africa. We want to better understand and document the state of healthcare education throughout the world and make this a resource available to students, faculty, accrediting bodies, and anybody else who would like to understand better how we educate in healthcare throughout the world. Finally, here is our very talented leadership team without whom none of this work would be possible and who have really accomplished all of this work. I'm sure you recognize some familiar faces from our team. Next. We will be celebrating our 20 years of existence in October, and we would love if you would consider joining us for this virtual celebration. This will be a 4-hour conference, which is always challenging throughout the world. The first 2 hours will be a conference that will feature FAMER fellows and FAMER faculty and FAMER alumni. The third hour will be a plenary session, and the fourth hour will be a cultural celebration. So we will invite you. So in summary, next. I hope I've made the case that doctor requires more than physician skills to lead the educational program of our next generation, and that these programs are critical to leadership and change in our institution. They make a difference in implementing these changes that are required to keep pace with changes in healthcare practice. And finally, that FAMER is only one such program, and that we have been very privileged to work with many of you over the last 2 decades. And we look forward to future partnership as we collaborate in many areas. Thank you, and I would be eager to take any questions.
Thank you so much, Dr. Jenny. Are there any questions online? All right. If there are no questions online, could we have some questions from the members present? Anyone? Yes, Professor Sarah.
Thank you very much for that presentation. I am a FAMER Fellow, 2004 to 2006. And as you are presenting and saying what FAMER Fellows are doing, I was saying that probably we need this leadership development. The challenge we've had in our institutions is that leaders come and go, leaders come and build, leaders come and break. And I wonder if there is how other places have grown leaders who have built on what other leaders built, and how we can deliberately grow leaders and influence succession of leaders in institutions, because it's a big challenge. So do you have any information about how other people are doing it? And what can be done to ensure that the leaders who come build and don't destroy? Thank you.
You know, I know well you're a Famer Fellow, and I look forward to meeting you personally. You know, I will comment from my decades of experience and from my experience in the United States, as I do not know your culture well. I now believe that we need to teach everybody as a leader. So I think there are critical self-determination skills and knowledge that are important to us who work in the healthcare environment, because we will always be seen as leaders in our community. So I think leadership is a skill that we need to begin early, just like I heard the students say we need to begin research skills early. But I think in terms of the institution, you are correct, leaders come and go. I think that requires that the institution have a clear vision and mission, and that the leaders engage in teams that are interprofessional and that will go on to carry the work that is set in motion. I've often said in the United States that once an institution is stable, it's almost impossible for a single leader to destroy it. Although I don't believe that is true of programs. I think programs are often individual and do not continue when the charismatic or committed leader leaves. So I think it's really important at the institutional level to put in sustaining guidelines for programs that will be reviewed, when they will be reviewed, and how they will be sustained. As you know, it is very easy to start something and never stop something unless it dies of its own accord. And it is just as easy to start something and have nothing move forward unless there is a true institutional commitment. So I think it starts at the top. However, the top can never be effective without ground up input from the students and those who live in that institution. So I do think it requires continuous leadership and a way to support those leaders. And I think once you get to the top, you can sometimes be isolated and be by yourself. So you need to develop teams that understand your vision and mission and have that vision and mission aligned. So that's kind of the view from the top. I'm sorry.
All right, thank you. Anyone else in the room with a question? Members online, do you have any questions? All right, I see someone behind here.
Thank you, Dr. Janet, for that great presentation. I heard you mention in your presentation that in India, FEMA fellows helped in the development of CMEs, which is being implemented nationally across India. So my question is, could you throw a little bit more light on that, specifically the role that FEMA fellows or their institutions played in the development of the CME and its implementation? Thank you.
So, you know, I will excuse myself by saying that I am new at FAMER, so I have not had the opportunity to travel to India, but I have worked online with the leaders of the institutes for the last year as we have redefined our vision and mission at FAMR. And what I have learned from my colleagues in India and Dr. Rashmi Vyas, who is in charge of this area of FAMR, is that because FAMR fellows were instrumental in faculties and faculty development, they were seen as change agents. And because they had that leadership training and developed projects that they implemented, some of which were based on CBME, they rose to leadership in the essentially national academies, which made these decisions. So I think the first decision that was made was that every faculty member had to go through faculty development of sorts. And FAMR is only one of the faculty development programs, but is known as having a great leadership in that arena. Second of all, they mandated at the top level that CBME would come into place, and now they're in the implementing stage. Our new CBME curriculum we've been working on for about 10 months now will be implemented with faculty starting in January in India. We have that collaboration. It is between faculty in the US and the leadership of the institutes in India. And that will be rolled out first for faculty development among the faculty in CBME, and then they will take it up and disseminate it to their faculty. So this was decided after a needs assessment in India, and that's how we took on this curriculum. So that's how we are, that's how the process is going, and that's how far they are. But it did come with a national mandate. Again, I think everywhere you look in India is a FAMR fellow.
All right. Thank you so much, Dr. Jenny. And thank you all of you for the questions. And you can continue on that chat for those who want to continue more questions. We will now move to the next presentation that is from Dr. David Gordon, who is the president of the World Federation for Medical Education. And his keynote address will be on quality assurance and accreditation in health professions education, past, present, and future. So,
Good afternoon. I'm David Gordon. I'm the president of the World Federation.
So yes, we have it.
I'm very pleased to be with you today. Of course, I'm very sorry I'm not physically there, and indeed, I'm sorry that I'm not speaking live because I was unable to actually attend on the day. But I'm pleased to give Good afternoon. I'm David Gordon. I'm the president of the World Federation for Medical Education, and I'm very pleased to be with you today. Of course, I'm very sorry I'm not physically there, and indeed, I'm sorry that I'm not speaking live because I was unable to actually attend on the day. But I'm pleased to give you this recording and some thoughts about quality assurance and accreditation in relation to health professions, both in the past and in the future. I apologize that I will concentrate on medical education. That is hardly surprising, given that that is our remit, but I'm sure you will understand. And much of what I'm going to say is very much related to the other health professions. The structure of the talk will be a little bit like this. I will talk about why quality assurance and accreditation are important in medical education. What's the history? What's the evidence that they are essential? Do they actually make better doctors and other healthcare workers? Does it improve healthcare? Accreditation is expensive, and I'll talk about why it might be. And I'll talk also about the way in which the World Federation has a program for studying the quality of accreditation and verifying that accrediting agencies are working at the right standard. And I do not hesitate to I couldn't deny that it is expensive. The World Federation, let me give you a few words about it. Our aim is to enhance the quality of medical education and to promote the highest standards worldwide. We were established some 50 years ago, and we are a partnership with its founding members, WHO, the World Medical Association, the 6 regional associations for medical education, and some other members elected to the executive, including the Junior Doctors Network, the International Federation of Medical Students Associations, and the Educational Commission for Foreign Medical Graduates. As I say, we were founded by the World Medical Association and WHO, and with the 3 priorities at the moment: promotion of accreditation through the WFME recognition program, raising the standards for basic medical education, postgraduate medical education, and continuing professional development, and maintaining the World Directory of Medical Schools. Now, this is what the World Federation Executive Council looked like 2 years ago when we met in Seoul. And you can see there that there are representatives, amongst others, from the World Medical Association, top right, the World Health Organization, the Educational Commission for Foreign Medical Graduates, and in the center of the front row, the representative of the International Federation of Medical Students Associations. Now, that's what the Executive Council looked like 2 years ago, and this is what it looks like now. We last met over the internet, and just above my head in this recording, you will see the representative of the Association of Medical Schools in Africa, Professor Olabunmi from Ibadan. The regional associations for medical education are shown here: the Western Pacific, the Americas, the Association for Medical Education in Europe, the Southeast Asia Regional Association, the Association of Medical Schools in Africa, and hiding behind my head, the Association for Medical Education in the Eastern Mediterranean. Now, when I think about accreditation and quality assurance in medical education, the Eastern Mediterranean is a good place to start. This is a picture of a marketplace in Egypt in Roman times, and we have the record of a new doctor who wished to open a space to run a clinic in the market. And we have the record that he was examined by the manager of the market. Where was his medical school? Who were his teachers? What evidence has he got of his competence? We know about this because, like a lot of new doctors, he was writing to his mother to explain what was happening. And we have a good example here of quality assurance of medical education, even more than 2,000 years ago, but there was someone working to verify that the new doctor had actually been to a properly structured medical school. Now, I'm going to take you from 1837 to about 100 years ago, just about the process of improvement in medical education. It was pointed out to me by a colleague from Australia that accreditation or evaluation of the quality of medical education started first in the most lawless countries in the world. And the first that we have a record of is actually in Australia. This is the Act of Parliament setting up a process for quality assurance of medical doctors in one of the worst of the states of Australia, and verifying that they really, really needed to improve. In 1858, another lawless country, the General Medical Council of the United Kingdom, was set up. And I'm going to take you on to the Flexner Report in the United States. But in the UK, there was the General Medical Council, and the wording says that it is expedient that persons requiring medical aid should be able to distinguish qualified from unqualified practitioners. In other words, there were plenty of people working, calling themselves doctors, but they really were not doctors at all. And it's so important to notice that the title says medical education and registration. In other words, the key to ensuring that the quality of doctors was good enough was the matter of medical education. And here is the Member of Parliament who proposed this legislation. In 1910, of course, there is the Flexner Report in the United States, visiting every medical school in the United States and Canada, examining how they were working and verifying that whether or not they really should continue. And he insisted on suitable and high standards for medical education. He talked about the academic content of the course, the quality of the staff, was the course long enough, were the facilities good enough? And he encouraged that best practice from foreign universities, particularly Germany, should be brought into the United States. And this was a remarkable thing. It closed half of all the medical schools in the United States because they were really, really very bad indeed. There is the great Abraham Flexner. But despite those positive outcomes, there are some negative ones. And I'll list them in two categories. First of all, there was his idea that medical education should be in a particular style. It must be scientific. He used the example of the Johns Hopkins University concentrating on the physical sciences and then moving on to the clinical sciences, giving the structure of the traditional medical course as many of us studied many years ago. But there was little possibility of bringing the curriculum into a more integrated form. The other subjects that might be studied outside the hospital, say in primary care, could not be included. And although there was anatomy and biochemistry and so on, the other things that are important, anthropology, economics, and so on, were not actually even given a place in the curriculum. And I personally believe this is very important. This is one of the most remarkable books I've ever reviewed about the way in which to understand the AIDS epidemic as it spread through Haiti and then on into the United States. We had to think about the study of the society as a whole, the anthropology of Haiti, to understand why the AIDS syndrome was so uncontrolled there. It was a failure to behave the way society worked. Another less positive outcome from Flexner, and one I feel quite strongly about, but I was not aware of until a little while ago, was that he had the effect of closing 5 out of the 7 what were called historic Black medical schools. In other words, medical schools that encouraged applications from Black medical students in the United States. And this is a direct quotation from him, where he said that the Negro needs good schools rather than many schools, but it meant that the possibility of improving the poorer quality of schools was lost, and therefore education for Native American students and for African American students was greatly damaged. And it was only 2 medical schools that survive, Howard in Washington and Meharry in Nashville. They still survive. They are absolutely excellent universities and excellent medical schools. Howard, of course, is the alma mater of the current Vice President of the United States, where she studied law. And once these medical schools closed, or even before these were established, students traveled to Europe or trained in some Eastern or Midwestern universities, Pennsylvania, Harvard, Yale. They did not distinguish on color, only on ability. And a remarkable statistic that the first Black physician to earn a formal medical degree was Dr. McCune Smith, who studied at the University of Glasgow. And I'm not sure that the University of Glasgow in Scotland realizes their remarkable achievement in providing medical education for Dr. McCune Smith. And here is Howard University, and those are the students currently, and you can see what a fine mixture they are. And this is one of the medical schools that closed as a result of what Flexner did, and sadly never reopened. These buildings are still there in another university, but not used for medicine. Now, this is a quotation from our own history, talking about the need for reform and quality improvement in medical education. And the reason why this is important was because of, I highlight it, the increase in the number of medical schools around the world, many of them being established under questionable conditions, and in a world of increasing globalization and mobility of doctors and other healthcare professionals, we have to be more aware of the need for accreditation as a quality assurance tool. And 17 years ago, my predecessors sat down with representatives of the World Health Organization in a strategic partnership to improve medical education, and they set up a task force on accreditation, and that task force formulated guidelines for accreditation of basic medical education programs. And indeed, those guidelines are still there. As we say on our website, the function of accreditation is to verify that medical schools are competent in the delivery of medical education, that medical education programs are suitable, is to ensure that medical schools are educating doctors fit to serve the needs of the population where they function. And it's not just ourselves that believes that that's important. WHO in its 2016 global strategy said that we should, by last year, have established accreditation mechanisms for health training institutions in all countries. That's the document. And more recently, the International Association of Medical Regulatory Authorities, IAMRA, has called for accreditation of medical education in all countries. Now, there are questions we need to ask. For example, what are we measuring medical schools against? If you're going to accredit a medical school, you have to say, well, what kind of standard should it meet? And then how do we keep that accreditation process fair, but not rigid or mindless? In some countries, there are standards for medical education that don't talk about how good the students or the doctors or the educators are, but talk about how big the lecture theatres are. I don't personally much mind how big a lecture theatre is, as long as it's good for the purpose. I don't want a tape measure to measure the medical lecture theatre. I want some kind of instrument that will measure how good the teachers are. We also have to be certain that accreditation is cost effective, and above all, is it doing good in the long term? Very difficult to prove, but we will try and do so to see if it does make better doctors and thereby improve health. Now, measuring of the effectiveness of accreditation is very difficult. There is some evidence. I will quote just two papers, one of the many done by Marta van Zanten and Jacques Boulet. This is in the journal Quality in Higher Education, and they look at the possibility of obtaining evidence that that accreditation is really helping. But actually, this is my favorite paper about accreditation in a medical teacher, the long reference there. And this was a joint piece of work between Saudi Arabia and Australia. And they made the important point that accreditation was clearly doing some good in increasing standards, but it was most useful for the medical school examining itself and saying, we're not passing the test, are we going to be accredited, but are we thinking about how we'll make ourselves better? How are we increasing in the long term our quality of education? Also, we can't ignore history. The process of setting up the General Medical Council or of Flexner going through North America and saying these medical schools are not good enough was an accreditation process of a kind. And there's no doubt that they improved, those processes improved accreditation in those countries. And indeed, we shouldn't be too critical of ourselves for lack of evidence for the benefits of accreditation, because there's a lack of evidence for most activities in medical education. So let us think about what is being measured and how. And is the medical education program suitable? Is the medical school competent? Those are things that should be measured. And therefore, we're saying, does it meet the agreed standards? We must decide what standards should be. And those standards may be whatever is appropriate in the country in question. In the UK, they're the standards published by the General Medical Council. In the United States, they're published by the Liaison Committee on Medical Education, but that's being nationalistic in the Western world. In the People's Republic of China, there are the China Standards for Accreditation for Medical Education, and our team has evaluated these, and they are superb. They are absolutely excellent for the purpose of medical schools in China. Of course, many of these standards for medical education are based on the World Federation's own standards. This was the first edition, published in 2003. The third edition is on our website and is rather less prescriptive of the old standards, but was more developmental. It's actually helping you to develop the standards you need wherever you are. So accreditation, what is being measured and how is it being measured? Well, we have to say, how are we going to say you've met those standards? You have to have criteria to meet the standards, and you have to have a process to test that, that measurement. And a direct screen grab from our website, we have guidelines for the accreditation of basic medical education developed by that task force I mentioned, and they form the basis for the policy and for the IAMRA statement about medical education. And we have criteria which are actually set out again on a paper on our website. And it includes a number of things. I just take out one that we talk about, the necessity for an actual on-site observation and evaluation of the medical school. You need to see what's going on. I won't read the whole of this. You need to see what's actually going on in the medical school. And you can find these criteria, recognition criteria for agencies accrediting medical schools on our website. Now, why do we think a site visit is important? Why did I pick out that one criterion? Well, I'll give you an example of many I can give. Here is a medical school. On paper, it looks fine. But actually, if you look closely to that medical school building, you know, we can't all have grand buildings, but inside it's a ruin. And if you look outside that building, you will find students protesting about the poor quality of the education. These are actually overseas students from India. This is a medical school in Kyrgyzstan, in Bishkek. And I also have a letter from the ambassador of India to Kyrgyzstan advising all these students to go to different medical schools. That one is terrible, but then the ambassador arranged excellent medical schools elsewhere in Kyrgyzstan for all those students. But if you had not been to see that medical school, you would not know how bad it was. On paper, it looked all right. Now, the accreditation, therefore, is expensive. You need a team of experts with their administrative support. It takes time, and time costs money, and there needs to be a site visit, and that also costs money. Now, our own program is looking at accrediting agencies and verifying that they're working at the right standard. And the program started because we recognized the dangers of unacceptable money-making accreditation systems. There's one country in the world, if you wish your medical school to be accredited, you go and see the Minister of Health, and he says, of course I'll accredit your medical school. Put $100,000 in my hand and I'll write you the certificate now. So there's that. We need to have a precise tool to measure the quality of medical schools, the accreditation process. And as I said before, to enhance the quality of education, making sure the school is competent, the program is suitable. So our recognition program evolved when in 2010 in Philadelphia, the Educational Commission for Foreign Medical Graduates said that after 2023, it's now 2024, schools must be accredited through a formal process using globally accepted criteria such as ours, or else a graduate would not be able to apply to work in the United States, sponsored by ECFMG. So we had the criteria to measure accreditation, but how did we create the process? The process is, in essence, very like the accreditation of a medical school. We ask the accrediting agency to evaluate itself. We look at its documents. We visit it to see if it will work. And then we examine their final decision-making process. And we are looking to see whether the accrediting agency should be accredited or accepted, or what is the best word, and we chose recognized. So to avoid confusion, we don't talk about accrediting the accreditors as well as accrediting the medical school. We don't talk about standards for education and standards for accreditation. We say medical schools are accredited, measured against standards for medical education. Accrediting agencies are recognized using criteria for recognition. That's a terminology just to keep our own minds clear. The program initially was rather Western in feel, and we've worked very hard over the last 10 years to make it feel genuinely applicable anywhere in the world. We have adjusted the timescale of the process to make it quicker. The papers were rather too long. I hesitate to say this, but some of our colleagues in some countries did write things that were just too long and too complicated. It's now much more concise. The detail of the recruitment of assessors, their training, their evaluation, the travel and site visit policies, and so on and so on. But the process is underway. One particular problem is the cost, because to meet it, we actually need $60,000 plus the expenses. That was systematically worked out in 2014. But we had three principles. It must, as far as possible, cover the true cost. It must have a process for making sure that no country that cannot afford it is excluded. And indeed, we have to also have a process to make sure that the money is in our hands before the final assessment. And do we meet those principles? Well, yes, this barely covers the full cost, but it almost does. We certainly have a process for making developing countries be able to be assessed, even if they can't afford it. And we don't always get the payment before final assessment, but the costs are under systematic review. So the recognition program as it is now, we have, as I mentioned before, a medicine-specific process where the accrediting agency evaluates itself. We visit it and observe it at work, and we have a recognition to make the final decisions. And we're working on criteria based on that old WHO, WFME policy, an expert consensus. We bring that up to date. And here is a World Federation site visiting team in operation, actually in Japan, with a member from Canada, one from the United States, and one from Sri Lanka. And just as my favorite paper on whether accreditation works, my favorite comment about the recognition program is when accrediting agencies say, we feel that you are a partner in our development, you are helping to improve what we do, as well as making sure that we are compliant with the criteria. And that's a very nice compliment to receive. So here's another recognition team at work. This time the members are from Sri Lanka again, from Australia, and from the Czech Republic. And the team from the accrediting agency, if you look at them, you could work out that they're actually in Indonesia, and where they have an excellent accrediting agency that was recognized by the World Federation following this evaluation. And the recognition committee that makes the final decisions, they take the report from the site visiting team and the report on the papers and other features of the accrediting agency. And this group of 6 individuals, one from each region of the world, each of the 6 regions we use, make the final decision. And so as we're speaking in Africa, the representative from the Africa region is Professor Luis Sambo, who many of you will recognize as the former regional director for WHO Africa. Professor Sambo, of course, is from Angola. Now, which accrediting agencies have been successful in the process? And this map I have to bring up to date quite frequently. It's up to date now for this month. And in dark blue are countries where there is at least one accrediting agency recognized and working according to the criteria that we believe they should meet. And in light blue, there are countries where there is an accrediting agency in process of evaluation. And you will see that there are already many countries with very large numbers of medical schools: Brazil, United States, the Russian Federation, China, Japan. There are already countries with many medical schools in operation already recognized. The countries with very large numbers of medical schools not yet in the process, particularly include India and Pakistan, but we believe they'll come through soon. The Philippines produces a large number of doctors, and you can see that they are just started in the process. The map of Africa is not colored blue at the moment, apart from one or two exceptions, but we have had discussions with representatives from both East Africa and West Africa, and we hope for progress. And indeed also the CIDMEF, the Organization for French-speaking Medical Schools, is in process, and that will cover a large number of the medical schools in Africa. Now, what do people ask us about the recognition process? Well, they ask a number of things. Have we turned anyone down? The answer is no, because our job is not to make things worse, but our job is to make things better. And we have examples of 2 accrediting agencies that were going to fail as they went through the process. And we said, stop, go back, think what you're doing, improve your processes, improve your documentation, think it through, and it will be better. And indeed, one of those has now actually succeeded very emphatically in being recognized, and the other one, I'm sure, will be there soon. We are often asked, not by 1 or 2 countries, saying that surely you know that medical education in my country is the best in the world and does not need external assessment. I think there are 2 answers to that. One is, how do you know it's the best in the world? That's very difficult to prove. And secondly, some medical education systems that are believed to be very, very good, nevertheless have things that can be improved. And we also have examples of accrediting systems in countries early in economic development, but nevertheless have a very good accreditation system. Does the accrediting authority in your country have to come in for recognition? If you would like to be recognized by the World Federation, of course. When will ECFMG clarify its policy? That's up to them. Ask that question, but we don't answer for them. We should be asked who gives the World Federation authority for this, and in sociological terms, it is earned authority, not positional authority. In other words, people develop trust in what we are doing. Is it right for us to have a monopoly in doing this? It probably isn't, but that's the way that it has evolved. What are our problems and what are we worried about? Well, we are worried about making sure that we keep it as good as possible. And amongst the questions we ask ourselves, how do we keep it fair? How do we make sure it's not inappropriately rigid or even unthinking? So I'm nearly finished. I would need to think about cost effectiveness as well. But I will point out that accreditation of medical education is difficult. It's a problem of evidence in education. It's not a hard science. There is the statement of ideas, maybe sound convincing, but it is not necessarily verified. It should be examined thoroughly and with caution. And anyone selling a new idea in education, I think, should be looked at with as much care as anyone selling a new drug. And we also have to avoid the dangers of conflict of interest, concealment of process, and outright fraud. And we have to, at the moment, deal with the question of whether we really need the site visit. And indeed, we are holding the policy during this pandemic that a site visit is really necessary. To conclude, I'll give you a thought about the accumulation of knowledge. As we study medical education, as we think about the accreditation of medical schools, I'm always reminded that knowledge is a very special kind of thing, because the more you try and give people what you know, the more you learn from them. And this was reported most recently by Amartya Sen, who won the Nobel Prize for Economics a few years, but it comes from Bengal originally. Thank you very much, and I hope that this has been of some interest. Thank you.
All right. Thank you so much, everyone who has listened and made sure that this is a successful meeting, both online and physically. We thank the presenters for this seventh session and the last session of this meeting. So I would like to invite Professor Sarah so that she can make some few closing remarks. And once again, thank you so much.
So thank you, Faith. Actually, I don't have much to say. The future is secured with you here and you're our tomorrow. So thank you very much. Thank you, the institutions which have been here up to the end, but most of all, thank you, the people who have attended online. I don't know who is still there, but we've been honored by everyone. We've been honored, and we believe that we can keep our community moving online. Okay, that is what COVID brought. And I think we can continue sharing once in a while. And I think that sharing, that is important. I think that's why students hate us when we stand in front of them and talk for hours. Do I do that? If we can, each of us presents, okay, shares, and then out of that, we have a discussion and we move forward. Okay, so there are many ways of doing it so that we don't get tired. So I'd like to request Dr. Ampaji, the Deputy Dean, Busitema University, to just come and close our conference. Dr. Ampaji, please come and officially close. I know we are tired, but thank you very much. Thank you, the people who have organized. Thank you, Hotel Africana, for looking after us. I don't see the sanitizer, but thank you. Oh, those are the people online. Please take a photo. Thank you, blessings, Sambuko. I don't know where you're from. Thank you, Edith. We are grateful. Anna from Pema, Yunus. Thank you. Actually, there are many people. Thank you, thank you. Thank you for being there. Please put your videos on for a minute or so that we see your faces. And I know many people have left. Oh, we are really, really grateful. Thank you very much. Titus Kahiga, our neighbor, we've been honored. They can't hear you. Yeah, thank you. Titus, thank you. We've been honored. Anna, thank you. Everyone, please, thank you. Irene, thank you. We have actually been honored to have you, all of you. Thank you. I don't know if before Dr. Ampaji comes in, we should give an opportunity if anyone wants to say anything online. We don't want to stop without final comments from any of you online. Does anyone want to say something, anything?
Dr. Sarah, this is Anna. I'd like to thank you for the invitation and for allowing the participation of FAMER be presented today. And was really enlightened and always learning more about the work that you're all doing at Macquarie University, as well as what's going on the continent of Africa. So I'd like to thank my colleague Faith Nuaji and Fiona Kenwa for their wonderful support and the support that you have shown us with FAMER and the GEMX program. So thank you, Dr. Sarah. We really appreciate your partnership and your friendship.